check test one testing check test one two ठीक है
हेलो चेक 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 हेलो हेलो चेक चेक आ रही हेलो 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 चेक चेक आ रही है अब यहाँ से तो जा रही है यार यहाँ से तो जा रही है हेलो हेलो चेक वन टू हेलो 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 अरे हाँ यार क्या सारा कुछ हो रहा है
check test
अब इसमें फट हेलो 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 चेक आ रही है हेलो चेक चेक हेलो हेलो चेक वन टू हेलो 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 चेक वन टू हेलो 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 चेक 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 हेलो टेक
Good morning, ladies and gentlemen. Wow, quite a silent audience. Good morning, ladies and gentlemen. Okay, I'm going to try this. It's going to be weird, but I'll try it anyway. Namaste. At least I picked up something. Huh? So may I welcome you to sit in the front seats. Don't feel shy. It's going to be a small group, very interesting discussion. So please, if there is a seat in front of you that doesn't have anyone sitting on it, just come up front. We're not waiting for any special professor or president. So please, feel free to still come up front. You don't get... I still have a seat up here. Just one more brave person. Just one more brave person. Yes, it's you. Yes, you can do it. I see two people who want to go, but they're still hesitating. All right, we'll kickstart our session today. Welcome, ladies and gentlemen. I am Amani Tinkasimile, and I work with Africa Academy for Public Health. And today, I'm happy to welcome you to our session to discuss on partnerships between India and Africa for food security and for capacity building. And today, our chairperson, Dr. Mary Monica Sando, will be leading us throughout this discussion. And I'd like now to welcome her on the podium to give us her welcoming remarks. And thereafter, we will proceed with the presentations. Ladies and gentlemen, Dr. Mary Monica Sando.
Thank you very much, Amani. If I may also try and say namaste. Yeah, so good morning, everyone. Great. Is there a pointer too? Just okay, great, wonderful. Esteemed delegates and colleagues to the 2025 World Health Summit Academic Alliance Regional Meeting, good morning. All protocol observed. It is great honor and privilege for me to welcome you all to this pivotal side event on strategic Africa-India partnerships that is hosted by the Africa Academy for Public Health under the auspices of the World Health Summit Academic Alliance. Even in their absence, our colleagues from India, NIMS University and their collaborators, Ashoka and others, who have put this together, we say thank you, and it's such a privilege for them to offer us the opportunity to host this session. On behalf of the Africa Academy for Public Health, in short AAPH, I deeply appreciate your presence this morning and your commitment to shared vision that brings us together today, transforming food systems and building resilient capacities to ensure a healthier Africa, India, and the world. AAPH is a charitable non-governmental organization in Tanzania, East Africa. We were established back in 2009. Our mission is to advance public health priorities through research, training, capacity building, and knowledge translation. Ultimately, as an organization, we aspire to become a premier provider of innovative public health research and health systems training activities that will benefit our community in Tanzania, within Sub-Saharan Africa and the world at large as much as possible. Together with the Harvard T.H. Chan School of Public Health, about 11 years ago now, AAPH co-founded what we call the Africa Research Implementation Science and Education Network. This network stands as a beacon of collaboration uniting African institutions, a dynamic platform of groundbreaking research, transformative education, and sustainable partnerships across our region. The ARISE network is committed to fostering sustainable collaboration among African and global institutions, such why we're here today. And ultimately to be able to advance training and research for and within Africa and our global partners. Ladies and gentlemen, this gathering today to us is more than a meeting. It is a call to action. Today we convene at a critical juncture where our shared development journey, our nations, home to over a third of the world's population, bear the disproportionate burden of undernutrition, food insecurity, and poverty. Together, Africa and India account for nearly 70% of the world's undernourished and over 2/3 of its stunted and wasted children. These are not just statistics. They are faces and futures of our next generation. We owe it to them to act decisively and collectively and collaboratively to finding better strides as soon as we can. While Africa faces harsh realities in climate-related shocks, persistent drought, economic vulnerability, and public health emergencies, India's experiences offers both inspirational and practical models of progress. Through your transformative initiatives like the National Food Security Act and Integrated Child Development Services, India has shown how targeted programs can move the needle in stunting food insecurity and nutritional outcomes. This side meeting offers a unique platform, diverse in terms of expertise of the panelists that will be speaking today. We are here not only to learn from each other, but to build together, to move from dialogue to co-creation, a very common word now in the space of research and programming, but also to form parallel efforts for joint actions. Not parallel efforts, but rather joint actions. So let us be bold in reimagining South-to-South collaboration. We're talking of India and Africa here, or Africa and India, and thinking about how this collaboration can be a force multiplier to achieving the Sustainable Development Goals. Particularly, and of very importance to this session, is SDG 1 and SDG 2, eradicating poverty and hunger of all forms. Let us also recognize the potential of partnerships to address interlinked challenges of agriculture, health systems, nutrition, and climate resilience. The common agenda we explore today emphasizes on innovation, equity, and inclusion. It is from strengthening primary health care, enhancing disease surveillance, and increasing agricultural productivity through sustainable, climate-smart approaches. Our ambitions are comprehensive, and rightly so, because these challenges we face are complex and deeply interconnected. Ladies and gentlemen, joining us today on this matter are esteemed colleagues from Africa and India addressing this important common agenda. With this dialogue, we aim to get into our, I moved back, sorry. With this dialogue, I'm coming now to the objectives of this session. We aim to review the pressing challenges and opportunities in food systems and transformation in Africa and India, exchange knowledge and identify mechanisms that can be employed to facilitate knowledge sharing, transfer of capacity, with the understanding that there's so much development, so much innovation in this part of the world. Our hope is to begin and continue with learnings and lessons that already are existing, but that will also be diverse to our African context. We have a lot of similarities, we're sure, so we hope through this discussion, and I applaud and encourage you to please share your thoughts, your experiences as well when you come to discussion. We also aim to discuss and look at ways of promoting innovation and investment across nutrition, healthcare delivery, and health emergency preparedness. And most importantly, we would like to identify existing pathways, how they can be improved, but also find new pathways where we can be able to build for longer term, mutually beneficial partnerships that are rooted on solidarity, shared responsibility, and trust. In the spirit of Ubuntu, that our humanity is bounded together, I invite all of us here today to imagine what is possible when India and Africa, or Africa and India, which one do you prefer? We're in India and Africa. Either way, the host is given that privilege, where when India and Africa join forces, and not just as partners, but as co-leaders in shaping a more nourished, a more equitable, and a resilient future. So let us begin by listening to our panelists, and I would like to thank you all, and I wish you a productive and visionary discussion ahead. To start with, I would like to introduce my colleague, Dr. Ntuli. I will introduce all the panelists, 4 panelists today. Dr. Ntuli Kapologwe, first on my left, is the Director General for the East Central and Southern African Health Community. His bio is portrayed up there, and I'm sure more engagement can happen at the end of the session. Following him, after Professor Monica, is Dr. David Sando. He's the Chief Executive Officer for Management and Development for Health, large NGO in Tanzania. After Dr. David is Professor Tinku, also a long-term collaborator, and we have seen how Africa and India, so our large clinical trial, can really make strides into creating scientific evidence that hopefully will be able to change clinical guidelines for better outcomes of health for women and children. Professor Tinku is the head of Department of Biostatistics at St. John's Medical College. Back to Professor Monica, Monica Arora. She is the Vice President for Research and Health Promotion. I'm sure it's a very household name here in India, from the Public Health Foundation of India. So without further ado, ladies and gentlemen, I would like to invite on the stage Dr. Ntuli Kapologwe to take us through his remarks, and if okay, you'll be inviting the next and the next. And of course, if I may introduce the last person at the corner there, who's done quite a lot of work in putting this session together. May we clap hands for him? Is Amani Tinkasimile, my very able colleague. He's the Senior Manager for Strategic Partnerships and Programs at APH. So this topic is his responsibility at APH. Welcome, Tuli. Thank you very much.
Thank you very much, Dr. Mary, for your kind introduction. As I have been introduced, my name is Ntuli Kapologwe. I'm the Director of East, Central, and Southern Africa Health Community. My talk will be on Africa's unique needs, practices, an opportunity to accelerate eradication of extreme poverty, hunger, and all forms of malnutrition. So the current situation in Africa, as we march towards 2030, hunger and malnutrition continue to pose critical challenges across sub-Saharan Africa, including the EXA region. 1 in 3 children facing severe food poverty globally lives in sub-Saharan Africa, which translates to 59 million children. This remains to be a major barrier to realizing regional full health and economic potential through human capital development. And Africa is the only continent that has recently reported increased levels of food insecurity, poverty, and all forms of malnutrition as compared to some other continents. And the number of children that are stunted has been increasing in the continent, and of recent data, it has increased from 54 million to 63 million, with a regional stunting rate of 30, but it varies across the countries. Some countries have reported up to 40, and we are far above the global average of 22.3%. This has long-term effect in terms of education performance, but future earnings and human capital development. But as Mary has said, we have some similarities between Africa and India. Together we constitute 36% of the global population. And these two continents have got the youngest population. But both India and Africa have 69.4% of the world undernourished people. And India and Africa accounts for 67 of the world's children under 5 with stunting. And these two continents again account for 76% of the world's children under 5 with wasting. So a significant population from these two continents lives below poverty line, relying heavily on the agriculture for their livelihoods. But again, the issue of climate change poses a great challenge to these two continents, but more significant in the African continent. Meanwhile, the urban population depends on the market that are increasingly impacted by economic inflation, rising food prices, and the widespread availability of cheap and healthy ultra-processed food. And to a great extent, that pushes some of the population to more extreme poverty. So the East Central Southern Africa Health Community, it was established about 51 years ago under the auspice of the Commonwealth Secretariat. It's a regional intergovernmental organization that fosters and promotes the regional cooperation in health and well-being among member states. So it has 9 member states, but its activity spans to 17 other non-member states. So in total, we exist in 26 countries, as you can see from the map. That blue is for the 9 member states, including small islands. And that orange color, I think I get it right because many are not very good at colors. Yeah, so those are the non-member states. So this is the map to depict where the X exists. So looking into the opportunity to accelerate transformation, so EXA has high convening power. The supreme body for decision making are the Health Ministers Conference, which really provides the direction of all the activities, but also it approves our strategies and budgets. But also we have clusters for knowledge management, and I'm very happy to be sharing the panel with colleagues from the academia. So we also deal with the knowledge translation. And also we have 11 colleges of health sciences. And these we call College Without Walls. This is one of the flagship initiatives under the EXA. However, we do not have a College of Nutrition. So we are about to start the process of establishing one. And I'm happy, I think I'll have to get some collaboration and partnership with the Foundation of Public Health from India, and as well as St. John's College of Medicines. We continue investing in the area of early childhood development, and we would have to leverage what is happening here in India. We continue to accelerate regional food fortification agenda and universal iodation, without forgetting the surveillance for nutrition interventions. So in the past 2.5 years, EXA have been able to come up with adolescent nutrition advocacy, That is one of the strategies, trying to accelerate some of the nutrition interventions, as this is a region which is badly affected by the all forms of malnutrition. Now, a pathway to strengthening partnership, this was mentioned by Dr. Mary. India's National Food Security Act and Integrated Childhood Development Services is key. So we won't be reinventing the wheel. I think we need now to see how best do we partner, because India have shown some very good progress in that area, as well as we have seen some very best results coming out of these interventions and also acts that have been implemented in the country. So we hope to learn from India's agricultural productivity through sustainable practices, as well as having the programs for nutrition and supply chain for nutrition commodities that is well implemented in India. So we believe through partnership and collaboration, we shall be able to address some of the challenges that has been affecting the EXA region and sub-Saharan Africa as a whole. Looking into the EXA's unique value proposition, we are into multi-country coordination and collaboration. We have diverse number of stakeholders whom we engage in implementation of different interventions, but we want to have diversified stakeholders, but not only in the continent Africa, rather even beyond continent Africa, like working with India. But the convening power this is one of our unique strengths, and that allows us to penetrate whatever agenda we want to the member state and beyond the member state. Regional mechanism, peer-to-peer learning, where we have some of the countries that are labeled as mentors, others as mentees. So we believe in that framework because it has done very well in trying to address a number of the challenges in the region. And also we have the technical expertise to help us to implement a number of interventions. So I'll stop there, and I'll be very happy during Q&A to get your input, your comments, and questions if at all there will be any. Thank you.
Thank you very much, Dr. Ntuli, and I would like to invite Professor Monica Arora to the podium.
Good morning, colleagues, and thank you so much to AAPH for putting this together. It is always a pleasure to talk about South-South partnerships, and given the current funding situation in the world that we are seeing in this tumultuous time, it is all the more important that we start becoming self-sufficient and less dependent on the other part of the world, where we have always been wanting to see that best practices come from. We have innovations, we have best practices in South-South partnerships, and we should be working more towards that direction. So thank you for putting this together, and I think within India and Africa, we have a lot of experiences and similarities which will help us find common solutions. So just to put in context what we are talking about today, yes, India has made rapid progress in terms of ending poverty, hunger, but the objective has not completely been met. On top of it, though we were talking under Millennium Development Goals about reducing undernutrition, alongside we came across overnutrition. And currently, the coexistence of undernutrition and overnutrition complicates the situation, because for government programming, the two ends of spectrum have to be balanced. what should be the common messaging from the government? Eat less, eat more? It is very difficult. What should be the focus of government programs? They cannot be that in rural areas you eat more, because we are now seeing obesity there as well. So rural areas are also grappling with the issue. So the syndemic approach that was put together by one of the Lancet publications about what are the common solutions for countries where undernutrition, overnutrition coexist, but also the burden is exacerbated by the climate change. And what climate change is doing is, with this global syndemic, which is not just affecting human health, but planetary health as well. And India particularly is at the crossroad, because with this interaction between what's happening with our climate, the common drivers which are influencing this syndemic is food and agriculture, because the crops are getting impacted, urban design, which is making it very, very difficult for people to access healthy nutrition and be physically active. Transportation and land use are adding to the complication. Also, with the dietary transition that India is seeing, there is increased consumption of ultra-processed food. There is declining intake of nutrient-rich traditional foods, because more and more people are migrating from rural areas to urban areas. And climate stressors of erratic monsoons, heat waves are definitely affecting our agricultural productivity, and more importantly, the dietary diversity, which is what is contributing to the current burden of both undernutrition and overnutrition. Also, as I said, these health inequities are more prominent in rural populations, women and children. So, rise in rural obesity in India is again closely associated with all the drivers that I discussed about. The good news is, yes, data is very clearly showing reduction. If we see our latest National Family Health Survey, anemia continues to be very, very high still. So that is our very prominent focus. But in terms of underweight, overweight, wasted, stunted, these numbers among children under 5, among adolescent boys and girls, and among women are definitely much lower than what we had in the last 2 decades. So you see a trend here where we can very clearly see that on all the indicators there is decline in undernutrition. And as I said, the only area we need to currently work more vigorously on is anemia, both in children and in women with reproductive age. In terms of the key challenges that we are seeing in maternal, newborn, child and adolescent nutrition, with babies still low birth weight, about 18%, India significantly has these trends higher in rural areas than in urban areas. In terms of early initiation of breastfeeding, exclusive breastfeeding, again we are seeing that according to the guidelines and recommendations, we are not being able to achieve the targets that should be exclusive breastfeeding continues, and we see a sharp decline after 3 months. So we need to look at some of the related programs also, not just programs which are under Ministry of Health. It's a multi-sectoral issue which needs to be tackled with various other ministries having a role, with women and child development coming in, with Ministry of Sports and Youth, Health. But other than that, agriculture becomes a very important stakeholder. So I'll not get into very data-oriented discussion because we'll have time for that, but just want to highlight that India's 50% area which is under agriculture is rain-fed from the sown area. So with this, again, it becomes very, very vulnerable to the climate shocks. We are also saying that climate change has reduced the wheat yield from current times to 2050, the projections are we will have a reduction about 19% and 40% up to 2080. So definitely we need to start working towards crops which are not dependent on monsoons. Also the heat wave that we are seeing, so every 1% rise in temperature could reduce the crucial crops for India, which are like wheat, soybean, mustard, groundnut, potato. And again, these numbers are very, very worrying when we want to talk about food security for the population. Also, climate change overall is projected to cause about 250,000 annual deaths globally, and putting these together, undernutrition, malaria, diarrhea, heat stress are all tropical weather environment related issues that are interconnected. So agriculture and nutrition policy nexus we are all aware of. We need to start working in greater capacities on diet diversity, horticulture, nutrition sensitive agriculture. And importantly, 2023, the government of India dedicated that year as International Year of Millets. So a great emphasis on millets did help in India's agriculture narrative and policy discourses. And just to highlight that, apart from ICDS, India has worked on a number of other policies and programs like the public distribution system, midday meals, which are again supplementing the food for children, women, and the vulnerable age group. We also need to look from the climate perspective on the subsidy structure, because currently the subsidy is given for water and fertilizer intensive crops over climate resilient, nutrient dense foods. So some adjustments need to be done in Indian setting as well to achieve the last mile that we are still left behind. And I will let the Food Security Act be talked about by Professor Tinku. So various programs and policies, just to quickly show that each program has beneficiary as children, pregnant and lactating women. The focus is on nutrition, health and cognitive development. Midday meals are served in school settings, ensuring children get hot meal, and also this has improved not only their school attendance but also has helped in eradicating the extreme hunger and undernutrition. Best practices, if we talk about, we have integrated programs. As I said, multi-sectorality is very, very important with Poshan Abhiyan, not only doing a month-long campaign, but also tackling stunting, anemia, low birth weight through this multi-sectoral action. Apart from that, many other programs which are also looking at micronutrient support, so providing weekly iron folic acid supplementation to reduce anemia, and folic acid supplementation are also given in not just the community setting but school settings as well. Then quick, what research is going on, because I talked about both undernutrition and overnutrition. So PHFI started looking at what is the food environment of children. So around the schools, the food which is being served inside or outside the school is food high in ultra processed food, so which are high in fat, salt and sugar. This is an urban area research, but looking at again what is the advertising scenario that children are seeing. So our research, which analyzed the content of advertisements that children are exposed to in both children channels and youth channels, showed that the exposure for unhealthy food, which are high in fat, salt and sugar, is much higher in children channels as compared to youth channels. So the industry is very clearly targeting them. So this is adding to the burden of unhealthy food and overnutrition. So we started a campaign which is again a very multi-partner, multi-sectoral on Let's Fix Our Food, which aimed at not just bringing all the government sectors together on reducing unhealthy food consumption, increasing physical activity, decrease in screen time, and co-creation. Adolescents themselves were involved in this campaign. So scientists did the policy briefs, scientific publications, bringing the burden and solutions, but youth themselves started changing their food policies in the school setting, in the home settings, and in the community settings. So they are the youth leaders who are taking the campaign forward to bring about a social behavior change. So there is a call for syndemic informed strategy, and we can discuss it more, but we need integrated solution to understand and address both undernutrition and overnutrition, and integrate nutrition goals in both agricultural and food policies, strengthening dietary diversity, and even through the public distribution systems need to start focusing on nutrition dense food to be distributed rather than calorie dense, which has been traditionally India's focus through the PDS. Pathways for taking the India-Africa partnership forward. There are a number of capacity building opportunities, given PHFI is an academic and research institute and AAPH has similar structure. So a lot of student exchange and scientists exchange as well as policymaker visits can be done. Strengthening institutional capacity for further research and development in food and agriculture, and particularly what syndemic solutions mean for India and Africa. Knowledge transfer about various agricultural initiatives that are being undertaken in India can be discussed. On the policy and governance, advocating for inclusion of food security and nutrition in regional and global agendas, and particularly all the diplomatic platforms of South-South partnerships. And last but not the least, research and innovation, given India has huge potential for digital interventions, that can be another area we can explore together. I'll stop here. Thank you very much.
Thank you very much, Professor Tinku. I know you struggled on how many slides can I put with such a breadth of experience from your work. So we thank you for trying to narrow it down and covering a wide spectrum from your work and research. So next I would like to call Dr. David Sando to take the podium and take us through his remarks.
Good morning. Good morning. Yeah, so I want first to thank the presenters who have actually done this before me. A lot of the content on what I'm going to talk about has been partly covered. My role really is not to take you through numbers and statistics, but rather to present existing platforms in Africa that could, pose a case for potential Africa-India partnership in these areas. And as we know, already India has made great effort actually in initiating efforts for Africa-India partnership. I know from bilateral perspective, there are a number of platforms that are ongoing now where India and Africa have actually forged partnerships. We understand a lot of work that is currently being done on different portfolio to really embrace this South-South collaboration and partnership. And my talk is going really to introduce ARISE. ARISE is a network that is based in Africa and really provide a potential for synergy, but also as a low-hanging fruits for South-South collaboration as we speak. So ARISE stands for Africa Research Implementation Science Education Network. It was co-founded by Africa Academy of Public Health, AAPH, and the Harvard Chan School of Public Health from Boston in 2014. And to date, since 2014, it has a network of 22 institutions, research and academic institutions, across 10 African nations. And in addition to this, this network also include Harvard T. A. Chan School of Public Health from US, and also Edelberg Institute of Global Health from Germany. And just to actually mention the countries where ARISE network exists so far, we have Ethiopia, we have collaborative institutions in Uganda, in Tanzania, in South Africa, Nigeria, Ghana, Senegal, and Burkina Faso. And the focus really of ARISE is to contribute efforts towards building the capacity of health professionals and the teaching institutions actually in these countries to make sure that we have a strong and robust training practices and efforts, but also leadership, and make sure that a lot of great work that is being done, especially in evidence generation, is translated into impact in terms of having evidence-based policies. As it has been discussed, there are a number of challenges when it comes to food systems in African continent, and we share that challenge, I think a lot of those challenges with India as well. At the moment now, when you talk of food systems, you're talking of the entire chain, from the production, storage, distribution, processing, and a lot of that have been affected with climate change, with population, with urban planning, the transportation, and so many other factors, as also Monica have pointed out. When you look now in Africa, in many African countries, actually, we are suffering from the impact of climate change. The quality of the food, so the nutrient content of the cereals, the common cereals, legumes, and other food crops that are produced there is no longer the same as before. And we understand that the productivity and output of the agriculture sector is affected severely, but also livestock as well. And this is because of many extreme weather events, whether you talk of the heat, the drought, you talk of the extreme rainfall and floods. We've had also cases, and a number of cases of landslides and mudslides, even in Tanzania, where I come from, and many other African countries. But I also know that India is not excluded from some of these extreme weather events, and they have been actually impacting a lot of food production and the food system in general. And to this extent, nutrition has been a big problem. We've been fighting nutritional problem, as data have been shown by Dr. Ntuli. Nutrition is still a big problem: stunting, wasting, and food security in general. So this is now compounded with the climate change, and there is very little funding when you talk of climate change studies that are looking at the impact, the mitigation, and adaptation as well. And so this poses a case for collaboration to leverage on existing infrastructure. The resources that are there, they're scarce, but if they are used effectively and jointly, we can learn from each other. One thing that I've learned, from yesterday is that there are so many good practices that are being done here in India or somewhere else, but these are pockets. They're pockets of good practices that if we can collaborate and really document this well, we can learn from each other's and also avoid duplication, and also make sure that we better, we use our resources more effectively. So I think there are definitely a lot of work that needs to be done here. And when you look at our RISE network, since its actual formation, a lot has been done in terms of research. As I said, the focus is actually in generating evidence to make sure that we have data that is necessary to inform policy and practice. And a lot of work that ARISE have done have been focusing on adolescents' health and well-being. As we've seen from the data, India and also Africa have the majority of the youngest population in the world. And investing into this young population is the only way, is the developmental approach that we can't avoid to take if we want to move from the extreme poverty that we're actually seeing in our countries. And these studies have focused on nutrition and physical activities. It has been mentioned actually because of the urbanization, because of migration, we have seen reduction in physical activities even among youth that have actually also contributed to overnutrition and obesity and overweight that we are seeing. But also wash activities. It's a pity that at this juncture we are still talking of a lot of conditions that are associated with wash. Water, sanitation, and hygiene in most of our schools and environments. Actually, we've not actually been able to provide a decent wash environment. Mental health. This is also another epidemic that is facing Africa and is also, here in India as well. From the presentation we've had, we were talking of double epidemics. We are talking of infectious disease, non-communicable diseases, also the second epidemic, which is now overtaking infectious disease. But when you look at the calamities of climate change, health security threats, and mental health, you can clearly agree with me that we also have another epidemic here. And less has been done actually in this. So with these triple epidemics, the Global South is really put at no choice than looking at ways to collaborate and jointly use whatever resources we have effectively. Digital media and digital access is also a big issue now. We've seen a lot of good practice and innovation in India, where a lot of effective and innovation around the use of digital platforms to really improve access and reach the community that has been marginalized, and to a certain extent improve their well-being and access to health services. So it would be good to see what is there that we can actually learn from India and also expand to Africa as well. But we've not only focused on adolescents, the ARISE has also been focusing on maternal, newborn, and child health, understanding the importance of this group in our population. And with a number of clinical trials have been done on multivitamins, on calcium, and I know Professor Tink will talk about some of the, I would say, the proof of concepts work where Indian institutions and African institutions where we jointly work together to implement some of these calcium studies, and is really now, I think, taken as the best practice to build on that and really forge this important collaboration. But we are also working on emergency preparedness. As I've mentioned, outbreak and pandemic threats are now growing concerns. We've seen what COVID have done to us. We've learned on the effect of our dependence on Western and funding. What happened when the COVID happened, and most cases we are actually left by ourselves. So really looking on how we can become self-sufficient by learning on the best practices from ourselves, building our health system to make sure that we have a resilient health system that would be able to sustain and respond appropriate to future pandemics and epidemics. India has been called the pharmacy of the global, now global. So there are definitely a number of opportunities where we can actually, improve and make sure that we get to a point where we can self-sustain ourselves in terms of even fighting future epidemics and also pandemics. In terms of opportunities now, when you look at the research, as I've said, there are a number of best practices, and we propose to think through joint, as we always say, Monica, usually it's good to go with quick results. And I think conducting things like systematic reviews on some of these existing best practices around food systems and climate change, and really learning from what has worked, what has not worked where. And I think that could be a starting point to at least pinpoint some of the solutions that could be adopted and scaled in other part of Africa using ARISE and India partnership. Also collaborative intervention studies, and these could include nutrition initiatives, school health programs. We've mentioned a number of health programs that you're doing here. A couple of them are also being implemented in some of the member institutions within the ARISE, and it would be good to see how we can leverage on that and combine our shared experience and lessons to build strong and evidence policies that could help to chart our way forwards. Also, cross-continental data sharing framework for accelerated knowledge generation is a current opportunity that is there between Africa, India, and within the ARISE network experience. Capacity building is also one of the areas that ARISE network has actually been focusing, and it's good to hear a lot of good work that PHFI have been doing. And within the ARISE network, a lot of focus has been on professional development to make sure that we have strong teaching institutions that have the capacity to produce really public health practitioners who are well equipped to deal with a lot of issues that we're now facing. You would agree with me, the current and the future challenges of public health in South are multi-sectoral and requires interdisciplinary. So our previous approach of very confiscated and unified, rather disciplinary teaching may not work. I'll take an example of where I come from, Tanzania. We've faced a number of outbreaks and pandemics, and during recent Marburg outbreak, you would probably need a number of sectors to act together to respond to even a small outbreak of Marburg. And if you take a medical doctor who has only been trained on managing a case to come there, and there's no way they can work on what needs to be done on transportation sector, on supply chain. So it's really important that now we prepare leaders who also have this multi-sectoral approach when it comes to the current and future problems. So ARISE is really geared towards making sure that our curriculum and teaching approaches are now changing to adapt to the need that is there. And we do this. We have internships. We have South-to-South exchange programs. We also have mentorship programs that are geared towards transitioning and impacting knowledge from some of the senior scientists to junior, and making sure that we have this generational capacity towards making sure that we have a sustainable leadership and around research and policy. So within the capacity building, as I've said, and you mentioned it, bilateral professional development courses, leveraging complementary expertise that is there is really one way to actually think of some of these opportunities, but also exchange programs, as you've said. India, we share a lot of similar public health problems, and that means there are opportunities for students from these member institutions to come here, but also Indian students to also go and learn from countries that ARISE is based on. Joint mentorship network, connecting students, shared curriculum development. I know in India you've done a lot of capacity building in terms of telemedicine. I think in terms of providing consultations for some of these critical medical conditions in some of the African countries. We can learn from that, and in a systematic way look on how ARISE and India institutions can work together to really see what is scalable out of that to improve. And within the telemedicine, there are also opportunities for capacity building for our healthcare providers. And I think that's one of the ways that we can actually think of this. And also in manufacturing, we have examples of India supporting African countries to build pharmaceutical industry and transfer some of that knowledge there. And ARISE poses a platform where we can actually learn on how we can transfer technology and some of that to make sure that South-South collaboration really becomes a platform for the next developmental milestone in Africa and India as well. And last but not least, in terms of our approaches, is the sustainable partnership. So as ARISE, we carry out a number of symposia and this started in 2016. So we have annual symposium where the network members actually come together to really share knowledge and experiences about the work that has been done. But we've also started to conduct conferences on adolescent health in sub-Saharan Africa, and also regional policy advocacy. We've created the African think tank for adolescents and youth health, where influential leaders actually from countries where these member institutions are really are used to help transforming evidence into policy and practice. So in conclusion, the ARISE network infrastructure, it provides, as I've said, a proven foundation to build this equitable, impactful India-Africa partnership in health sector. And by leveraging actually a respectful strength in research methodology, clinical practice, and food system expertise, our collaboration can accelerate progress towards shared goals. And together, our complementary capabilities offer unprecedented opportunities to address some of these complex regional challenges through innovation, capacity building, and knowledge exchange. Shukraya. Thank you so much for listening.
Great. So thank you very much, Dr. David, for taking us through what we currently have and we can build upon the ARISE network. I would now like to call our final panelists, and please applaud her as she comes to the podium. Professor Tinku Thomas, please take us through your work. That's it, right? Yeah. You didn't continue applauding her. Maybe you can go. They will applaud you.
Thank you. Thank you, Dr. Mary. I am indeed honored to be here. And I thank the organizers for giving me this opportunity to be here at this regional meeting. I am a biostatistician, and I am very much convinced about collaborative work, because all what we have done in terms of research and whatever I personally have done in research is all through collaborative work. So I think I don't need any convincing there, but then so what I'll talk today is about research synergy and opportunities using data science. So my previous speakers, Dr. Tully and Professor Monica, refer to the programs in India, that is the National Food Security Act and the ICDS program. And in this session, in this talk, I would like to just focus on the ICDS program and what we have done with that, and how that can be an opportunity for collaborative work. So just a background about the NFSA. This was earlier a welfare program, but NFSA really, that is the National Food Security Act of 2013, transferred it to a rights-based approach. And through this act, 1/3 of the population is entitled to subsidized food grains. So what happens is the central government allocates the food grains to the states, and the state has a further responsibility to deliver the program by adding foods to it, so that it is specific or is customized to the state's requirements. And there are special entitlements to children up to 14 years, pregnant and lactating women, so really focusing on the vulnerable ages. And this program has so far been acclaimed to have removed hunger in the country. But it is time that we think further than just removing hunger, and that is exactly what has happened. So with Poshan 2, the country has moved forward from just eliminating hunger to really thinking about nutrition itself. And there has been a shift in policy in terms of what the NFSA should deliver, and particularly the ICDS program should deliver, which is concentrating on children less than 5 years, pregnant and lactating women. So the program so far has been focusing on cereal and pulse distribution because that's what the center provides. And the target has been to meet energy and protein requirements because that was really focused on eliminating poverty. But with Poshan 2, there has been a shift to diverse food and how this diverse food can be provided by the state governments. But unfortunately, the budget has remained the same to provide this diverse food. So that becomes a challenge. So I'll just go to the specifics. So the ICDS program for 6 months to 72 months children currently is focusing on 500 kilocalories of energy and 12 to 15 grams of protein per day. This is what the program is supposed to provide. But data from the NNMB, the National Nutrition Monitoring Board surveys have shown that actually the energy gap is not so much. Over the years, and the protein is more or less met. But the problem is quality protein. Where does the protein come from? From cereals, we actually meet a lot of our protein requirements, but is it really quality protein? And there has been no attention to the other nutrients such as fat or micronutrients. So the revision now, which has come out in 2023, says that the ICDS program should not only provide energy, protein, but also fat and a set of micronutrients at a certain amount. Now this is a big shift, and it is also favorable because it has actually considered the data and brought down the energy requirement, not the requirement, what the program is supposed to meet, from the earlier 500 kilocalories to 400 kilocalories, because data showed that actually the gap is not too much. By just giving a lot of cereals and and just focusing on cereals and pulses, we are actually bringing in other problems in the country, like how Professor Monica was talking about as NCDs. So there is a big role of cereal-based diets on NCDs. So what we have done is to develop a optimization algorithm to identify how all these nutrients, that is protein, energy, and fats, and the micronutrients can be provided in a very limited budget, and that needs some serious programming, and that is what we have done. And this is to optimize the take-home ration and the hot cooked meal that is provided through the ICDS program. And what we develop with the funding from WHO is to develop a tool, because what data again has shown is that the burden of undernutrition or malnutrition in general is not universal in India. It is very much varied, and it is varied even at a sub-district level. So that is one problem, and the solutions are also varied. It is not one program cannot fix the problem of the nation. So if you have to offer solutions at a district or a sub-district level, then somebody has to have the capacity to provide those solutions at that level. And that is why the thought of developing a tool which can do the optimizations, because doing a linear programming and optimization is not a skill that everybody has or the program people have. So that was the real effort here, is to develop an optimization tool for the ICDS program. So we have developed this, and it is hosted in our data tools website. So what we really did was to create a database of foods and prices, because optimization is for minimizing the price. And this was through field surveys in all states in India. And we developed standardized recipes, and we considered what foods were fortified as part of ICDS. So this is really to understand what are local foods and what can be provided through the ICDS program. And using this data, the optimization algorithm has been built, which is actually not a very complex algorithm. It's a simple linear programming algorithm. And the tool and the backend all the optimization has fitted into this optimization tool. I won't go into the steps of it, but this just shows that you get a solution of what foods can be included, which is specific to a state, and we can even go through to a district level, and it tells you at what budget that particular provision can be met and what are the nutrients that are met through that optimized allocation. And this is for the hot cooked meal. The hot cooked meal is even more challenging because here we are talking about recipes, which is a matrix of different foods. It is much easier to optimize raw foods. So here again, so there are multiple recipes which are very much region specific, and then the tool is an interactive tool which facilitates the the users to finally identify a list of foods for 6 days that can be provided as the hot cooked meal for children who are attending the ICDS program from 3 to 6 years. And you get what the features of the optimized meal in terms of nutrients and how much it costs. So this is really the work, and this has been published. What can be done is to expand this kind of optimization algorithms to other programs that are in the country or anywhere in the world. There are so many optimization algorithms across the world, and there's a lot of push towards using data to identifying what can be provided in the programs. So the Indian experience has shown that it is possible to provide nutritious foods at very limited budgets, and this can be very local specific. And this is something that can be utilized in any country in the African continent for sure. And what the learning has to come in is in terms of implementation. Developing a tool is something, but actually getting it to work at the state level and states to actually use something like an algorithm to identify what is to be produced. So there is a lot of learning that has to come from the African collaboration, where how we can implement nutritious foods in food programs. So local contextual solutions is where the research really should lie. And the others, I have just listed some of the other collaborations. In terms of training, we have had an experience of receiving grant challenges, funding to have a short course on data science applications for improving public health in low and middle income countries. This was with a professor from Ghana, and we ran a short course, which was an online course, which was very successful and covered all the South continents, and so we had a very diverse participation. And we, as Dr. Mary has earlier mentioned, we have had this experience of doing multi-country centric studies with African nations, and I think there is a huge opportunity to combat malnutrition together. Thank you very much.
Great. So a final hand of applause to all our panelists. And I would like to say thank you for taking time to prepare your remarks this morning, and the continued commitment that we all are doing in advancing public health and improving health and livelihoods of our people. So now we would like to, how are we doing with time, invite people for questions, comments, clarification. You've been such a very attentive group. So we look forward to please opening it up to discussions, questions. Yes, Martina and Professor Ibingura. We'll appreciate if you just mention your name and where you are, and if you have a specific person you'd like to ask, also shoot.
Thank you. Of course, my name is Martina Möllers. I'm from Germany native, and I'm working more or less in epidemiological and women health related issues. My background comes from tropical medicine, but I have been as well trained in different settings and institutions in Germany and in UK, either London School for Health and Tropical Medicine and Edinburgh and in Tübingen. And I'm just concerned about malnutrition, of course. And I just have been looking to one of my institutions in Germany with whom I have been working for. It is Göttingen and Kassel, and it's honestly the oldest university where we are working as well with organic agriculture. And we have vast experiences overseas as well in tropical areas, and we have as well working in Nepal as well with India and in African settings since a long, long time, since roughly 100 years, roughly, these institutions. And I'm wondering how you are coping with climate change during this time. We have to raise up this question for sure. Organic agriculture is one of the major points as well to make it sustainable. You are talking here in India about the monsoon. We are talking from the African sub-Saharan setting about the rain season and climate change, dry area. I have been living in different settings in sub-Saharan area, Africa. So far I saw a lot of dry and drought areas in Ethiopia and Somali areas, and even nowadays in other areas, even Tanzania, Rwanda, we are talking about dry season so far. Yes. And agriculture, what is the case? How you are pointing it out from organic agriculture, how you make it sustainable here in India. This would be as well my case when you are transferring it to Sub-Saharan Africa.
Okay. Do you have anyone in particular you'd like to respond?
I would say, yes, I would go to Monica. Yes.
Okay. Maybe we take a couple of them and
Yes,
then,
of
yeah.
course.
Professor Ibingira.
Yeah, thank you very much. My name is Professor Charles Ibingira. I'm a surgeon, but also for the interest of the participants, I'm a previous international president because we hosted the World Health Summit in Uganda 2020. My question is, I think, to the two professors from India, and one, I would like to know how you are combating overnutrition, particularly obesity arising from fast foods. How is the Indian government regulating fast foods? It is a very big challenge in Uganda. Two, how are you regulating overuse of pesticides? Because they are a big challenge to organic foods in our country. I'm happy you have the Food Act. I think this is a very good practice by government to combat hunger and undernutrition. I think this is something we can copy. But how are you managing the two in the current times?
Thank you very much. Okay,
Thank you, I already have it. I hope you can hear me.
Welcome.
Okay. So my name is Emma Rono from Aga Khan University. We are the next host of the regional meeting in Africa. And my questions are not really directed to the panelists, but even to the crowd. And I have to, we were looking at collaborations, and we want to know more of the most promising areas of collaborations between India and Africa in terms of innovation and tech transfer. And as I said, it's not entirely directed to the panelists, and we can hear from the floor. And secondly, how can the partnerships address issues of food waste? Because, there are aspects of food waste in other areas, which I don't think we've heard this morning, but we can also look at that, including post-harvest losses, and also thinking about sustainable agricultural practices that have been mentioned and low productivity, yes, which can also be tied to what Professor Charles has talked about pests and diseases, which is, also related to organic agriculture and what have you. So let's see let's see about the most promising areas of collaboration and how the partnership can address those issues I've talked about: food waste, low productivity, in a nutshell. Thank you.
Thank you very much, Emma. As Emma noted, let us all plan to be in Nairobi next year.
Most welcome to Nairobi next year, April from 26th to 29. Thank you.
Thank you. Should we start with this? Prof. Monica, would you like to take the first, and then you can also go to the second, and then Professor Tinku and David and Ntuli, you'll also chime in on the three questions.
To start with, yes, organic farming, definitely we need policy measures. If we want to bring about a large level impact, it has to be subsidy for organic farming, and that is the only way. Otherwise, little efforts that are happening at individual level, schools are starting kitchen gardens. That is also a way of, ensuring that from a very young age they have the concept of farm to plate. Otherwise, students never appreciate the fruits and vegetables. So those are some other efforts that are happening, like at the community level to engage community. But at the farming level and large scale, it has to be policy measures that can promote organic farming. It is also related to the second question on pesticides usage and monitoring and reporting these use of pesticides in the products. That is something which civil society researchers can get very actively involved and report that they are exceeding the permissible levels. So that is the role of public health policies. On the question of how we are regulating overnutrition, so the Food Safety and Security Authority of India is currently working on coming up with guidelines for front of pack labeling. So which will be informing the consumers about the products that they are eating, whether they are high in fat, salt and sugar. So that is like consumer rights initiative. And our Prime Minister actually has given a clarion call in his monthly meetings that he does nationwide. There is this call of reducing obesity in India, and he has made a call saying, everybody please reduce your fat consumption. Please start with that. Especially for children, there is projections are huge for India, the numbers that we would have of overweight, obese children, and we are already starting to see type 2 diabetes in school setting, which was unheard of. Children in school age never had type 2 diabetes, it was type 1. And type 2 diabetes was something which would happen only after 40. But now school surveys are showing that in school settings we have high blood pressure, we have triglycerides, we have type 2 diabetes. So this is worrying, and the government is taking active steps in that direction to again start individual behavior change. But on the policy front, front of pack labeling, advertising restrictions, even the sale of unhealthy food items within 50 meters of educational institutions is actually prohibited. It's the implementation which is lacking, but there are policy measures. I'll let other panelists chime in.
Are running short of time. We started a bit late, but I think it still does not mandate us to stay over, being mindful of the next session. I understand there's a session immediately after this, right? So please.
Yes, I'll be just quick. I think Professor Monica already referred to the policies that are in place. Yeah.
Then you can pass it on to David and Tuli to also give their remarks. Thank you. No, please. Yeah.
Yeah, I just want to say that the portion 2, which is a shift from just focusing on cereals, by itself is one of the steps towards combating overnutrition, because the huge cereal-based diets is one of the problems that government has identified based on data that is promoting overnutrition. And the National Nutrition Survey, the CNNS survey has shown that almost 50% of the children have one of the metabolic risk factors that Dr. Monica just referred to. And again, cereal-based diets is one of the issues. So the move towards diet diversity in policies of supplementary nutrition is a very welcome change towards it.
Yeah, thank you. Maybe I'll just touch a little bit about the climate change effect and productivity in agriculture sector. I think this is really still an area that it has, poorly invested in terms of really looking on efforts that could actually address some of the adaptation and mitigation efforts. But we have some of the best practice, and I think we have practices where the small holders farmers have been actually supported, empowered to have access to credits and some of the financial support to be able to acquire quality fertilizers that adapted to some of these changes, but also the seeds that are also adapted to some of these weather changes. Also technical support in terms of understanding better farming practices. As we know, for example, in Tanzania now, the precipitation is expected to actually on average decrease over time, but also the temperature. I think in Tanzania for the past 10, 15 years, around 15 or 20 years, I think it has gone up by 0.56 degrees Celsius and is expected to rise, which means that the risk of landslides and drought, which means it makes whenever you have extreme rainfall or flooding, then part of the land that is fertile could be also taken away. So adapting some of those mitigation, I think, and adaptation practices is important, and the use of existing community platform like community health workers and other extension workers to really provide awareness and knowledge to farmers on how best they can adopt some of these practices is important. There are a number of other ways and practices that have actually are now being implemented, but I think for the sake of time I would stop there and happy to continue with this discussion afterward. Thank you.
On my side, just to build on what my colleagues have said, we have already some existing best practices from India, then it's up to us from Africa. We shouldn't reinvent the wheel. Some of the best policies, regulatory frameworks that exist in India, then it's up to us to be able to take. And I think that's the essence of having this type of platform where we get to learn from each other and try to implement some of the best practices in our setting. So I'll stop there.
Thank you very much, my very able, esteemed colleagues and panelists, for your great remarks and sharing your experiences and thoughts about what can we do in going forward to ensure that we enhance what we already have and sustain them, but also look for ways to further collaborate in very meaningful way where there should be mutual benefits between our two areas. Without further ado, I would like to say thank you, but also invite Amani to say the thank you. I will invite Amani to do the closing for us very shortly. Thank you very much.
Thank you. I will be very brief. Very big thanks to Dr. Mary, my CEO and leader, for being the thought leader for this session and really driving us to convene and make this happen. Dr. Ntuli, we appreciate your time. I know you're a very busy person, coordinating many things in country and across Africa. Professor Monica, I know you were busy with the Foundation Day, but you still made time to come out here and join us. Dr. David, we appreciate your guidance and also putting together the presentation for the Arise Network. Professor Tinku, pulling you out of the family event and dragging you out here. We really appreciate your time, but most importantly, to the audience, thank you very much for joining us this morning, and let me wish you a lovely day ahead of you. Thank you so much.
Thank you very much. Namaste.
good to go? Do you want me to just explain to you? You just basically just, yeah, you just basically, yeah.
Okay.
And you just basically,
Yeah, next. Yeah. You tell me when we start.
okay. I think we'll start
Priya?
one time, yeah. Start one time.
Should we wait for Priya?
She sends her slides at 4 o'clock in the morning. We'll catch up with her when she gets there.
Okay.
We'll start so we're on time.
Okay.
Yeah. We can always slot her in. She'll probably be here by the time.
Okay.
So let's start. It's 10.
Okay.
There's a couple of seats down here. There's one over here. Okay. You're right.
So let's get started. I'm Gary Aslanian. I work at the Special Program TDR at WHO. And obviously, I am attending this meeting expecting a lot of learning, so just like you do. And the mastermind behind this session, obviously, is Lindsay Baines, who will introduce herself very soon. And we thought that this session should not be a regular panel session, but a bit of a more discussion with the audience. So as you've seen, the framework and the discussion around the global health diplomacy intervention framework, how to link that to building healthcare capacity both in India or in the region. That's a focus of our session today. We will have a bit of an overview of that shortly. Then, as I said, Lindsay will give a bit of a background. We'll hear from some of our panelists who will then also lead some discussions. And one of them is still missing. Priya, I think, is not here, but Alex and Lindsay and myself are here. So that's our plan for the workshop. So the framework is a tool where we will see shortly, and it was developed to build both healthcare capacity, but also link it to diplomacy, link it to global development goals, link it to regional goals, and how we can actually use those interchangeably and to help achieve some of these goals both in the region, in India, and also have an example how to work in this area. So I think that's the background to the overall session. Lindsay, I think you're next, I believe. Are you? Yes. Okay, and Priya is here. Perfect. I think everyone is here. Over back to you.
Thank you, Gary. Okay, so as Gary was saying, we're going to provide a bit of an overview both of India and the region around the progress made towards universal health coverage. And then we'll move on to look at the framework that we've developed as a way to sort of guide you through putting together global health diplomacy. So India's initiatives towards universal health coverage has really been around Modi Care or Ayushman Bharat. Prime Minister Modi or Modi Care has really been administered by the Health Authority, for those of you who are not working here in India, and it aims to provide free health coverage to significant numbers of the population, particularly the lower socioeconomic groups. And we know, I come from the UK, and we have universal health coverage, which is free at the point of entry in the UK, but we're having trouble sustaining it because with advances in technology and growth in the population, and also in terms of people's expectations about the sort of care they might receive and the standard of care, we're having trouble actually sustaining universal health coverage. We'll also go on to look at healthcare in India for seniors and how it's jointly funded by the union government and the states. However, it seems that not all states are complying, so it's not without its challenges. So in terms of India's Global Health Security Index ranking, it's currently index score of 42.8. It's ranked 66 out of 195. And there's been very little shift since 2019. If you look at the Global Health Index, I teach at University of London, and if you look at, we've been using the Global Health Index in our teaching, and the students have actually been using the index as part of their assessment. So they were able to select one country, and I teach international students from China, India, all around the world, and we actually followed their progress towards universal health coverage and SDG 3 since COVID, since 2019. And India's pattern and trajectory is very similar to most of the other countries registering their data on the index, in that it's been very difficult to make changes and to improve and really make progress towards universal health coverage since the pandemic, because the pandemic, as we know, took such toll on all countries. Some countries, as we're hearing in the last session, did not have their health systems as robust as they would have liked, and they found themselves pretty much alone and isolated in terms of vaccinations. So it is a similar trajectory across all rankings in the Global Health Index, that countries are struggling to really make progress towards SDG 3 and universal health coverage, because they're still on the back foot and recovering economically from COVID. By terms of ranking, India's doing pretty well. It's pretty much holding its own at the moment for the reasons that we just discovered. I'm just going to hand you over now to my colleague, Alex, who's going to talk to you a little bit about the current health threats and resilience in India.
So I have the privilege of talking to you about India, despite me only being half Indian. So I've been coming here for 35 years and have worked here both as a medical student and also now I'm a qualified doctor. I get to move around the world a lot. India is one of the most sensitive, beautiful and geopolitically important countries in the world right now. And that is because they are on the cusp of essentially economic and health greatness. But there are some challenges. So the whole world is looking at a very bad situation which they don't want to accept, and that's on antimicrobial resistance. When I used to work in intensive care, we had antibiotics that worked. Today, those same antibiotics are resistant, meaning they do not do the job they should do. People die as a result. In India, unfortunately, you can walk outside, get a taxi, get an Uber, get a bus, walk to a pharmacy. You can buy an antibiotic of good to low quality at a shop, a pharmacy, without a prescription. So the use of these things is not well controlled as it should be, and so that results in overuse and resistance. A lot of the attention that's grabbed in the headlines is about SARS. Many years ago, some of you remember, it'll be about COVID, it's about Ebola, it's about Zika. Having been involved on the front lines in Sierra Leone for Ebola, in Brazil for Zika, or Zika, I should give the correct pronunciation, or to a lot of the other outbreaks and global health challenges in the world, it's the non-communicable diseases that kill the most. You're in Delhi, right now it's beautiful outside. It's not really. The AQI, the air quality index is very high. In winter it pushes 900. That is astronomically bad for health. It's astronomically bad for heart disease, for children, for asthma, for things like that. So you've got to think about the growing middle class, obesity, diabetes. Climate-sensitive diseases. The world is changing, not just geopolitically, climate-wise. We're looking at increased floods. You've just seen the earthquake in Myanmar. You're looking at decreased access to countries and not safe healthcare access as well to provide care and support and aid. So India is an incredible continent, let alone a country, made up of all these different cultures and states. It is very important to think about the diseases that go hand in hand with this, with climate change, and that's things like dengue and heat waves as well. Digital divide. I think it's amazing that you can get on a train across India and go to a remote village and be in what was life possibly like 30 years ago, albeit with phones, with Paytm, with access to 4G, 5G. When I travelled across Rajasthan as a kid, there was no telephone service. Now you get 4, if not 5G in the remotest areas. So there is that. Epidemic risk as well, we've talked about. So in relation to health system resilience, India has the capability to provide huge resilience against these massive challenges. They have plans against AMR. It's not a one-country job. It's a worldwide problem. The way that we move, people will have flown in from America, even from South America here. You are taking diseases with you. It's the way of the world. And resistance patterns as well move accordingly. We've heard about AB as well for NCD detection and community level care. India does community level care better than anyone, and that starts at home with its own family. Amazing the way family members take care of themselves and others around them. We've talked about climate change, AB digital mission. I don't know how many of you are Indian and how many of you have used Paytm here or UPI. The digital systems in India are groundbreaking in the way that they're rolled out, but also at the capacity and scale. If you're Indian, you'll know something called the Aadhaar card. Everyone's nodding. You can't exist without one. You cannot be an Indian citizen and interact with the systems that keep you safe, whether it be healthcare or anything else, without one. The rest of the world is very far behind, in my opinion, UK included. We don't even have a digital ID for national identification. So these are things that can be incorporated to healthcare. Vaccine production capability, COVID showed. Oxford came and produced its vaccines in India. The Serum Institute led the way for the world, as it is doing. And it's not just they're producing low-quality vaccines, not at all. They are WHO-certified standards in vaccine production, and they are better than many other places in the world. And having been to places as good as Brazil, the Instituto Butantan has done a lot of the legwork in vaccine research, the capability and production of this country is unrivaled. So I hope that gives you some background to the resilience and challenges in relation to global health security.
Hi, good afternoon, everyone, and thanks, Alex. You mentioned AMR, and I've just come from a session around AMR and One Health, and we know that it is a growing problem. The kind of perspective that I'm going to bring into the session is really a little bit about India's big neighbor. That's the Republic of Indonesia. It's a country of 17,000 islands with a total population of 285 million. I've been asked to talk a little bit about the UHC in Indonesia, which somehow and in some ways parallels India's own journey for UHC. So Indonesia has a very large social insurance provider, a lot like the RSBY scheme or the Ayushman Bharat scheme as we see today, which is the largest insurance provider in India. The Indonesian provider is called the Jaminan Kesehatan Nasional, which is the Indonesia's national health insurance program, and it was launched in January 2014 and is managed by the Badan Penyelenggara, the Jaminan Sosial Kesehatan, or properly known as the BPJS Kesehatan, or the Social Security Administration Scheme for Indonesia. It covers almost 95% of Indonesia's population. And the primary aim is to improve the access of the average Indonesian to healthcare services and to provide financial protection for all. It also, like the Ayushman Bharat scheme, features registration. So it has two options. One covers a broader population that is covered. That is all people under a certain economic group is covered under the BPJS. And then the scheme splits. And then there's a registration for employers and self-employed who register themselves, and there is a digital registration that is separately managed, that is also managed by the BPJS scheme. So essentially, BPJS Kesehatan is a financial safety net for those who need healthcare expense assistance, particularly for catastrophic conditions. But like all insurance schemes, though the Indonesian one was born a little bit after India's own trajectory towards universal health coverage, I was part of the initial high-level expert group secretariat commissioned in 2010 by the then Planning Commission of India under Montek Singh Ahluwalia, who commissioned the high-level expert group for UHC for India across 12 terms of reference, and we undertook these massive baseline studies over 12 years. Indonesia followed kind of somewhat closely, and I remember during that exercise we went and actually had a lot of discussions with colleagues in Jakarta, even as they were looking at expanding their own social insurance schemes. But like all schemes, nothing is perfect, and there continue to be persistent challenges. And UHC essentially is never a one-size-fits-all. Initially, I had repurposed this to actually include other ASEAN countries, but the lesson that I would take away when you're looking at UHC is that there is no one glove that fits every hand. What you do is you cover as much as you can, and in some cases hope for the best, or you gradually kind of, improve the scheme across different levels. How am I for time? Almost? Okay. So some of the challenges include uneven distribution of healthcare resources. This is a common thing. You find it in India, find it in Indonesia, Laos, PDR. There's never enough money. And particularly, this is acute in eastern regions like Papua and Maluku, which are, islands that are way on the eastern side, and therefore it's very difficult to actually get to them. Supply chain disruptions. You see that in India as well. When you're in remote, up in northeast or the Sundarbans, it's hard to get to people. So remote and rural areas frequently experience shortage in essential medicines and medical supplies. And then, of course, there are financial sustainability concerns like healthcare programs that face inadequate funding. Primary healthcare is often left behind in many of these cases. Though Indonesia has done particularly well, they have a very interestingly networked set of primary health centers called the Puskesmas, which is interestingly now linked to Elon Musk's Starlink, and therefore you have all these digital connectivities. However, things like who owns the data, where does that go, are all things that are still up in the air. And finally, Indonesia is a mixed health system. Private sector fragmentation. So you go to a local hospital in Jakarta today, which is a government hospital, a lot like our government hospitals, but then you also have hospitals like Max and Apollo. So private healthcare exhibits fragmentation, and this again, causes inconsistencies in quality of care. Finally, one of Indonesia's biggest problems is human health worker shortages. In fact, they plan to hire foreign doctors because of the severe backlash. Indian doctors, if you're looking to get a job in Jakarta, this might be a good time for you to apply. So this is how bad it is. And finally, you do see a shared pattern across ASEAN. Sorry, Lindsay, I actually thought you had deleted the slide. So this is across many countries. You have mixed health systems with both public and private. You have urban and rural disparities. So cities tend to have significant differences in healthcare. You have fragmented financing. So you have a kind of a pool purchasing model, and then which can often be stretched, and then you have workforce shortages. So across the ASEAN, like I said, different countries have evolving systems of UHC. Thailand, which is publicly funded, community-driven, but is fragmented again, and it offers broad coverage, but often suffers from pool fragmentation, which is, there is employee or employer-specific funding, and then there is funding from the state. Philippines, which had the UHC Act in 2019 to address the very high out-of-pocket expenditure, but still OOP really persists, and this is actually hindering some of Philippines' own, progress towards UHC. Vietnam has a very high insurance coverage, but quality of care again varies across the countries. Cambodia, again, small country, not quite fully UHC, but has developed something called health equity funds that reimburse public providers for treating poor patients. But again, they hit the bottom of the pyramid. Everybody else, goes into private networks for care. So it's a targeted mechanism. And finally, Singapore. Singapore actually has a pretty well-ordered and well-funded system till now. But again, mixed financing and through what is called a mandatory savings account called Medisave. This is highly efficient, but again, equity concerns emerge, particularly because of the difference between Singaporeans, permanent residents, and migrant workers. And Medisave often doesn't cover the bottom end of the spectrum. So there are lots of opportunities for mutual learning across countries. The health workers from India, for example, who the ASHAs and the ANMs, there have actually been several ASEAN forums where there is a lot of cross-exchange of the deployment of grassroots level communities. Indonesia's Satu Sehat is a digital scheme that was actually rolled out, and there are many parallels that could actually inform the ABDM rollout. One very interesting thing that the Satu Sehat does is that it expands across all the 17,000 islands, but the really interesting part is that it integrates private sector data from hospitals as well as public sector data, which our ABDM doesn't really do as yet. So that's a big point. And then, of course, there's a lot of cross-learning that can emerge from telemedicine, digital health, and so on. So at the end of the day, the future of UHC in many ways is around regional collaboration and South-South platforms, which include the ASEAN collaboration. There's a lot more of that happening. You'll see that in a lot of the debates around diplomacy today, where as the world becomes more multipolar and fragmented, there's more room for local and regional transformation and coherence and convergence. Thank you.
Thank you. Thank you very much. Okay, so now we come on to we've provided you with some background information, so hopefully we're all in one place. So now we want to introduce to you a framework that we've developed. Remember, global health diplomacy is still a very new field, and so it's important that we get not necessarily some sort of standardization in process, so that we're all doing the same thing and we're all referring to the same thing across different countries, but it's important that we have some sort of process in place, which is, flexible and can bend to the needs of specific countries. So we introduced to you the Global Health Diplomacy Intervention Framework. So you just follow the circle round, and these are the aspects which you're going to be focusing on today in your small group activity. So there's nothing new here, so we don't really need to linger. What we've done is we've brought together key components which you can follow when you're trying to put a program together. Because we know that global health diplomacy is no longer the prerogative of career diplomats. That at all different levels, we are working across many different professions and many different disciplines, in many different kind of environments to be diplomatic. Okay? So we want to focus on health promotion and prevention. For those of you who were in the last session, there was a wonderful example of a feeding program in Africa. We then look at education and training frameworks. So you imagine that you're sort of at the forefront of setting up a new profession, of defining the parameters. These are the areas and elements which you're going to have to get in place in order for it to be a coherent discipline. So we need to decide on the training and the education frameworks. Also establishing new governance mechanisms and building alliances and stakeholder engagement. And we know that stakeholder can be right from a very rural village up to a career diplomat. And also how we promote evidence and value-based intervention. I was sitting in an excellent presentation yesterday around kangaroo maternal care. And they had gone to great lengths to roll out their program and to test it and make sure it was evidence-based. And they had rolled it out in the clinics and got wonderful results. But then other countries and other disciplines decided to copy that, which was fine, which was what it was there for. But they didn't quite follow the pattern to the letter. So they were recruiting different cohorts with different characteristics, applying slightly different variables. And lo and behold, the results did not support their primary results. So it was actually the results were quite negative. So that's why it's really important that at this point in a very new profession, we have a framework in place. So what we're going to do is, it's going to be rather like being back at university. We're going to put you in, sort of get yourself into small groups of maybe, so we need 4 groups. And so if you get your groups into maybe sort of 6, 7, 8, and then we will allocate you a particular element on the framework. Go find somewhere to sit around the building. And if you come back here by, should we say, 11:40, we come back here by 11:40, and make sure you have an allocated speaker who can feed back what you've actually discussed. So can we, if you've got any, you don't want to be with anyone in particular, your number one aim is in the room, just let us know. So could we sort of form one group here? And can you allocate yourself a leader and a note taker? Okay, so they're quite important roles. So you're looking for someone who's paying attention, who's very together, right, who grasps aspects very quickly. And would you like to focus on health promotion and prevention? So in terms of global health diplomacy, how can you apply health promotion and prevention? And if you could come up with some specific examples, that would be really good. And should we say maybe a group here, up to maybe you? Are you happy to work with these people? Okay. So would you be happy to look at education and training? So remember, you're really looking at mid-career professionals who are going to present for training. People who sort of started their career, but really sort of still trying to find their way. And they will be coming from cross-disciplines. So remember, you could be teaching scientists, you could be teaching medical doctors, economists, all within one cohort. So just bear that in mind, okay? Another sort of group here, sort of happy. Allocate yourself a leader, okay, and a note taker, so that when you come back, you've got something coherent to say. Can I allocate you establishing new governance? Okay, so we're going to need some kind of governance in place, okay, to support. And then from Matthew down to sort of here, this area, you happy to be a group? And could you look at building alliances and identifying stakeholders? So again, it's rather like education. These stakeholders are going to be drawn across disciplines. So when you're working across disciplines, remember the most common barrier is terminology. So what's one person's is collaboration is another person's chatter. Okay, so you're going to need to make sure that you've got common terminology. It's going to be one of the most challenging. And then finally, this group here, would you like to look at promoting evidence? So looking at value-based. And one of the biggest questions from the sessions that I've been sitting in so far has been, how do we accurately translate what we find in our research into the clinics? How do we actually translate that into the clinics? Okay, and that, of course, none of these elements exist independently. Of course, they all interact. Okay, you can't have one without the other. Does anybody feel like they've been left out and they don't have a group? Oh, you don't have a group? Okay. Yeah. You can choose. Which one would you like? Choose to your strengths. What are your strengths? Health promotion. Are you happy with health promotion? Yes? Okay. Health promotion. So each group, you could just go off and find somewhere to sit, but make sure you know how to find your way back, because it's all a bit of a maze. All right? So we don't want to lose you. We need your pearls of wisdom. So if you can go and find somewhere to sit and be comfortable and cool and get them hydrated, and then come back with somebody who's going to speak for your group, and we'll work our way around the groups. And what would be really great if we could start to work on our findings and formulate them into some sort of paper. Okay? So we'll see you all back here at 11:40. Okay? Don't get lost. Thank you. Because when they do the group, when they distribute the photos, I don't always get photos on my
could be whatever it is. So I think the first thing is think about, as well as commonality British person, a Britisher, as well. So, should I be speaking Hindi? Well, no, not if you speak Telangian, not in Manipur. So, the point being is, I think there has to be a real serious consideration for how this. What else say up there I didn't get enough time to speak about? Sweden, the UK, and other countries talk about development, talk about the fact that we're on losing hands a lot of us, practical policy in the UK side, whereas India is not. American seems to be. But the point being is we have electricity, we take for granted that we have a baseline education that passes a lot of people. The very fact that you can spell the word diabetes and understand what it means is a huge advantage if you have the disease. If you don't have the disease, you may not connect to the word, you may not connect to the sugar level, you may not connect to the medication, means you don't take medication. If you have a bad GP or not a bad GP, if you had a bad specialist, they would write the prescription and send you out without explaining the importance. So health literacy is massively important. That's something that we take for granted. Top analogy of what clothing you're going for is important. But also the difference, especially in the room, you cut across the use that, and that's about HIV prevention and children. What's the promotion now? A child. Start with parents. Aren't we making an assumption that everyone comes up to have both parents with health literacy? The child there, 70 to 90% of children who are deaf are not speaking their own parents. You realise that's plus. So it's thinking about all the subset of population. And in relation to health literacy, that's go on, but with India, that's the most beautiful thing about the incredible country is the diversity. From Manipur in the northeast, from the headhunters and the Konyak tribe in Naga, to Nicobar in North Central Ireland that has no contact with any outside here, to Kerala with the highest literacy rate in India and the lowest child mortality rate in India, to Delhi where all the geopolitics is happening, Jai Shankar's out there doing his thing, and Mumbai, the powerhouse of Punjabi slum that's going upwards instead of outwards, is generating over $2 billion in cash in an area of 2 kilometres square. That is a diversity of India, all of it language, culture, and otherwise. So when you try and direct the subject to one country, dengue may be important in the northeast, or in Delhi as it has been with outbreaks, but it may not be important in Nicobar or Andaman. And so it's finding a commonality of cause. And then I would say as well about experience. Who here has experience in diplomacy? You raise your hands to diplomat, not pointing you. I am pointing you, but not enough of critical ones. What experience do you have if you would like to try that in diplomacy?
Different terminologies that are used to refer to certain drugs.
Yeah, and it's very competitive, depending on if you're in Sweden, you have to do exams, you have to do top courses, you have to be good at what you do. But I would argue against what you're saying, that you raise your hands instead of a diplomat, you raise your hands as a experience. How old are you? In roughly 20, 30 years? You've got at least 5-10 years worth of life experience. So that's a different experience. That's a huge difference. When you go to a bilateral, multilateral, unilateral meeting, it sounds fancy, doesn't it? It's going to a country saying you've got little, we need to why don't we give you some aid to do a trade? It's pretty straightforward. The language you use and what you mean is like having a conversation with a bus driver. You're driving a bus. I need to get on this bus. I need to give you some money. You need to take the money. I need to get to Bhubaneswar or wherever. Yeah, it's a transaction thing. The whole point of diplomacy is recognising you don't need very rudimentary, low, but really important form of medicine, which is one-to-one diabetes, baby changes or an hourly basis. You have field functionaries. And I'll say that whatever you do, whatever level you do, don't underestimate the basics. We have to be based on a regular basis, like on a behavioural change. So how many are you public health trained here? What better can be done? Any public health training? So what is happening on a daily basis? Yes, it doesn't have scientific rigor of it, but it allows for informed decision making for the next stage. So that is also a food security, right? I wanted to bring that to the perspective. Because it's hugely important. Behaviour change is very different between Manipur and Orissa and UNICEF. I'll say UNICEF, I know but it's totally different, and yet all head towards the same thing. Lower cases of HIV among children and vertical transmission. They don't get it by through sexual intercourse, they get it by usually by their parents. It's very unusual to have intravenous drug use like that. I haven't got enough money to think that maybe in whatever country may have access to drugs that I haven't received in London. So to think about actually.
Yeah, just to add to that, yes, I work for a public health organization. So we've done a lot of
women.
We have a lot of women.
Yeah, it's amazing. I only know that from that.
We're women led.
Yeah, exactly.
Yeah, so one thing is that we've done a lot of SMSCC related to HIV, and now we're trying to do it with HPV vaccine. So one of the biggest things we should mention is that there's when we go into SMSCC, even when we're in Tamil Nadu, when we're doing in Bangalore, we have to do it we get a profile of open vulnerability, the community we are training, the community capacity. It's a very long process. You have to learn that you have to know that we can train and by the way, we go and just get a basic training. But for that,
Health literacy. Health literacy. What's the idea of not opening doors to people without the key to get to
one other piece that I think is inclusion is strawberries. There are areas in Assam that are in the south. There are organizations like Lockdown and Bangalore that are having book showings of them. So that is a lot of piece that I've done some programs that are which actually assess
I want to give you a practical example quickly. I just asked to give myself a kudos, and I'm very happy with the creative side of that. How many of you have worked in creative to your thoughts of yourself in creative, painting, music, I'll try and be particular. The creative side is really important. I'll give you a real project. So Vietnam for HIV was very good. We did a superb job of getting rates down. To the point that the schemes that were paid with funding in place for years ago were nearly out of the job. It's astonishing. They didn't have to do any action. So I found a team of homosexual males who come together to go out in t-shirts and get people to have HIV. That is what they did. And because they were flirtatious and amazing, they'd pick up the lady in the market and say, hey, and whisper around and say, HIV test. And they would get away with it, in the sense that they could do that. They could break that boundary, they could cross, they could unlock that door. When they're out getting up and looking to what to do, I was in Vietnam looking at high blood pressure, hypertension, entry was massively improved. It's hard to work out how to get more people to attack their blood pressure. Good measure. I'm sure that you've heard their story and that problem of hypertension, their problem. It's about crossing over, being creative to combine something. Why don't you marry yourself? What? And introduce blood pressure monitors on the chair where they're sat for 5 minutes. And dentists who are in a chair. You need your blood pressure not when you're running a marathon. So we did that. Lo and behold, massive amount of high blood pressure in men who have diagnosed and then going to hospital diabetes or hypertension. You see about the lateral movement and creative side that you can roll in, whether it's in HIV or otherwise. Suddenly these people were going out in the market, not HIV rapid tests and treatment, so we're going out with blood pressure. Nail samples, you're going to start that, and men as well, and anyone else. Have you done nail samples? Everyone's done it. Anyway, what we do is then suddenly in nail samples. You just take down to the lady, allowing them to access what they need. So health promotion is about behaviour. It's about breaking down societal boundaries. It's not about being delicate and putting yourself in a situation going, how can we do that? Neither is it I know best. And the terminology we use to pick up on health ignorance, I would never use, but it's not perfect. Say that's really valid to make you feel bad. Let's say that we're all learning. You know, I've been doing a huge amount of learning recently around transgender identity. So it's about trying to work out what with that. But for you, I would think about maybe not going to your friends and saying that, and instead checking out something more positive. And we're all here to make positive gains. Does that make sense? Does anyone else have any points about health promotion? I said that in a diplomatic way while we did it. I said that there are multiple things to think about across diverse populations like India. I've had examples. Commercial. Equality and inequity. Yeah. And also the back, we smash away the background to that. You're familiar with formula milk, you've all heard of this stuff. It's also nice how that turns out, and talk about what it is. So you need to do your homework and be diligent, because the population you're serving may not be vulnerable, may be vulnerable, may not be able to yourself. How on earth are you expecting the 5-year-old child to walk back to health modelling? I'm not saying correct that, with HIV, to be an advocate for yourself. And so it's important to break down those boundaries. And not smash them down with a gun or a hammer. It's about the delicate, but So you mentioned fill up an entire conference about financing of healthcare. PPP, public-private partnership, right? University. Right. 2 days ago I was working in a university in South Korea. It's the most, it's like, I shouldn't say, but India, Pakistan, there are very sensitive, awful things happening, as well as, you know, a long history that I can possibly understand. So putting your foot wrong accidentally can cause bad circumstances. In terms of funding, that can be catastrophic. It can end the program. If you were to abuse your position and do something really awful against the local population, take advantage of these things, and there'll be people looking at you for that opportunity to complain to you. So if you want to fight responsibility, wearing that thing, it's important you think about that. Funding, there is no worse and no better time for global health funding, like what now could be said. The worst is what's happening in America. Things are being tied up and screwed up and thrown and then picked back up and gone, no, actually, you can't do that. It's catastrophic.
Okay, everybody. Oh my goodness. Next time we need a bigger room. I was sitting in a... Okay, everybody. So if your nominated speaker could just get ready, and then we'll start the feedback. I don't know. Do you want me to do this?
One of the things I heard is that people should interact. Yes. I just one of the girls. No, in the back now. Okay, let's do it.
Okay, everybody. Okay, so just make sure that your speaker's ready and good to go. Bullet points. No rambling.
Okay.
Yes, passionate. Yes, I'm seeing a lot of passion in the room. It's lovely to see. So, Chatham House rules, and when someone else is speaking, please just, listen. Try not to mumble to the person next to you. Okay, everybody, so we need a bit of quiet now. Okay, so which group was looking at health promotion? Super. Do you have a spokesperson? Okay, would you like to stand up and just give us some feedback?
And we give you a microphone.
We will.
Oh. Hi everyone, good afternoon. My name is Mariam. I'm from Swasti, the Health Catalyst. I was a part of the health promotion group, and this is a quick rundown of the kind of pointers we discussed. So when we discussed health promotion, one of the first things that we came up with was health literacy, where health literacy is kind of lacking in certain areas. We have to go around telling people about certain situations such as diabetes, the NCDs. Health literacy was one of the key points that was brought up, where across India, that is something that we're still working towards in different communities in every corner of India, right? In relation to that, we also have the geography, right? We have a diverse geography across this nation. We have certain areas that are only accessible through boats. There are certain areas that are not accessible at all. So that was another key point in relation to conducting health promotion. One of the key other pointers was on social and behavioral change. I know most of you who work in India know this, that when you try to get any community to like adapt any health strategy or any health behavior, health-seeking behavior, you have to consider social and behavioral change particular to that community. When you're doing it, you have to go in with research on the particular community you're serving, on the languages they use, integrate with the locals on how you're going to do that. And I think one of our group members mentioned a great point, how previously we did only IEC material. And we're moving towards more SBCC training on ground, and also through innovative methods, like I think Sir was mentioning, using videos, using songs, using theater, because that's what engages people. One of the main things that I've seen on the field is there are very avid WhatsApp groups. They don't want to read things anymore. They want visual content. They want video content. So that was another important part. One key factor that I think we discussed was related to funding. As we know, health funding is something that we're all looking for. And we discussed on how we can better collaborate multi-sectorally, because, and one of the ways that we mentioned was through collaboratives, through being a part of collaboratives as organizations, being diplomats, as I think that was a big part, that we're all diplomats here, even though we might not consider ourselves to be, but every one of you in your room is a diplomat for who you're representing or where you're representing. Other than that, I think one of the key factors is that when we think of doing health promotion, we have to think through human-centered design. That is one of the main things. So I would like to invite any team member who would like to add any additional points. Yeah.
She has summed up everything, but one more point I would like to add, which the group discussed and agreed, this is my suggestion, that before we proceed on health promotion in any area or any village or any country, we should have some, before the actual start of the promotion activity itself, we should have some basic idea or knowledge about the local population whom we are going to address. Is it a rural population? What kind of language they can understand, and because every region, every population's level of understanding different, so we have to have some basic idea about the local population or which country, which geography, then only we should proceed further. Thank you.
Thank you so much, sir. Any more questions? Okay, next team. Who was looking at education and training? Okay, do you want to bring your speaker up to the front? Escort them, maybe? I think it's good.
Magic microphone.
Okay. Good morning, everyone. My name is Rifka. I am from Yemen. I'm representing this group. I am, by the way, a TDR scholar. We are a group of 8, 5 from India, 1 from Zimbabwe, and 2 from Yemen. Our topic will be about training and education. By the way, I'm a clinical trainer in Yemen. I have worked with Mary Stopes International, which has like a big sector in training, especially in midwifery. First, we wanted, because this is like one of the most important things in the health workforce is one of the building blocks of health systems. So training is also very important things for health workers. So what we decide is that health system in general, healthcare in general, we cannot just unify one idea to include all this. So we choose to more specific topic about AMR or maternal and child health and NCDs. So we tried to grab ideas between those things and to unify this and become in one idea. So we looked for existing frameworks before. So we wanted to check, do we have to create a new one? Do we have to use a previous this framework. So we found for health workforce trainings frameworks before, it is existing, so many researches. But what we found is that it is like a linear process, linear framework, or like a circular one. Circular one indicates that it is like a continuous process. Linear one indicates that if you do this, you will get this outcome. So the training is not that easy, especially for me. I came from a low resource setting. You cannot just spend funding on training. And for my context, let's be honest, health workers are saturated with knowledge. They have been through many trainings, and the outcome is still poor. I guess this is shared with many countries. So what we thought about, we have to divide the process into three steps, like retraining, training, and post-training. What else we need to do is that we have to make it like a web-like. Web-like means that it is not if you do this, you will find this. It is like a multi-directional. It should be like multi-directional framework. It should also include circular shape, because it is also indicates like this is should be a continuous process, and it should be also linear. So web framework, it should be suitable for training topic. For pre-training, we have suggest that we have first of all to gain trust of building trust with health workers. Second thing, what we thought about is value assessment and norms assessment. What we found in our country, for example, and we share this information with the Indian colleagues, is that if the health worker himself does not believe that this is valuable, or he believes that this practice is giving like a side effect for the patient, he will never do that. Midwives, if the midwife believes that this contraceptive has so many side effects, or if she saw before that this contraceptive has many side effects, she will never prescribe that, whatever training she have been through, whatever knowledge she has. So value is important. Assessment of the knowledge is very important. Pre, during, and post training. You cannot just give training to the old guidelines. It is just a matter of just give this guideline, make the midwives go to training, and then assess that they have knowledge. They know everything, and sometimes we have been through trainings where midwives are like 25 years of experience, but she does not do that. She thinks that the IUDs are very dangerous because she sees complication. She saw complication before. That's why. So pre-assessment, building trust, make it community specific, context specific is more important for before training. So after doing that, we have to tailor the national guidelines according to the context specific. There should be like no universal training or guideline for country, because in same country you have like so many differences. We face this in my country, Yemen, and I believe also this is in India and other countries. So building giving like a new guidelines, and the trainers should be like capacity building of the trainers should be more careful to be like value specific, should be like context specific. And then after making the training, we will like pre-evaluation, training, and post-evaluation, pre-test, post-test should be like a continuous process along with monitoring and evaluation. Post-training, to be honest, for low resource or low middle income countries, there is no like long-term assessment for health workers, and the feedback is also missing. So we should include this, and we should highlight this in the framework. We try to include many things, but it is like we didn't have like a lot of differences. So as I said, it should be like a web. So I would if anyone from the team wants to add.
Good morning, everyone. My name is Aziza. I'm also a TDR student, a scholar here. I'm also from Yemen. One of the points that our team has mentioned is getting to know the language of the specific people who are training. As we have noticed that before, midwiferys, they have so many trainings, but the language that is used and the terms or the level of knowledge that is transferred is somehow high level. So they come out of the trainings with, let's say, the least minimum knowledge to be tailored by them. So having the knowledge, having the language that is accepted by the group or the people we are training, keeping in the level of education on mind, so they can benefit as much as possible from these trainings. That's all.
Thank you. I just wanted to add, when we were developing the education framework, we separated out skills and competencies. So there were certain key, say maybe 3 or 4 competencies that you needed to have when you finished a program. But those competencies could then be applied, as you actually, the point you're making, could be applied in context to the environment, the culture, the region in which you're working. So I think it's just important to reiterate what you said. There's a difference between having competencies in a particular profession and also how you apply them. You can't roll out one training program for all countries. It's not going to be portable, but the competencies might. Absolutely.
Yeah, so the point which she was talking about and the point which was raised earlier about the health literacy, when we are talking about health promotion, we are talking of health literacy. At that point, we mean like most of us have focus on the community, but at the same time, organizational health literacy is equally important because that is how the messages are translated. So if you don't pay equal attention to the organizational health literacy, I think there is going to be this issue of why the behavior is not changing.
Yeah. So it's a combination of acculturation and health literacy. Yeah. That would be a core competency, really. Yeah. Okay, so thank you very much. Was anybody looking at governance?
Yeah.
Okay, all right, well, you're all ready to go.
Yes. So I'm Dr. Arohi Chauhan, and we had a fabulous group of individuals who had experience of working in different countries, and there were people from WHO as well. And we had a very nice discussion on the new governance mechanism for global health diplomacy. At the starting of our discussion, we all agreed that for the new governance, it should be built on shared vigilance, solidarity, mutual accountability, and science-driven decision-making. Now, it should focus the regional alliances involving other non-state actors like the academia, the civil societies, etc. Now, this does not mean, creating new institution or replacing the existing one, but strengthening those institutions so that we have a multilateralism and a shared leadership in the global health responses. So, we discussed that we already have the architect and the structure in place, but what is lacking is the interagency coordination in terms of the tools and the mechanisms. Like for example, the OECD workforce or the policy repository or the medical tourism. The second issue is, the recent dialogue which is going on around the flow of the funds, the financing mechanism. Like recently what we are seeing, the finance flow the funds have been halted. So how to, maintain that flow of funds, because for governance that is also an important aspect. We also talk about governance should be kind of a hook where it takes into account the bottom-up approach or the top-down approach or hybrid kind of approach to have a unified collaborative surveillance. The third thing, in order to have a global health diplomacy with other countries, there is also a kind of a felt need to include the use of the newer technologies as well as the AI-driven solutions. The shared learning should take place so that we have a good governance mechanism. And it should happen at all levels, institutionalization of those mechanisms. For example, like the one which you were talking about from the lessons from the Indonesia, which Dr. Priya was talking about, which can be taken to India, the Setu Sahat. So cross-sharing, but with regulatory authorities should also be there. And it should be like a multi-directional exchange. Yeah, I would like to invite the other group members, if I have missed any point, if anyone wants to add anything. Yeah, fine.
I think you were quite comprehensive. Yeah. Thank you very much. And was there a group looking at building alliances and stakeholders? Excellent. Okay. You got a microphone? I think this one here, down here works. There you go.
Okay, hi. I'm Arushi. I'm a second year medical student from Ahmedabad. We were a group of 4 first years and 1 law student and me. So I'm sorry if this is a child's opinion on it.
Yeah, okay. It's an exclusive group.
So we discussed stakeholders about in global health. So now, when you think about it, everybody is a stakeholder in health because healthcare will apply to every sector of the society at any point in time. So, firstly, there are private sector companies that manufacture, medical equipment, radiological equipment. There are pharmaceutical companies. There are the patients. There are the insurance companies that are covering the patients. There are law-making bodies who, make laws that help execute healthcare in effect. Then when it extends to conditions like pandemics, there are border control organizations, there are airline companies, there are, employment generating sectors that also get involved. So as when we talk about antimicrobial resistance, there are the farmers, there are veterinary practitioners, there are again pharmaceutical companies because their production of the antibiotics will be affected. Now antimicrobial resistance is a whole other umbrella which I won't be getting into. But stakeholders in healthcare are endless if we begin to list them. So alliances that we need to form in terms of India, as someone who has recently started working, trying to work in a tertiary hospital, I think we have primary healthcare centers and then we have up to tertiary hospitals. So in terms of India, we need to first mitigate the differences within the healthcare sector. We need to maintain a clear chain of communication between, beginning from any PHC in some village up to their nearest tertiary healthcare center that supplies them medicines, and up to the molecular genetics laboratories that are creating vaccines or doing their tests for them. So as long as we don't maintain a solid communication between these, we can't expect ke hum we make alliances outside, we make alliances with different countries and it'll work. We need to start with forming a good baseline within our healthcare sector. Then we can move on to making alliances with international organizations, the WHO network. Then we can work on infectious disease control more effectively. We should also work on environmental surveillance bodies and maintaining alliances with them, because I just attended a session on wastewater surveillance and how typhoid, which is a very common disease in India, and the outbreaks of typhoid can be monitored and very effectively controlled and prevented very easily if we are in contact with wastewater surveillance authorities. So if we have this many resources, we just need to form a system, make sure we have the good groundwork within ourselves, and then use it to our benefit. And lastly, for infectious disease control, another thing we found is neighboring countries should maintain good relations, at least if not on political basis, keep that aside and just communicate, if not anything, just to ensure that your citizens are safe and infectious disease can be controlled.
Thank you. There's a very interesting point there you made around get your friends or the countries that you are already working with lined up before you go to the WHO. So you approach the WHO as a cohort, really. So my question to you is, what do you do about those countries with whom you're not so friendly?
Well, that's my point, that there will always be differences. Even within our country, we are such a diverse country that there are communal wars all the time. But medicine, this one thing that relatives always ask us is, are you in it for the money or are you in it for service to humanity? So if not anything, I would hope that sometimes think about humanity And even if you're not at the best of terms with a country, if there is an infectious disease like a cholera outbreak that you know will spread across the border, then, you know, try to...
Diplomacy.
Yeah, diplomacy.
Oh, questions. The audience might. Don't run away yet.
Okay.
There may
Any
be some
questions?
questions. No, they're too shy. Okay. So finally, was there a group looking at promoting evidence and value-based care? And that very important issue around translating your research into practice.
Hi everyone, I am Dr. Ashna Chalana. I am a healthcare consultant at Ernst & Young. So our group discussed promoting evidence and value-based interventions. So we briefly talked about the evidence pyramid, where we start from expert opinion, case studies, case reports, observational studies, RCTs, and at the top of the pyramid we see systematic reviews. So this is all the sources of information which gives evidence, and that is a piece that we're able to convert into a policy brief. So ideally the flow goes from research to policy to finally implementation. Our group also briefly talked about polio. One of our members, group members is working on certain initiatives related to polio, where they talked about how they detect the water in waste, detect the virus in wastewater in certain regions, post which they scan the area to check the vaccination coverage and are finally able to introduce vaccine campaigns to further vaccinate the population there. So we also talked about the COVID-19 example, post which I think surveillance as a practice has been promoted. So because of which we now have access to routine surveillance data, meaning that before we even move to research, we're able to access certain routine surveillance data through apps. For example, during COVID, there was an application through which there were heat maps, GIS mapping in regions where there were more affected population. So I think that particular data set also helps to convert that data into data-driven actions and further decide the policy actions. We also talked about regional outbreaks. There was a person who mentioned something about if there is a certain problem in Delhi and there is a certain the same problem in Bangalore as well. So there is an importance that we're able to not be fragmented and have the value-based interventions at a certain place where we're able to see what's working in Delhi, what's working in Bangalore, what's not working, so that we can also decide the overall policy action. So just to conclude, I think the surveillance data as well as use of digital apps can promote evidence as well as value-based interventions, because as we've spoken about how connected we are as a country, specifically India, we're able to promote data and evidence better. That's it from my end. If I've missed anything, any of my team members would like to add.
You have a question here? We have a question? No, just encouraging, making encouraging. Okay. Yes, some very good presentations. Excellent. Yes, well done. Everybody that presented, well done. So we're going to be wrapping up now, and Gary's going to just sum up for us. But before we do that, I just want to make a little plug. Oh, sorry, you got a question. Oh, absolutely. Yes.
So you were talking about that pyramid, you know, of evidence. So what I want to add here, like above systematic review, there is one more thing which is, you know, emerging kind of like the Mendelian randomization studies, which actually establish the causation. Okay, so that was one of the thing. And the second point, like when we are discussing about the evidence-based policy translation, the one important thing which is missing here, you know, most of the time policymakers, what they are saying, like the research which is being conducted, this is not our priority area. Like we want research in the particular priority area. And the secondly, like there is a disconnect, you know, between those who are conducting the research and those who are making the policies. And there is actually a need to bridge this gap.
And how do you suggest we do that?
To have, you know, stronger discussions, voices need to heard. Like you don't expect policymakers to go down. You have to bring the researchers close to the policymaker. Like, this conference is
Physically or metaphorically?
It's difficult to answer.
I wanted to respond to that. For us, we did discuss about that. Having policy briefs after gathered the evidence synthesis, then you can have a policy brief. But there are some disease conditions which wouldn't allow you to do that. For instance, viral hemorrhagic fevers and something like that, which you just need a prompt intervention. So we did had different discussions, but also categorize different ways on how you can promote evidence. There are some of the evidences where you need to get a political buy-in. You need lobbying, you need diplomacy. It's where the diplomacy is highly needed. For instance, where I'm coming from, in Tanzania.
Which country?
Tanzania.
Right.
So maybe I should introduce myself. So I'm Tuli Kapologo. I'm the Director General for East, Central, and Southern Africa Health Community. So sometimes you find maybe you are having Ebola or Marburg virus disease in one country. So for you to be able to deal with that regionally, you have to make sure that you apply health diplomacy to convince the neighboring country through the cross-border discussions, cross-border surveillance systems, so that you can have a buy-in on the other end. So with regard to the question which is said, there are some of these things which you might end up just having the evidence and you get the buy-in from politicians, but others you need to write a policy brief, others you need even the issue of lobbying and other things for you to have your ideas been accepted by the politicians. Because in the end, we need politicians for us to be able to do whatever we want to do.
Yes, we just need to make sure they're saying what we want them to say. Yeah. Just before Gary sums up, I just want to make a little plug. It's been a year in the making, but Matthew, Alexander, Gary and myself are editors on we're going to be a paperback, affordable book, which gives a lot of practical direction around global health diplomacy. And it's aimed at people like yourself, mid-career, early career professionals, as something that you can take into the clinics with you, take out into the field with you, and it give you some sort of guidance and cover all the topical issues. So we anticipate a publication later in the year. So please do connect with one or all of us through LinkedIn, and then we will, promote it through there. Also, Gary will hopefully promote it through his Health Matters podcast as well. So it will be an affordable manual type book focused on global health diplomacy, which is aimed at your cohort, people going out into the field, people trying to form alliances and figure out who's friendly and who's not. Okay, all right, Gary, I'm going to hand over to you.
Any of the others have reflections? Should we ask? Yes. Priya and Alex?
Hello.
Okay.
I'll be very quick. One thing that we said in our group was about diplomacy and diplomats, and the idea that you don't feel like you're a diplomat. You are, for your organization, for your country, for your cause, but for your patients as well, or the people you serve. Where you may feel you don't have any diplomatic training or experience, think on the other side. Sit in a room of diplomats and say, who among you have had health training? And I can tell you, having sat in Ricina, the brilliant dialogue here, which doesn't even have a health strand, or around the world with various diplomats in various rooms, they have very little health or medical experience. So you're the experts in the room. That's the point I wanted to leave you with.
Priya?
Thank you. Great discussions, and it was really interesting. And thank you, Lindsay. You moderated this whole thing very beautifully. I think there were many threads that you brought together through your framework. We had a session yesterday morning with Gary on collective diplomacy. And increasingly, we live in a world that is going to be fragmented. But the point is, when I spoke to a former diplomat, he said, it's not our job to confront. We are diplomats. And that's what diplomacy means, is that we don't directly confront, but we kind of negotiate. But the negotiating or the leveraging there are interesting ways to do it. And yesterday there was a speaker who said collective negotiation will increasingly be a norm with health as a leveraging tool. So whether it is vaccine nationalism or procurement or the sharing of evidence, if countries can band together to be able to leverage their united power, you may have a larger say in an increasingly multipolar world. So great job, everybody. Thank you, Lindsay.
Okay. So I think they've done part of the job in reflecting on this wealth of knowledge that came through the parallel collection of thoughts. I think we've achieved our goal, Lindsay, here. You've done a good job in initiating this discussion. Every group had sort of questions from what I heard, how to link different parts and how to link, health, skills, diplomacy, policy, use of evidence, use of research, and that's what really is part of this framework in terms of bridging those silos, bridging those gaps that we invented. So no one actually told us that's how it should be. We invent these things, and then we close ourselves in those silos. And hopefully this session helped you to think outside and think of this interconnectedness and think of a future that will probably be even more complex than we have now. And all of these skills are needed, and this framework would help future health professionals to actually practice or use their skills in a different way. So I don't think I would say more. We'll thank, first of all, Lindsay and our speakers who helped us to set up, and most importantly, everyone in this room, which we can say every single person who came to this workshop participated, and you don't say that quite often. Okay. Where are you? Are you in Lusaka?
I'm in Tanzania.
But you said you're with
East Central.
The office is in
I would be
Arusha.
featured in here. I would like to be featured in your podcast.
Have you listened to it?
Once.
Really?
Yeah, that's why I'm very happy to see you today. It's super exciting.
How did you find it?
I just found it, I think it was in LinkedIn.
You listen?
Yeah.
Oh, nice. Ah, good for you.
I will connect with you today. Yes.
So, before you go though, since you mentioned the podcast.
Yes. So you have my card.
Yes, I do.
And I will send you a message in the podcast now. Okay, thank you. I'll do that. And
As a promotion.
As a promotion.
So are we doing a forum?
You had a very good intervention, and I'd like to connect with you in LinkedIn. So I'm telling you, I wanted to be part of your
Arusha.
Smile.
Yeah, sorry, you were saying, I was saying Arusha, amazing place.
Yeah,
I've
so
climbed
can I have your
Kilimanjaro.
card, please?
I will send you my details. I don't have my
Are
card.
you in LinkedIn?
I am on LinkedIn, yes. Just add me on LinkedIn. Dr. Alexander. Yeah, good. Would you, I don't know how
I'm not. How did you know? Where do you work? Where do you... Oh, okay.
Yes, yes.
Oh, sorry.
Sharma, and I represent Novo Nordisk Foundation's India office. Our headquarters are in Copenhagen, Denmark, and we are based in Research and Innovation Park, Indian Institute of Technology, Delhi. I want to start by sharing a very important fact about us. We are an old and at the same time a very young organization. What makes us old is our history of working in Denmark for the last 100 years. And what makes us young is the fact that we started in India just 2 years ago. And most importantly, while spreading our wings globally, health remained our focus area of work. So today we are honored to have with us His Excellency Rasmus Ebigor, the Ambassador of Denmark to India. His Excellency's presence here reflects the strong commitment Denmark has towards advancing global partnerships for sustainable development and scientific collaborations. His Excellency, may I request you to please share with us your thoughts on how scientific collaborations can further strengthen Indo-Danish ties to address global health challenges. So.
Oops, just click on here. Yeah, here we go. Honorable dignitaries, distinguished guests, friends. I love the very intimate space we have here today. Feels like a tightly packed press conference where I'm now about to announce tariffs against the whole world. But that's of course not the case. But it is indeed a great pleasure and a privilege to be here as the relatively new Danish ambassador to India. And today at the World Health Summit regional meeting in New Delhi. I understand it's a very important gathering of global minds committed to advancing public health, scientific collaboration, and sustainable development. And let me start by thanking the Novo Nordisk Foundation for inviting me and for organizing this session on partnerships for institutional capacity in science and health. But also allow me to thank you for the very impactful work you do and support both here in India and in fact all over the world. So the theme for today's session I think resonates deeply with Denmark's values and priorities. We firmly believe that global challenges, especially those related to health, sustainability and scientific innovation, require global solutions. And these solutions are best built on trust, collaboration and strong institutional partnership. Denmark is proud to be a nation that invests in knowledge, in innovation and in people. And I think these values are also at the heart of our Green Strategic Partnership with India. And it continues to be a model for how two democratic nations can work together to address some of the most pressing issues of our time, whether it's clean energy, water security, or health and life science. Through this partnership and through the work of Danish companies and foundations, including the Novo Nordisk Foundation, we aim to promote not just bilateral cooperation, but in fact long-term capacity building. And our partnerships are more than just policy agreements, they are built on shared values and trust. But let me share a small Danish story that illustrates the spirit of the collaboration that we cherish. Back in the 1920s, Denmark faced a very serious public health crisis, and that was the spread of tuberculosis back then. And at that time, it was one of the leading causes of death in Denmark. But then a small group of Danish scientists and medical professionals came together to create a new institution. And these scientists had limited resources, but an unwavering commitment to global welfare. And the result was what would later become the Danish State's Serum Institute, Statens Serum Institute in Danish. It's a public health institution that would play a pivotal role, not only in eradicating tuberculosis in Denmark, but it would also later become a global leader in vaccine development and epidemic response. And I think the key point here is not that it was scientific talent that made this possible, although that of course played a key role, but it was this public and private support, the public and private actors coming together based on a shared societal vision that health and science are public goods to be protected and advanced for all. And that same spirit lives on today in institutions like the Novo Nordisk Foundation, which exemplifies, I think, Denmark's commitment to a science-driven philanthropy. They bring the vision to invest in long-term research and the commitment to nurturing talent. And in India, the Foundation's engagement plan is testament to the power of collaborative investment in areas such as health innovation, education, and sustainability. As we look to the future, capacity building in science and health must remain a global priority, whether through training the next generation of researchers, strengthening public health infrastructure, promoting collaborative research. Such efforts are crucial to shaping a healthier and more equitable world. And certainly, Denmark stands ready to support and expand such partnerships, and we're eager to work with India and global partners in building platforms that enable cross-border research, innovation ecosystems, and public health solutions, serving both nations and indeed the world. And in this effort, we must also confront some of the critical health threats, such as antimicrobial resistance, AMR, which represents one of the most serious and growing challenges to global health security. So strengthening research and institutional capacity to tackle AMR will be essential in safeguarding the progress we make in healthcare and development. So let me close by reiterating Denmark's deep commitment to the Indo-Danish partnership and to our shared vision for a greener, healthier, and more inclusive future. So again, let me thank the Novo Nordisk Foundation and its partners here today for their dedication to this vital cause. Thank you very much, and thank you again for inviting me.
Thank you, His Excellency, for your very thoughtful remarks and for highlighting the importance of international collaboration in advancing research and innovation. We appreciate your presence and continued support in strengthening partnerships between India and Denmark. Thank you. May I now call my dear colleague, Ms. Mette Davidson. Mette is our Director of Global Health Programs and has traveled all the way from Denmark for this very important session. Mette, may I call you to please introduce Novo Nordisk Foundation and our strategy. Thank you.
Thank you. Thank you so much, Monica. Mr. Ambassador, distinguished guests and experts, partners, colleagues, and friends. Thanks for joining us for today's session. As Monica mentioned, I'll give a brief introduction to who we are and what our strategic priorities are globally, and then later I'll hand over to Jakob to say more about our priorities in India. As some of you know, Novo Nordisk Foundation just celebrated our 100 years anniversary, and I think it was also mentioned by Monica. So now I'm representing the aging part of the organization, and you are representing the young. So that's all fine. I'll promise I'll not go through 100 years of history, because I also realize in this room we have people who have been friends of us for a long time and partners, and you have probably heard part of this story before, but just let me briefly introduce who we are, and that also includes a very important part of our history that I hope these slides will illustrate. That it actually all started with the discovery of insulin in Canada in 1922. And as Danish scientist and Nobel laureate August Krogh, he visited the discoverers of insulin, and he was, I think, quite lucky, but also very clever enough to get actually the permission to produce insulin in Scandinavia. But he also in return gave a promise that the profits would go back to society, would go back to research. So when he came back to Denmark, he started producing insulin with a group of peers, and also actually his wife, Marie Krogh, played a pivotal role in this. And the ownership of the production of insulin rested with a foundation that gave profits back to research already back then. Today, as is illustrated by sort of the right part of the slide, is that we in Novo Nordisk Foundation, we try to fulfill that promise even today, the promise that was given more than 100 years ago. As you can also see, we are still owners of insulin production. We are the proud owners of the pharmaceutical company Novo Nordisk, or the majority of shares, not all of the shares. Novo Nordisk and actually 170 other life science companies. And we have another organization, our family that I think also is represented here today, Novo Holdings. You can also see that that's basically our bank box and our colleagues who invest the money. And we at the foundation, we have the privilege of then using the profits to give out grants to science and health in Denmark, Scandinavia, India, and hopefully soon all over the globe. But I'll say more about that. Anyway, this next slide is a bit on what we focus on when we give out grants. What we do is we try to follow our vision, which is very ambitious. It's about improving people's health, the sustainability of society and the planet, no less than that. And we have a list of philanthropic purposes, while at the same time we also have an obligation to take care of the Novo Group companies, including Novo Nordisk. We are in a very privileged position. Actually, as you can see here on this slide, the outlook for our grants looks very positive. So we expect to see an increase from the current 1.4 billion euros. I cannot share the exact numbers, but we hope to see an increase. And that is also why our board of directors have decided that we should go more global. So when you look at our current strategy, which will take us to 2030, and this is just a very brief summary, this is what we are doing and have been doing very much with a base in Denmark and Scandinavia. Right now, 85% of grants are within that region. However, as Jakob will also say more about, already you will see these strategic priorities reflected in what we do with Indian partners. And almost as we speak, actually, our board of directors are discussing and hopefully approving an internationalization plan for the Novo Nordisk Foundation, where you will also see these areas reflected. And basically they are health, life science ecosystems, and sustainability. So jumping right into from sort of the global level and our strategic priorities, I would like to say a few words about a very important partnership for the Novo Nordisk Foundation here in India, in East Africa, and also globally. Partnership for education of health professionals. And I'm so happy to see today in this room many of our dear friends and partners who actually right from the beginning advised us, helped us to shape this partnership. So it's here in India, PHFI, AIMS, CMC Vellore, and also now we also recently had a project approved to government of Assam. So thanks for being here today. The reason why I wanted to highlight this project is of course because it's very important to us, and I hope also for partners in this room, but I also hope it will illustrate what the Novo Nordisk Foundation is doing and what we do. So basically it's about providing better access to prevention and care for cardiometabolic diseases, and we have a focus on training of healthcare professionals. And then I will finish on a very happy note. Today I'm actually able to announce that 3 new large-scale projects focusing on supporting new centers of excellence hosted by AIMS, CMC Vellore, and PHFI just got approved by our board of directors. So please allow me to spend the last few seconds to congratulate AIMS, also represented by Nikhil Tandon, and also PHFI, Professor Sotpe, and we have CMC. But anyway, I'm so happy to announce this. We are looking very much forward to the collaboration, and congratulations on the continued partnerships. That's all from me, and then I would like to hand over to you, Jakob, to say more about Novo Nordisk Foundation in India. Thank you.
Thank you, Mette. My name is Jacob Williams, and I work in Copenhagen, focused on promoting India programs from the foundation here in India. And we were joined by Ambassador and are joined by Ambassador, and we also started with the Danish bilateral relationship with India, where we very kindly and also, I think with good reasons, were invited by the two prime ministers to take up work in India with Indian science ministries. And we have many in the room here who were part of that process. It was a relationship that started, an idea that started with the Principal Scientific Advisor's Office organizing work together with the foundation and CCAMP, who's also in the room, in 2021, then leading into this joint statement from the prime ministers. And since then, we've been looking into how could we deliver on that. We are delivering on that within the strategic priorities that Mette has just outlined. But we have tried to tailor it to the Indian context. India we see as a key opportunity for the foundation for many reasons. First of all, it's a place of immense scale, and therefore also opportunity to deliver on some of the key ambitions of the foundation. Secondly, it's a place, and I think we have some in the room here from NIMS and Ashoka, it's a place of extreme opportunity within the scientific talent that are coming about. We have an Indian government and Indian industry that have systems and ambition to scale good ideas, good initiatives on the challenges that we share within, for example, food security, cardiometabolic disease, AMR, and so forth. But we had to focus in a little bit, and we are focusing on 4 areas, one being health equity, which has been the driver for our entry here with the Partnership for Education of Health Professionals. Second being cardiometabolic disease burden, which, as you noticed, is our legacy concern all the way from 1920 to now. Third, we are looking at programs in climate and agriculture, and we may even be looking at carbon capture going forward. That you could say is also a legacy. Not a lot of people know that, but it's a legacy concern for the foundation based on the work that Novozymes, now Novo Nordisk, has done in the Danish context, and the profits from there that is coming up to the foundation. It is going to be an equal opportunity for us, and potentially also an equal priority for us. Last but not least, as was also mentioned earlier and by Ambassador as well, antimicrobial resistance is a growing concern globally, and it's a key concern for the foundation. And India is one of the front runners, both in terms of having resistant pathogens, but also, we think, a key opportunity for addressing this topic in a way that will resonate globally. Underneath, I've put a little bubble there, and that's an ambition to connect in the bilateral spirit, in the European Indian spirit, our life science ecosystems through our grants. On the ground, we have 5 employees in IIT Delhi, led by Monica, who was here, but we will slowly expand to a small, lean team that can deliver on all the different parts of the foundation strategy. And we are already working very hard, as you just saw demonstrated, the Partnership for Education of Health Professionals, It's growing rapidly, but we do have already existing engagement with a number of partners who are in the room and who are not in the room. And we will be launching a project, an overview of what we call the India Engagement Plan that collects all this after I'm done speaking here. I would like to mention that we also have a number of open calls that are open for the Indian audience, the Indian scientists. Sometimes you need to be in collaboration with Denmark, other times you can go it alone and apply for the calls that we have. It's a very important instrument for us, but it's not very well known outside of Denmark. Then last but not least, and I don't know if Nikhil is here from FITT. Yes, please come, Nikhil. I would like to announce that we have just sought and achieved the approval of a project on innovation for the cardiovascular disease NCD area that we are going to implement together with the FITT at the Indian Institute of Technology in Delhi. So please just very short.
First of all, it's a great pleasure and is an honor to be here. First of all, I'm thankful to Novo Nordisk Foundation, especially Jacob, Aditi, and all the team members for making that happen. It's a small start, but I think it's a very strong start. It's a message, it's a template that we are building. And we believe that this start can culminate a much bigger activity in the future. So we are focusing on coming up with a Healthier India campaign, where we are focusing, working on the cardiovascular disease. And there is a deep partnership that already exists at IIT Delhi. We have experts, we have friends from Niti Aayog who are already standing there. So there is a support coming from the government. And we believe that this partnership can roll out into much bigger relationship in the future. Thank you very much.
Thank you. Thank you, Nikhil. And we are very proud to be engaging with such an illustrious organization. And it is another example of how we would like to anchor ourselves with key institutions in going forward. Now, I will play a little message from our CEO, Mads Krogsgaard, who was here 2021, kicking this off during the meeting between our prime ministers that we saw before. He will speak a little bit more about our ambitions with India and also give voice to some of the partners who are in the room here today. Thank you. Right, so if it starts, or that's something I have to...
Foundation, we consider India a pivotal partner in our mission to drive science-based impact and tackle global challenges. These include advancing sustainable agriculture and food systems, combating antimicrobial resistance, and addressing the escalating burden of cardiometabolic diseases, which is felt acutely in India.
There are over 300 million people living with high blood pressure, another 100 million living with diabetes, another more than 100 million with pre-diabetes.
When combined with the scientific capability and the willingness of the government to invite industry, philanthropy and other international partners to work towards these challenges, this can bring big impact.
The Novo Nordisk Foundation began working in India with the launch of the Partnership for Education of Health Professionals, also known as PEP, together with scientific partners.
One of the critical vision of the program is to ensure there is equity and the vulnerable people have access to quality care when it comes to cardiometabolic diseases, and can be delivered only when we equip the health workforce in the country.
Cardiometabolic diseases are increasing in prevalence and also it requires a comprehensive management. I think it is crucial to acquire the skills and knowledge in cardiometabolic diseases, as we are the flag bearers and advocate for the patient.
We have been closely working with Novo Nordisk Foundation through the PEP program. We have a very strong partnership. The foundation has been very helpful in advancing the larger agenda of reforms in health professional education in the country.
I've really seen how PEP has facilitated for us to actually think about our own ideas and not really be told what to do.
We are focused on building meaningful partnerships in India. For instance, our journey with AIIMS Delhi began with PEP, but has since expanded with the signing of a memorandum of understanding that includes research collaboration as a core focus.
And that envisages a broadening of the scope of interaction beyond the healthcare professional education, looking at the travel of scientists across borders, the identification of research areas which would be of mutual interest.
India is not only rich in its scientific capability but also is open to international collaborations and a place where government, academia and industry is working together.
Our India branch office was opened in 2023 and is located at the Indian Institute of Technology, which serves both as a welcoming host and a valuable partner. Anchored at the Institute is the Healthier India program, which aims to address health equity and the burden of cardiometabolic diseases through technology-driven solutions.
We are looking at science and engineering and medicine coming together to make an impact in healthcare and look at taking innovation forward to make a difference in people's lives. So we are delighted with the partnership which we have now in the RNI Park with the Novo Nordisk Foundation, and we think that together we can make a difference in this initiative on Healthier India.
In the coming years, we'll continue to work closely with India, strengthening existing partnerships and developing new ones to address critical human and planetary health challenges.
Thank you. And we have now also been joined by our chief guest, Professor Soumya. Thank you so much for coming. And we'd like to go directly to actually the the presentation of a publication of the existing activities by the foundation here in India. So please, Soumya, we would like to present the book to you. And then you'll, And Ambassador, sorry.
Ambassador.
Yeah, please, Ambassador, if we could also ask you to join us.
We need one more copy.
Yeah.
We need one
And
more.
so,
Yeah, Monica's from there.
yeah. So, we can still here.
Yeah.
Maybe over there.
Here we go. So. Yeah. Okay. So.
But please touch this screen.
Okay. So. I'm ready to announce now the launch of the India Engagement Plan and India Portfolio. Thanks for joining us for this. Yeah. So, thanks a lot. And now we are actually moving in to the part of the session that I have really been looking very much forward to. Of course, it has been exciting to launch our engagement plan, etc. But actually now, we have a chance to listen to the insights and advice from a group of distinguished Indian experts. And I have to say some of them also long-term friends. So I'll invite you to the stage in a minute. However, please allow me just to say a few words for introduction. So actually we are moving into this panel discussion called Partnership for Institutional Capacity in Science and Health. At the Novo Nordisk Foundation, we believe that partnerships are key to success. We believe that meaningful and long-term partnerships between research institutions health agencies and funding organizations such as ours can be central in strengthening institutional capacity in science and health. But are we right? That's actually the question we are going to discuss. Can philanthropic organizations such as ours, born and based in a country in Denmark up north, play a role in catalyzing science and innovation in a huge country, a continent such as India? And how do we best do that? So that's basically the focus here, and I hope for a vivid and inspirational session here. So please let me introduce our experts and panelists. So I'll start out with a long-term friend of the foundation, Professor Srinath Reddy. Please join us at the stage. And give his applause. He formerly served as the president of PHFI and was the head of cardiology at AIIMS. He is currently an honorary distinguished professor and goodwill ambassador of PHI for public health partnerships. And may I add, a long-term standing friend of Novo Nordisk Foundation, and among the first person I met together with our CEO, Mads Krogsgaard, when we visited India 3 years ago. So thanks a lot for your guidance already so far. Then I would also like to invite Dr. Soumya Swaminathan to the stage to join us, a former chief scientist at the World Health Organization. She currently serves as the chairperson of Swaminathan Research Foundation and the principal advisor to the National Tuberculosis Elimination Program, and co-chairs the Global Commission, Our Common Air, which focuses on air pollution and its health impacts. And I think you are very active, both advisor and person in this summit. I've seen you being so busy, so thank you very much for joining us, and please enter the stage together with other experts. Then Nikhil Tandon. You are actually among the experts that has truly guided not only PEP, but also a range of other activities. So please welcome Dr. Nikhil Tandon to the stage. He's a professor and head of endocrinology at AIIMS, New Delhi, and a leading expert in cardiometabolic diseases. He has led major epidemiological and clinical studies, including CARS cohort and several multi-country trials on diabetes and hypertension care. Thank you. So, next in line, Dr. Asha. Sorry if I call you Asha. I know you're known by the name Asha in our organization. Asha. You were also among the very first persons to welcome you, as you back then worked with the Principal Scientific Advisor's Office. So thanks for doing that, and thanks for being here today. Please enter the stage. Asha is currently serving as the India Director for Women Lift Health India, and is a seasoned healthcare innovator with a strong background in biomedical engineering, and she has contributed significantly to India's science-based entrepreneurial ecosystem. Please give her a hand. And last but not least, Dr. Søren Tranberg Hansen, currently serving as the Science and Innovation Council and Deputy Head of Mission in India, Bangalore, for the Danish Agency for Higher Education and Science. He's a seasoned entrepreneur and researcher, combining expert knowledge in tech with innovation and business development. So please join me in giving a hand to our panel of experts, advisors, and friends. And I'll just jump to the stage with them. Are we okay? Yeah, now it's on. Thanks for joining once again, distinguished experts, and some of you have actually been acting as advisors to us from the very start, and I realize many of you are, I would consider partners and friends, but I hope you would be critical partners and friends in this panel, also allowing sort of good advice and critical comments to us. But what I would very much like to focus on in this panel is, of course, that question I raised at the introduction. We believe in partnerships, but are partnerships with us actually of value to the Indian science system and health ecosystem? And how do we do it best? So maybe if I could invite you to start, Dr. Soumya Swaminathan, both representing, I think you're working many years both with government, international organizations, but in a way also today also representing philanthropy yourselves. So any remarks? Are we doing the right things by creating partnerships, and how do we best do that?
Yeah, thank you very much. I think this is a really important question, and so happy that you're asking this question. Philanthropy certainly has a very major role to play. It has always had a major role to play in global health. If you think back about smallpox, the whole eradication program, you know, that started in fact at a time when the US and Russia were engaged in a Cold War. And yet they were able to, countries were able to come together at the WHO and agree that smallpox eradication was a goal that went beyond any kind of geopolitics and so on. And then of course you have the Global Polio Eradication Initiative where the Rotary International and you know, many foundations, many philanthropists, and of course governments, again brought together by WHO, have made remarkable progress. We haven't achieved, you know, it yet, the eradication, but remarkable progress in a few decades. So I think partnerships I see as very fundamental to solving problems, whether these are partnerships at the ground level, in the community, whether these are partnerships between NGOs and the government, between the private sector and government, and of course philanthropy. Now philanthropy has a very particular role to play, particularly I think when you're talking about international, there's a lot of domestic philanthropy now that's growing. I think it has to grow even more. But then there are the big international philanthropic donors. And again, looking back historically, you can see that they have catalyzed things which have then become much bigger or have got mainstreamed, you know, as a result. So I think research is one area where certainly philanthropy can make a big difference, particularly funding either high-risk kind of research, which government agencies may be reluctant, or finding those gaps where there's very little funding going in from the traditional research funders, and if they are important enough, you know, investing in those, funding, I would say even networks and consortia like what you've been doing as well. There are many examples where, you know, the NNF has funded these type of networks and more and more, I believe, and at this conference, I think several of us have been expressing the view that we need regional partnerships in addition to global regional is even more relevant because we're closer to each other, we have similar burden of disease, similar issues, similar socio-cultural and socio-economic problems, and the solutions may be also more relevant, you know. So funding those kind of initiatives, sharing of knowledge. Today, I think knowledge is something that really needs to be democratized. It is still, there are so many solutions available that people who need it are not aware of, you know, whether it's a small farmer, whether it's a fisherman, whether it's a woman, you know, there may be a solution for that person's problem, but they're just not aware of it. And earlier today, I was also at another session where we talked about, you know, using the ECHO platform to democratize knowledge, not just in health, but now also in education, agriculture, we're taking it forward as well. So I think there are many, many roles, you know, that...
Thanks a lot. Very, very encouraging, and also very important that you highlight that it has to be based on local knowledge and local needs, because this is indeed something we have been trying to do when entering India as a philanthropy. maybe if I could ask you, Dr. Nikhil Tandon, because you have also been following us right from the beginning and with your experience from AIMS and also shaping academic leadership in India, are we on the right track, and any good pieces of advice for us at this point of our journey? Please, Dr. Nikhil Tandon.
Thanks, thanks, Mette. I'm not sure if I'm in a position to advise, but we can definitely participate in the discussion. Perhaps that's a more equitable way of putting it, and therefore let me first come up with the story of equity. And I think equity becomes a very important part for any sort of intervention or support from philanthropy. It actually does assist in leveling the playing field in many instances, and that's for me a very important part. I think in terms of global health initiatives, if we see, and I'm sure Dr. Reddy will have much more to say on this, or definitely has much more to say on this than I can, but nonetheless, the early era of global health was primarily driven by countries who had, perhaps, for example, if you look at all the schools of hygiene and tropical medicine in the UK, they were driven by the need for Britain with their expatriate citizens in different parts of the world. But I think we need, therefore, to decolonize global health and make it more bi-directional between high-income and low-income countries. And again, that sort of effort is likely to come more from philanthropy and foundations than from individual governments. Thirdly, I think it provides the opportunity, sort of an initial platform for interaction. And I think philanthropy is more nimble in their decision-making process. I mean, governmental decision-making process goes through its own, necessary steps. And with philanthropic organizations and foundations, that nimbleness allows an early entry into emerging problems, allows some initial steps to take place. In the meantime, more governmental presence can be felt in the same space. So I think, we've had these discussions in the past, I think it's important for a mutual understanding of what our needs are and what the foundation can provide, specifically the Novo Nordisk Foundation, which has its own specific strengths, and a sort of a marriage between the strength of the foundation and the requirements of a recipient country and recipient researchers is a very important part for that.
Thanks a lot. And since you mentioned Professor Reddy in your intervention, maybe handing over to you to participate in the discussion with some of your perspectives on how we best engage with government research institutions to enhance public health research in India. Please, Dr. Reddy.
Since I've been making eye contact with your timekeeper there, I'll now look at you rather than be intimidated by her. Okay, and I'll try and be as brief as possible. I'll try to be as brief as possible.
Very experienced panelist.
Yeah. So, given the fact that you are really emphasizing on three elements here in this question. One is public institutions, second is health systems, and long-term investments and impact. Now, I would say that when you're dealing with institutions, you're dealing with government, both at the political level and the bureaucratic level, who expect also some short-term and medium-term results. Institutional heads also expect medium-term results. The scientists and the scholars may be ready for long-term perspectives. So even as you're engaging, do think of some early wins, which can at least create enthusiasm for continuing the project. That's going to be an important element. Second is when you're talking about health systems, it's recognized while policy is made at the national level and programs are configured there, the actual implementation is done at the state level. In the federal polity, you have to engage with the states, with the blessings of the central government wherever possible, but you have to do that with the states. Third is build technology transfer as an important component. Because far too long we've had fly-by-night researchers and institutions coming in, collecting data and going away, but without actually engaging in technology transfer and capacity building. Try and remove that kind of a blemish. Fourth is train teams, not just individuals. Whether it is elucidatory science or implementation science, it's teams that will deliver. Individuals may float around, but teams generally stick together, and it's the teams that are going to be producing results. So train teams. Fifth is align with primary care-led universal health coverage, which is the pivotal area of our national health policy. So even as you are looking at chronic diseases, for example, it's not just tertiary care institutions. I love Nikhil, but nevertheless, you have to look at where the missing gaps are, where the missed opportunities are. If you don't pick up your diabetes, pre-diabetes and hypertension in primary care and try and develop efficient referral systems, you're going to lose out at the end in terms of impact. So I think do revolve your programs around that particular area. And next is ensure how this, for the sake of the government approvals, make sure how this fits in with the larger ambition of the government, vision of the government of Viksit Bharat 2047. So when the moment you start saying that this fits in well with the government programs, alliance, you're going to automatically get support. So that would be my few pieces of investment. So
thanks a lot indeed, Professor Reddy, and I'm so happy that colleagues are taking careful notes, so that
and one of the things is we do have strengths. So you have to also show how you appreciate our strengths and leverage our strengths. Right now, India is quite proud, and justly so, of its digital health technologies and the applications in digital health. Do try and leverage our technologies as well and show the world how useful they are, so that it should be seen not as a one-sided initiative, but you're also supporting our investments in this area, but highlighting it for the application at the global level.
Great. And actually, I think your intervention raised a lot of questions I would like to discuss further, but I want to make sure that we have time to hear from all panelists. So I would turn to you, Aisha, Dr. Aisha, with a few remarks, and maybe you are already doing that, taking your sort of current role into consideration, but actually the Novo Nordisk Foundation, we would also like to promote gender equality, and a part of the PEP program is actually empowerment of women healthcare workers. So any advice on how we actually do that, or any inputs to the conversation? Thanks, please.
Sure. Thank you very much. And I have to say that I am also going to be pretending to be as rich as the Novo Nordisk Foundation to be able to comment on some of these things. I would say that I totally align with what has been said already in terms of the government alignment and the country priorities. Women-led development is also very key, and women-led development is one of the key pillars of how we are really going to achieve economic development from the Indian perspective. And we have been talking about investing in research, investing in community health. So what I want to say that while we do all of this, gender integration has to be the core of all of this. We need to be able to invest in gender-based research when we are doing more cutting-edge research for cardiometabolic diseases. We need to be able to invest in gender solutions when we are developing solutions for community health workers as well. And I think overall, what's also very important to understand is that what really matters is impact that lasts long. And this impact that lasts long is really going to come from two broad pillars. One is the institutions, the other is the community health. When I go to institutions, change really happens at the intersection of people and systems. So that has to be the core of any partnership that we build in India. A lot of times what happens is people focus either a lot on policies, programs, or people focus a lot on leadership. So I think we have to continue to ensure that we work at the cross-section of people and systems, because that's what is really going to create impact which is going to last long. Systems change, people change, but if both continue to be there, then it will be a long-lasting impact. And in terms of community health, we work with several women leaders, and over the past 4 years, one common theme that has really emerged is that when these women leaders work with community health workers, they come back and tell us that unfortunately, we look at these community health workers only as resources. We don't view them as community leaders. That's what really needs to happen. We need to start viewing these community health workers as community leaders, and this is what we really like to call as leadership beyond boardrooms. These people are also leaders, and we need to invest in them as leaders, not just only capacity building on technical front. So I think those are some points which I feel are going to be valuable for this partnership to go forward. Thank you.
Thanks a lot, Aisha. Last but not least in the panel, Søren, from a diplomatic and international cooperation perspective, what would be some of the insights you would like to share today, please?
Yeah, that's a good question when I have our ambassador sitting just in front of me here. But I actually did my homework a little bit and tried to look up what did we say in the joint strategic partnership and how does that align with the Novo Nordisk Foundation, and are we aligned on priorities? And luckily we are. So the joint strategic partnership is a little broader. There's the elements in that that doesn't overlap with your priorities, but the main bulk of it is actually aligned. So health and life science priorities and sustainability, which is also quite a big element in when I look at your webpage, at least green transition, which is the bulk of the strategic partnership. Then we have a really good match. Normally, I'm sitting in Bangalore at the Danish Innovation Center. Denmark has 7 innovation centers around the world in global hotspots. So we do a number of projects. We are not doing innovation as such, but we are facilitating innovation. And some of the projects we have, we also are also funded by you. And we would not be able to do that without like a third-party partner. That would simply not be possible. We have a few selected instruments. We have a bilateral call. We have which is every second year, and then we have every half year we have a global innovation network program, and that's more or less it. If we want to do something outside that, then we are dependent on other partners, so philanthropic foundations in general, not only you, but also others. It's really a keystone for us to be operational. Echo Network, I think you mentioned it in your slide, but we didn't. You didn't talk so much about it. But that's a small project budget-wise, which allows researchers, young researchers, to work on sustainability issues in India. Researchers, mobility between researchers between India and Denmark. It's not big projects budget-wise, but it's very consistent. So we have been running it for I think almost 5 years now. So these type of initiatives are not, we would not be able to do without your support also.
Thanks a lot, and thanks also both to you and the ambassador for being here today. And I think that also illustrates that Novo Nordisk Foundation, we are actually also trying to and engaging in aligning with the Danish government, and we also hope that our work here in India and with partners are actually building on that legacy. But aligning with government, it has been mentioned a few times by you and last by you, Professor Reddy. So my question would actually be, of course, for sure, we are aligning with government priorities, but we are also here to catalyze innovation and change. So I think already Professor Reddy, you are pointing a bit at Nikhil Tandon, so maybe you could take up that question. So how as a philanthropist, we have to align, we have to listen in, to align with your global health priorities, but we're also here to maybe catalyze innovation. And maybe after that, if you could comment on that, Soumya Swaminathan. I think you gave a few clues already in your intervention, but maybe highlighting a few more. Thanks.
Thanks, Mette. I sort of partially referred to that when I spoke to you initially, and I think the important thing is discussing with key opinion leaders as you come in. For example, at the moment, there are certain areas which the foundation has taken as important areas for taking forward. Discussing those, broadening the discussion to sort of not only just highlight the problems, but bring in a younger set of individuals who can come up with out-of-box solutions. Trigger initial projects or initial discussions becomes very, very important, because as I said before, anything can be finally systematized you need to start something in a smaller project mode, provide the necessary evidence so that that can then be taken up in programmatic development. And I'll just give you an example outside of the foundation. Work which we've done in digital health really started in that fashion, starting in a research mode, providing increasing more evidence in real world and implementation settings, and then finally incorporation within the government healthcare plan. So I think there is an incremental process which is required, and for that, frugal innovation for a country like India, contextually relevant innovation, again very important, and then bringing the right people who not only understand the necessary domain expertise in technology, but also have a clear downstream vision of what is required. And an example, if it is digital health, clearly technology is very critical, but the solution has to be keeping health in mind. It's not a technology which is going to be in vacuum. So I think those are the issues which become relevant for us.
Great. Thanks a lot, Dr. Soumya Swaminathan. And after that, Professor Reddy asked for a comment. Thanks.
Yeah, so I think, broadly aligning with the national priorities is of course a good idea, but then if you really look at the list of priority areas, let's say that the ICMR has in the area of health, it's a long list. So I think like your focus areas broadly definitely fit, because we have issues of, malnutrition on both sides of the spectrum, cardiometabolic diseases, still the infectious disease, we still have the anemia problem, and then the whole area of climate and health. But what is generally missing, I think, are the environmental risk factors for health, which are becoming more and more important today. So I don't think we can really stem the tide of diabetes in this country or hypertension if we do not pay attention to our environment, to air pollution, to diet, to processed food, and those are much more complex areas. There's no one vaccine or one drug that you can do a clinical trial and solve. It requires interdisciplinary, multidisciplinary partnerships. It requires time, effort, and engagement with a number of stakeholders. And solutions also, there will definitely be solutions, because I'm confident that we can find solutions. But it's going to require innovative ways of thinking and doing. So that is where I think philanthropy can come in. The government agencies it would be difficult for them to fund research of this nature. Yeah.
No, thanks a lot. And actually, you're mentioning that it is something that has triggered us a bit at the Novo Nordisk Foundation, because we look at the research coming out. Yes, for sure. This is where we have to we need more research. However, it's highly political. It's also about financing and taxes. So I have also worked with the Danish Ministry of Health, and sometimes politicians try to stay away. But you are now encouraging us as a philanthropist. Yes, please enter, but maybe on a research basis. That can make it sort of accessible and a platform where we could also work with partners in India. Thanks a lot. Professor Reddy, please.
I'll try to be brief. You're talking about innovations. Innovations can be there in elucidatory science, trying to tease out the causal relationships. Innovations can be there in implementation science to see how best interventions are delivered. But I'll make a strong case for India in the sense that here is a country which not only the largest population on earth, but a wide diversity of gene-environmental interactions. The kind of multiple gene pools, the kind of different dietary patterns, social demographic characteristics, climate. You will not be able to get this level of diversity in the study elsewhere in the world. So global science would be poor if you do not study this and have your algorithms developed for detection and treatment only on selected populations in Western countries. So I believe it's important for you to understand the great opportunity that India offers for studying this, and which will be the pathway for innovations, both for discovery as well as for delivery.
Thanks a lot. And that actually brings me to the second question for the panel, which would be in our collaboration and in creating partnerships with India, how could we take that even to a global level? Do you see potential of working with Indian partners that could also, we also have actually just opened an office in Nairobi, and partnership for education of health professionals is also now being developed and implemented in East Africa. And the same goes for many of our other programs. So we'd also like to take some of these experiences from India, but actually also maybe mobilizing Indian partners to work with us. But actually, you could maybe think about that, because before we enter into that, Aisha, I think you gave a few clues in your intervention as to how both to align with government, and you have also been working with government for years, but then also add this innovation, local voices into it. Please.
I would say that what I have learned in the past 20 years is that lived experiences lead to smarter solutions. So when we really talk about frugal solutions, local solutions, we have to be very targeted in our approach, that who's our audience, and therefore hear from them what they really need in those solutions. And if you're talking in terms of Indian community health, environmental health, we really need to be able to take those lived experiences into account while we are designing these solutions. And the second thing is that I think, like Soumya also said, health, climate, all of these are very intersectional now. So we don't have to be looking at these problems just from a scientific lens. These are now social problems. So we really need a social, multifaceted lens to be looking at these complex problems to solve them. So I think that is what is really going to help us to ensure that we can develop solutions which are local and which are suited for India, for Africa, for other regions as well. But again, bringing in the lived experiences from there as well into the solutions. So that's all. Thank you.
So taking the partnership approach even further, also when we include other countries. So I was just pitching it before, but any insights into how sort of as a philanthropist we could also help India's solution to advance global health research, now I'm being ambitious, globally. So any insights to share? I don't know whether you, Søren, you said you also have innovation centers across the world. I think you're opening one in East Africa soon.
So we are, yes.
But I'm sure also other panelists, maybe also Soumya, having worked with WHO for many years. And actually, I can also share, we just entered into a partnership with WHO that will be announced. Maybe now, but no, it is. Yeah, it will be announced further during the World Health Assembly. But maybe some perspective you after Søren. But Søren first, please.
Yeah, well, so the political part of it, yes, we have 7 innovation centers already, and we're opening up in Africa. So, and we have actually also a project in the pipeline together with India and East Africa in life science-related activities. So we are already on board on that, but I would actually like to support Dr. Reddy a little bit in what India is doing already, because when it comes to digital health solution, I think India is actually way ahead of the rest of the world. Because in my former job, I'm not a career diplomat, I was a researcher before. I've been involved in a lot of telemedicine projects in Denmark that never really scaled. And then I come to India and I can see it's all over the place. You can download a number of apps, you can get online consultation, you can get almost anything as long as you have a smartphone, and it really works, and the scale is just unbelievable. So it works for I don't know how many hundreds of millions of Indians already. So I think India, the way Indians approach these solutions, scalability is like the core of it, whereas in Denmark we start up with a local solution and then we try to scale afterwards, and it always fails. India's really, scalability is really the key, I think, for many of the solutions that comes out of India. And they're designed to be for the global south already, a lot of it. So I think we can definitely learn something there.
Yeah. Great, thanks, very encouraging. Soumya Swaminathan, your perspectives on that, and also maybe, we see a lot of perspective, but then bringing in India-breed solutions in East Africa, and also taking care of their local voices and knowledge being acknowledged. I'm sure you dealt a lot with that also when working with WHO, how to balance that. But please, if you could add to the discussion.
Yeah, so I can give you an example. I was recently in Nairobi at the CGIAR Science Week. And so all the CG institutes were there and a lot of local partners, mostly from Africa, but some from Asia. And there were many panels. On one of the panels, I spoke about digital solutions that our foundation has developed for small fishermen. And this was, a solution that was co-created, an app that's been there now for over 10 years, but it's gone through 54 iterations based on the feedback from the fishermen and the data that they want to see on their app. So it's grown, and it's providing more and more information to them, and also state governments have given their inputs. So, so that kind of participatory research and development. So anyway, when I finished my comments and I came off the dais, I was approached by several people from the audience who represented fishermen associations. And they said, by the time I got off the dais, they'd already opened the app. It's called the Fisher Friendly mobile app. And they said, all of these features is what our fishermen here need. We fish in Lake Victoria. There are 3 countries that, around that lake, and our fishermen are facing challenges now because the fish is going down, and we're often running into fights with each other. The boundaries are not, and you've got all of that figured out on your app. So how can we have access to it? I said, of course, it's all open source. That's not an issue, but you can then adapt it with your own data and your own needs, and then you can, use it. So I think there's, like you were saying, Soren, that there's so much affordable innovation in India, which is very relevant for the developing world. And therefore, I think that's another very big role that the foundation like yourself can play, is to foster those South-South partnerships and create more hubs that are doing South-South work. Yeah.
Great. Thanks a lot. Actually, now my dear timekeeper just let me know that we have 5 minutes left. So actually, I was planning to ask you, Nikhil, to also comment, since you have also been leading global research initiatives. However, at the same time, maybe if you could make a few sort of final remarks, and then I will just take a round of panel. So maybe starting out with you, Nikhil Tandon, then on to Professor Reddy, and then back to Aisha, Søren, and then finishing off the panel with a comment from Soumya Swaminathan. Please, Dr. Nikhil Tandon.
So I'm going to sort of reiterate the issue about having an eye on future scalability even at the beginning of the process. Going way down the road and then saying, well, this is going to work, but to scale this up is going to be well nigh impossible, really takes things away. So that's one. I would actually go to another level out here. We've talked about South-South collaboration. I personally feel that there's a lot which can be learned, which is essential for countries from the low and middle income background, in which you end up using affordable technology and frugal innovation, but the same would actually be equally applicable in a high-income world, freeing money for doing other stuff instead of investing all that money into a sort of high-resource dependent delivery of healthcare. So I would actually look even beyond the South-South collaboration.
Thanks for mentioning that, and I think actually that was also what Søren was alluding to, moving from Denmark to India when it came to telehealth solutions, and maybe the ambassador is also listening in now. But thanks for raising that mutual learning between Global South, Global North. Professor Reddy, please, a few final remarks.
Well, I think there's a great opportunity for collaborations across countries and for dissemination of knowledge, expertise, and even technology transfers. But I think there's an opportunity to use variety of fora, whether it is G77 or G20. Everywhere there is a science element also added to the meetings. So those platforms must also be utilized to project what is potentially transferable across geographical boundaries. So I think we need not worry about people leaving WHO. We can actually utilize every single forum that's available.
Thanks a lot. Dr. Aisha, please.
Yes, thank you. I think I'm going to end where I started, that what really matters at the end of the day is impact, which lasts long, and that is the key. And I have seen that when you scale, you tend to get stuck in the day-to-day, in the management, in a lot of things. and we lose sight of, why we are doing what we were meant to do. So impact is what still really matters, and I think this impact has to be measurable. It has to be really communicated to the world to be able to really inspire more and more philanthropies also to then come join the movement. So I think it has to be impact oriented, and we should not be doing anything which cannot be measured, cannot be communicated to the world. Thank you.
Thanks a lot. And I think maybe that's also referring back to your comment, Professor Reddy, about having some results to show, actually right from the beginning, even though we are building long-term partnerships. Please, Søren, a final remark from you?
Well, I can just, I guess, it's not really an addition, but the advice we give to any organization who wants to establish themselves here in India is that you have to be patient and you have to commit for the long haul. Now you've been here for 2 years, and that's still the honeymoon phase. Still the honeymoon phase, I suppose. There'll probably be a point where some of your board members want to scrutinize what you have achieved, and then I think you just need to have the stamina to be here for a long time. And I think the ambassador is also working to continue the political agreements with India. So we will be here to support you all along.
Thanks a lot, and we are planning to stay here long term, and actually our board of directors are planning to visit next year, so I think also that will constitute another milestone, and I hope ambassadors and others here will also be ready to engage with him. Soumya Swaminathan, final comments. We have also asked you to make a keynote later, but just to finish off this panel, and then you will also be given the floor later.
Thank you. So maybe just briefly 2 points, I think, to add to what the other panelists have said. Taking your partnership further, you could do it with government. So many philanthropic agencies have partnerships with the DBT, the ICMR, the Department of Science and Technology, and so that amplifies whatever the government already is putting in terms of resources into a particular program. If you partner, then you can double or triple or quadruple that grant and have a bigger impact and scale. The other is bringing in other philanthropies and partnering with them as well. There could be some smaller philanthropies. There are many philanthropies now that are looking for guidance and for partners. And for larger ones like yourselves, who can invest more in priority setting, developing strategic thinking and an agenda. The smaller ones would be happy to join if their overall thinking aligns with what you've done. And so I think you can also be a magnet and encourage more people to actually do philanthropy for science.
Thanks a lot. I'll not try to summarize right now. I think we have been exposed to a wealth of insights, some very nice discussions. I'm sorry that we did not have time to include the audience. You have been listening in patiently. I hope we can continue the dialogue with you. At the Novo Nordisk Foundation, we are really always open to dialogue, discussions, and really to develop our presence and programs in India in a collaborative spirit, not only with government, but also partners, experts, researchers, etc. And I think many of you present here today. So thanks a lot. I think we should give our panelists a hand, and then I'll hand over the stage. Yeah, Monica, just have a token of appreciation. It's no, I should not reveal what's in there, but there's some nice history lessons as part of it, and even a love story, I guess. Yeah, so thanks a lot. Another hand of applause. Thanks. So I could just ask the panelists to stay here, and then ask Dr. Soumya Swaminathan to give a keynote. I think, yeah, you are free to share whatever. However, we were hoping to hear more about how you see the roles of philanthropists in creating partnership for science and health. Please, I think we have around, is it 10 minutes? Yeah, 10 minutes.
I can give up some of that time if you want to open it up. That might be more interesting.
Yeah. Yes. yeah.
Serious. I don't think a keynote from me at this stage. We've discussed a lot. Let's have a discussion.
Yeah, no, but that's what an invitation. So, yeah, good. So I'll facilitate, and you're welcome to ask. Also, I think colleagues from the Novo Nordisk Foundation, like Monica and Jakob, are also open for. But please, any reflections from the audience? Yes, we have a brave gentleman here. And are you running? Good, perfect. Thanks. And please introduce yourself and
Hi.
where you're
Hi,
from.
everyone. I'm Dr. Bhavna Bakshi. I'm National Program Manager from Japaigo. So, as Japaigo has been working for pre-service education, specifically in nursing sector, since last 15 years. So, I'm really looking forward how your foundation and all the experts will be looking at. Especially, we are in the time when the Nursing and Midwifery Commission is going to come up, and lot of reforms are in place, and we really look forward to meet all of you and want to understand how and how, because one of your key the topic was that where you are interested is the education. So we look forward and see how we can collaborate together here, a lot of partners to look forward how we can improve the professional, because nurses are the back of a lot of health sector work that has been going on, and COVID has proven that. So we're looking forward for that, and Japaigo is going forward and supporting the reforms at the national level, and looking forward for your foundation to support it as much as you can. And the research, I think, is going to really help us in the longer run.
Thanks
Thank
a lot. I think we can take a few other comments, but I just want to thank you for mentioning nurses, because I don't know whether it came out clearly, but in Partnership for Education of Health Professionals, actually nurses and the nursing profession constitutes a very important part and is the focus of that program. And now, since I have the mic and are free to talk, I would also like to make a small advertisement. Tomorrow, we have another session hosted by the Novo Nordisk Foundation, which actually have a focus on nurses, nursing profession. We are hosting it together with the PHFI, who are also present here today. So please join us again tomorrow. And at that time, we will have a focus on nursing and many of the issues that you just highlighted. Anyway, a few other comments or questions to Novo Nordisk Foundation or the panel,
yes,
please.
To the panel, first of all, it's wonderful to hear this amazing panel. So in the panel, we spoke about primary care, strengthening primary care. I'm Divakar Mittal, I'm from Novo Nordisk in India, and we do a lot of work at primary care. So one of the learning is when we are developing primary care, community participation is very important. So, but it's also very difficult because we have so much of diversity all across. So when we are scaling it up, the primary care. So my question is, what are those bare minimum thing from a community participation as a model which one can take, which could get replicated, for example, in Tamil Nadu, Andhra, or Northeast, everywhere, those bare minimum thing, if I have to think like a model actually.
So we are really getting into a detailed question with all these public health experts in the panel. I think that could take another panel discussion. But maybe one more question or comment, and then I'll hand over to the panel.
Many congratulations for these wonderful initiatives. I am Kumar Saurabh from PATH. So based on my ground level experiences, I want to say that there is one opportunity where the NNF can add value addition to the India, and that is food safety component. No one is talking about the food safety, and I think no agencies is working at the implementation level. Only I think WHO is working that too only at the country level, not below than that. And even in the ICDS, in the school meals programs, the children are getting the protein, but the quality of protein no one is testing. Whether it's how much they are absorbing, and even in the ICDS also the quality of proteins. So I think this is another area, food safety, where you can add value addition and can have a larger impact. Thank you.
Thanks a lot, and I'm actually happy to let you know, if it was also not clear from the slides, that food safety and nutrition is definitely within our priority areas at the Novo Nordisk Foundation. Today we also have friends and partners from World Food Program present here, so even maybe the two of you can also talk later, but or maybe a comment from you what we are doing in that field. Would that be okay? Yeah.
Thank you very much, and hi everybody. My name is Nozomi Hashimoto. Thank you very much for giving me the opportunity. So WFP and Novo Nordisk Foundation has been in conversation to start up some research initiatives here in India. And that includes how to contribute to the healthier diet in India, but through the already existing public schemes that includes the PDS, also the midday meals, especially the school feeding, and that can also, be used both the diversification of the food, education for the children on the healthy diet, and then also to stimulate the local economy by using the locally produced healthy food. So it's going to be a long journey, I guess, and I'm sure that such a big goal can be only achieved with all the partners involved to work together. So looking forward to start the initiative, and thank you very much.
Thanks. So we have been very involving the audience here, but I won't leave the panel just sitting here. There was an interesting question or comment about primary health care. And sometimes I'm also thinking, okay, our investments in education of health professionals, how do we actually take it to reaching the last mile? How do we really go, how do we have an impact on the quality at the primary healthcare level, especially when we talk about reaching vulnerable population groups, underserved areas? So maybe I'm twisting the question a bit, but comments maybe from Soumya and Dr. Nikhil Tandon as well? And Dr. Reddy, I know you can give a lecture on this topic.
Yeah, it is a very big topic. But I think you are talking about essential elements, and it's again listening to the people whom you're trying to serve. I think it's as simple as that. Very early in my career, I learned that as a researcher, you go in with some preconceived notions of how you can actually improve things. And if you sit and talk to the community, then you're very much humbled by what you hear there, because their priorities are quite different. And if you go in with a siloed, your thinking, based on whatever your research interest is, as a researcher, you always have a particular thing that you want to do. But the community actually has a completely different set of questions. So I think the most satisfying kind of research, I think, is where you are participatory from the very beginning. And especially if you're developing solutions to very complex things, like somebody talked about food and habits and behavioral issues, then the insights have to come from the community. The solutions very often will come from the community. This is true for climate as well. We don't have to reinvent some things that we already knew and that we might have forgotten. Unfortunately, in our curriculum and our medical school, we don't have enough exposure to that level of health care. And so most of our exposure is in secondary or tertiary care hospitals. So that is something I think that needs to change, because we're not actually producing doctors and nurses who are fit for purpose to deliver comprehensive, good quality primary health care.
Dr. Nikhil Tandon, representing sort of a center of excellence when it comes to education of doctors and nurses, but also having an obligation to reach the poor and the underserved areas. What would be your comments on this?
So I won't repeat what Soumya said, but looking at it from a slightly different, wearing slightly different hat. So you want to do some work, and you think as a researcher you've come with a solution, and you will then go to a state government and say, well, we've looked at this problem, we think this is good for you. And the state government will say, every other year somebody like you comes and tells us, this is what you need to do. Have you ever bothered to figure out, did you A, think that we're stupid and we didn't know what needs to be done? And secondly, did you ever bother to find out why we haven't been able to get it done? So I think it's not only the end, which is the consumer, which is obviously the recipient of care, but also the people who are delivering the care. You need to understand their problems. You need to understand, if they've not been able to devote time, money, and resources for a certain vertical part of primary care, why is it that it's not been possible? So I think that is equally important in this whole process.
Yeah, thanks a lot. And I think it was also mentioned by you, Professor Reddy, about implementation research, because actually that is also what I think is being referred to here. So any comments from you?
There are a number of programs which have been well intended and well designed as well, but not well delivered. And therefore, it's important for us to find out where the disconnects are between the different agencies that are actually involved with delivering variety of services. What are the disconnects between different levels of care, And this you get the feedback from the community and other stakeholders there in the community. You do need not only quantitative research, but qualitative research, mixed methods. And then the important thing is then to find out how the solutions can be found to remove those disconnects. But again, a good deal of wisdom will come from the community itself, because they know what needs to be done and at what scale. And I think therefore it's important for anybody dealing with primary care to firstly try and bring about a greater degree of synergy between the various service providing agencies, ensure different levels of care are well connected, and also ensure that the community is aware of what the services that are promised to them are, what are being delivered, what are not being delivered, and then have them also talk about how solutions can be designed and implemented to improve those services.
Thanks a lot. And Professor Reddy, you are a cardiologist by training and heart, but you're also truly a public health expert by heart. I think this answer really proves that. So thanks for your insight. I think we are really coming to a point in time where I again would like to thank our panelists and also Dr. Soumya Swaminathan. Thanks for leaving your time for a keynote actually to engage with the audience. I really like that, and I would like to encourage you also to stay on for a while and engage with each other, and you're most welcome to ask any question to me, and I'm sure also maybe the panel if you're available for a few minutes, but thanks a lot, and thanks again for all of you for joining us today. It has been absolutely wonderful to have you here. I'm sorry it was so crowded, especially at the back, but I can surely say that we are here now. We were welcomed 3 years ago by Principal Scientific Advisor, Professor Reddy and others. We will stay on. We are here for the long term, and as was also mentioned by my colleagues, we are looking forward to see our program and portfolio developing. We have copies of our engagement plan and portfolio ready to share. But thanks a lot. Thanks again to the panelists. Thanks to the ambassador for joining us today, and thanks for all of you for joining today. Have a nice summit.
one of our panelists to chair the session, and I would take this opportunity to introduce Dr. Anant Pandhareji, who happens to be a very senior orthopedic surgeon and also a hospital management specialist, a person who has touched more than 1 million hearts through the work that they have done at Aurangabad, and the hospital that he has started, Dr. Hedgewar Rugnalaya, and now which has also added Sri Ramchandra Medical College to it, and has many other paraphernalia like Savitribai Phule organization, which is working at the ground with a lot of ground level healthcare workers, and then human resources, especially doctors. They have engaged through an organization called Seva Ankur for motivating human resources in health. It's a really big pleasure to have you, join us in this session, sir. And may I also request you to chair the session on behalf of Dr. Harshvardhan. Big round of applause to Dr. Anant Pandhareji, sir, please. Sir also happens to be the chairman of AIIMS Nagpur and also the president of All India Red Cross Society. May I also now take the pleasure and privilege of introducing one of the persons with whom we have worked very closely in Hyderabad, who happens to be none other than Dr. Srinivas, the director of AIIMS New Delhi, who is a pediatric surgeon, many publications, very good surgeon, clinician. Apart from all that, again, a very good administrator. We have seen how ESI Medical College in Hyderabad were transformed from a hospital where everything was a bhoot bangla, and then that was transformed in 6 months to 1 year into an excellent teaching hospital. And we know the kind of challenges he has faced there in Hyderabad and the kind of difficulties he was facing when he was actually ensuring that the hospital comes to fruition. But then he's a great administrator, great academician, and also great team leader, inspirational. And we're really happy that Dr. Srinivas has joined this panel. We welcome you, sir. Big round of applause. Over to you, Dr. Abha.
Thank you. And I now want to introduce and welcome Dr. Kochhar. She is the former head in Department of Physiology and has really led the initiation of the medical humanity initiatives at AIIMS Delhi. Ma'am has been a mentor and an inspiration for many years. So ma'am, please, a big round of applause for Dr. Kochhar. Ma'am, please come here. Our next panelist is Dr. Pankaj Arora. Dr. Arora is Director, HPQA Division in the National Health Authority. He's a surgeon in the Indian Railways and has actually got a master's degree recently from the London School of Economics in Global Health Policy. It's a real privilege to have you join us, sir. Please, if you can come. Dr. Santosh.
Thank you, Dr. Abha. Again, it's a privilege to introduce Dr. Nalini Mohan, who happens to be a civil servant, Indian Forest Service, but very long years he has worked in the healthcare sector, especially as Secretary Ayush. He has motivated, inspired, and catalyzed the work of Ayush workers in the combined state of Andhra Pradesh as a bureaucrat. He also has a rich history in bringing the biotech park. You call the Bharat Biotech, the vaccines, and all those big companies. The industrial park has been set up by him. And we really are so happy that he has joined us panel. And he'll also share the perspective of patients and human resources for health, the patient perspective as well. Thank you so much, Dr. Nalini Mohan, sir. Very warmly welcome you. Big round of applause for...
Thank you. And our last panelist is Ms. Minara Chaudhary. She has joined online. I want to confirm with the organizers that she's connected. Can you confirm? Minara, are you able to hear us? Minara, may I confirm if you are able to hear us and if we can have the Zoom set up on the screen? So while we are getting the IT set up, I just want to introduce her. So Ms. Chaudhary is a senior director in the Institute for Healthcare Improvement. It's an organization working for more than 3 decades in quality of healthcare in the US. Ms. Chaudhary has worked for many years for the Hamad Medical Corporation, Government of Qatar. She was also the country director for IHI in Bangladesh. She's currently located in London. She supports IHI's work in Europe, Middle East, as well as in South Asia. So it's a real pleasure to have you join us, and I hope you're able to hear us now. I'm confirming if you're able to hear us.
Thank you, Abha.
Yeah, thank you. I know you are not able to see in the room, but let me be your eyes to the room and you can hear my voice, so we will involve you and we'll bring you in the discussion. Okay, and my last panelist, of course, is Dr. Santosh, who I've already introduced. So Dr. Santosh, may I please invite you to come and take a seat on the panel. So we'll begin with opening remarks, and I want to invite the chair of our session, Dr. Anand Pandare. Sir, if you can please tell us, in your words, what is the ethical, strategic, and societal urgency for addressing and prioritizing healthcare workforce well-being? So may I invite you, sir?
So, thank you, Abha, and thank you, Dr. Santosh, for inviting me in this unique session. And I invite all the panelists and the great people on the dais to participate in this very unique subject. In fact, this should be, and this is the heart of the medical service and health services. We only speak about health services in terms of people-intensive industry, and we require more of a manpower and service industry. And this is an industry where, or this is a sector where we have to create our product on the spot. They call it as a moment of truth. That when a patient comes in front of a reception counter or in the cabin of the doctor, he just can't keep everything ready to answer him. He has to produce those answers on the spot based on the question, worries, queries, and everything. So we need to be very trained, all healthcare workers. We need to be very composed. We need to be at peace. And we need to be in the shoes of the patient when we deal with him, when he comes across us. These all 4 requirements are very challenging. So we always say in our country, in our Bharatiya Parampara, that the sadhan, that means the medium which we use, we are a medium. We acquired knowledge from a lot of our teachers and ancient innovations and everything, and now we are skilled to deliver it. So we are a medium of service, and the medium has to be equally nirdosh, equally pure, and very well skilled. So who is treating is more important. Unfortunately, today it is not at the helm of affairs. So who is treating? Who means what kind of human being is treating that patient? Whether he is at peace, whether he is spiritual, whether he is looking at a patient as God, whether he is looking at a patient as a customer, or somebody who is going to pay me a lot. So it depends. Even if you are a very skilled cardiac surgeon, a pediatric surgeon, a physician, what kind of human being you are, and what kind of human being is decided over a period of time. Like in this session, we are redeeming the spirit of medicine. So I am very eager, myself very eager to listen from all the esteemed panelists, their views, their efforts they have taken in rediscovering or rekindling the spirit in the hearts of the many health workers. What are the processes we do, where we miss, and then summarizing it everything, hopefully that we go back and implement it and let our country be the pioneer again in this field of rekindling the spirit of medicine and bringing back the joy in working. So instead of giving inputs at this moment in this subject, I would really love everybody to speak and contribute in this matter. Thank you very much.
Setting the context and bringing forth on how do we really restore the spirit of medicine. So to give a brief background, I'll do a brief presentation followed by Dr. Santosh Krileti, and then we will open it up to our panelists to share their views, and we will keep adequate time at the end. We really want to hear questions that come in from the audience, so please do think about the questions that you have in mind. May I request for my presentation to be uploaded? Yeah, I'm sorry, the panelists will have to turn, but yeah, it's very brief. So may I have the next slide, please? Surely, sir, surely. So really reflecting on, is there a need to change, and really what is the case we want to make on why we need to change the current status quo? And I want to start by showing you a very brief video. May I have the next slide, and can please play the video?
So once we've assessed and we've asked what matters, we need to go a little bit deeper to really understand some of the impediments to joy, which again can vary by context. So here's some of the things that you might find. Some barriers to joy might include concerns about your physical safety. We know that healthcare workers, particularly nurses, have very high rates of acute and chronic musculoskeletal injuries, high exposures to bloodborne pathogens and other infections. And across the nation, we're seeing increased incidences of unnecessary and unfortunate gun violence. So are any of these physical threats an issue in your environment? When somebody leaves at the end of their shift and it's dark and they're walking to their car, do they feel safe? And do they feel like adequate precautions have been taken to protect them? Psychological safety. Do people feel safe to ask questions, to speak up, to admit that they've made a mistake? Are people safe from bullying or harassment? We'd like to think that that doesn't happen in healthcare settings, but I know some of us have witnessed that. Equity. Do people feel that their work environment is fair and just? And that could be anything from pay, equal pay, to promotions, but also just feeling like their voice is heard as much as the person next to them. Camaraderie. Do people feel like they're part of a team, part of something bigger? Do people feel like they have some choice in how they execute on their daily responsibilities? And ultimately, do people have meaning in their work? Do they feel connected to that higher purpose? So as Derek pointed out, the relationship to Maslow's hierarchy of needs, others have plotted these against that hierarchy. And what this reminds us is that the things at that base of the pyramid, sometimes that represents first things first. And so if we don't first attend to things like physical and psychological safety, we may not be able to help people get to connection to meaning.
So using that video as a spark to this discussion that we want to do, as a provocation to this discussion, I'm a healthcare professional myself. I'm a pediatrician, and I've been on all the sides as a medical student, as a young resident doctor, as a treating consultant physician, but also on the other side as a patient and as a family member. And really, if the healthcare workforce themselves are not filled and have enough to give, it's very difficult for them to give to their patients or to their healthcare providers. And yes. And as a part of a healthcare team, and I do not know how many healthcare providers are in the audience, but you would agree that if may I have a show of hands, how many of you currently work as a healthcare professional? So there are just a few, maybe 4, 5. Yeah, few more. So we would love to hear your experiences when we open it up to the audience. But I have also felt at different points in my career, feeling marginalized and consistently not able to speak up and not feeling safe to speak up, whether I want to voice a concern or if I want to even admit a mistake that I have made. So what does the research tell us? Of course, we have this anecdotal experiences that we have from ourselves, but is there more science behind this? And we find that both in the global literature, but I will also show you Indian data, that there is a big problem which has been identified by the National Academy of Medicine and Sciences in the US, as well as in the 2022 US Surgeon General came out with a report where we are finding that 400 physicians die by suicide each year. And this rate is twice as what we would see in the general population. 24% of ICU nurses report that they have symptoms of post-traumatic stress disorder. Physician rates of depression are at an alarmingly high rate of 39%, and 20 to 30% of primary care nurses have said that they have emotional exhaustion. So these are very alarming statistics. Last year, the National Medical Commission actually did a survey of 50,000 healthcare providers. This is after the horrifying incident that happened in RG Kar Hospital in Kolkata. And as a part of the survey, and I'm just showing you one sliver of that data. So when they spoke with postgraduate medical residents in India, they found that 84% of them reported that they had moderate to high levels of stress. And they said 64% said that their workload significantly affects their mental health. And very alarmingly, 1 in 3 said that we had suicidal ideation within the last 12 months before the survey was conducted. And while we know that the National Task Force recommends a work week of 74 hours per week, which is to contain the number of hours healthcare workers work, this is still quite substantially higher than what we see in other professions. And recently, when we had COVID, it really exacerbated this problem, which was always lying under the water. So we only saw the tip of the iceberg with the pandemic. And we found a lot of evidence that came out with people reporting emotional exhaustion, increased mental distancing from our feelings, and even attitudes of negativity related to our job, and reduced feelings of personal accomplishment. So reflecting back on the Maslow's hierarchy of needs, as we saw in the video, really, first things come first. We really need to make sure that the physiological needs, adequate rest, sleep, food, that needs to be taken first. Secondly, we need to be physically and psychologically safe in the environment where we are working. Third, we need to have the culture where we have teamwork and camaraderie, where there is a feeling of belonging within the healthcare system. And that eventually will then lead to self-esteem, and only after that will we be able to have self-actualization and do everything that is required for our patients. It's going to be very difficult to ask healthcare workers to do more when they themselves may not have enough to give to their patients. So I actually wanted to start the panel discussion with this provocation, but I just also want to very briefly also bring in a little bit of hope that there is a hope on how we can solve for this. And then we will, in the panel discussion, contextualize this to the Indian context and see what the experiences are. So I very briefly want to introduce IHI's framework for joy in work, where there are 4 steps where they actually start with what matters to you conversation. Speaking with staff and really understanding, local to their context, what are the pebbles in their shoes, what are the barriers to joy, and then use those impediments and the information around that to really work with leadership at all levels to have a commitment to addressing those barriers and then systematically using the science of improvement to address them in a systematic way. And this is just a very brief overview, and during the panel there will be questions and we will be hearing more from our panelists about that. But this joint work framework really looks at 9 key elements, and there's a lot of literature that's gone into why these 9 key drivers have been selected. And they include some of the things that we've already heard. How do we create an environment which creates physical and psychological safety? How do we get healthcare workers to reconnect with meaning and purpose in their work? How do we give them more choice and autonomy in how they're functioning? How do we have more participative management and recognition of the work that is being done? How do we imbibe a culture of camaraderie and teamwork? And also, how do we really measure it? Can we measure burnout? Can we measure well-being? Is this something that's an important indicator? And then how can we use that information for daily improvement and really support our frontline workers to have wellness and resilience? So with this, I now invite Dr. Santosh Krileti, who is also very briefly going to talk about this topic, to help us anchor the discussion before we move into the moderated panel discussion. So may I have Dr. Krileti's slides put up?
Thank you very much, Dr. Abha. My slides are much more simpler, and because we have so much that we have already seen in terms of data already, and what Dr. Abha just has shown, we have seen in a study in National Medical Commission. And when we did a survey, we were quite startled for the first time that, you know, something of this sort is there existing in our system. And we did that only because, you know, because of the big trigger that we had in RG Kar Hospital in Calcutta. So if you look at a couple of things, I would just like to take all of you back to probably, you know, many youngsters wouldn't have watched, but then probably people who are around 35, 40 would have seen something called, heard of Jadoo Ki Jhappi. I'm sure you would have heard about Jadoo Ki Jhappi, and you would have seen that movie where Sanjay Dutt goes and hugs many workers in the hospital. Do we have that kind of an environment in our systems, in our healthcare systems? Or, for example, when we work with a lot of house surgeons, postgraduate students, they're so stressed up. So many workers. And we know that they're doing the job which is sometimes, many times, thankless. After doing 72-hour work, probably someone is attacking the doctor or the postgraduate student in the ICU or probably in the ward. And we have seen this sort of cases. And very recently, what happened? I'm sorry? Slides. I can change it, right? Yeah, thank you. I have only 4 slides, so yeah, thank you. So you see that many times, very recently in Telangana and in Andhra, we have 2 medical students who have committed suicide just 1 week back. 1 week back. We don't get headlines and we don't observe what's happening. And many times the stress levels are very, very high. And the reason, I know myself as a medical college student, and with one of our superintendents with whom I worked, she said that I couldn't breastfeed my child. Why? And she told me that within 1 week after my delivery, no one told to breastfeed, but everyone asked me to come back to work. She was a housie at that point in time, and she was doing houseman job, and that was the situation. So the kind of stress. And she said that only in her second delivery, when she was in a proper, she finished her MBBS, she went with her husband wherever he was working, that she could breastfeed a second child. So this is the kind of stress levels and this is the kind of work ethic that we have. And we don't talk about it. Many times we don't talk about it because as a country, you know, most importantly, we have a family to many times to support us. But for those people who don't have a family to support, or probably who don't speak to their family, what kind of probably stress or trauma that they're undergoing. So I think it's very, very important to understand the nuances what Dr. Abha has just put forward. I will just take you to this slide. Culture of 3 C's: compassion, care, and cheerfulness. If a hospital has someone probably at the top leadership level, and this is percolating down, who smiles, who welcomes everyone, and probably that will have a ripple effect. And the compassion and care and cheerfulness is something, if we give, if we sow this, that's what we'll reap. Everyone comes out with a cheer, everyone comes out with care and compassion. So how compassionate is our work environment in our hospital, in our healthcare system? I think this is very, very key. Is there someone like this doctor who is hugging his healthcare workforce, not just doctors in his hospital, but everyone around, and empathetic, not just sympathy, but are they empathetic? Words turning into actions. And just look at this person, just look at the smile on his face. Can we bring that in our workforce? And how will your patients be treated if your workforce is not treated well? So how do we need to treat our own workforce? How do we take care of them, and what do we do? And I think that is what is the essence of, redeeming the spirit of medicine. Yeah. And I would like to show this small video. Can we play it? Just look at her innocence, happiness, and how she's feeling the words that are being spoken. Can we have this sort of a time in our hospital healthcare system where we can reflect, where we can pray, where we have a spiritual corner, where people can go and sit, talk to someone, speak their emotions, and you have this sort of a system in place? Thailand has a very unique system. They have in their accreditation spiritual quotient. No other country in this world has. And Bhutan has started very recently. So can we bring this into our healthcare system? And we know someone in the panel has taken that to Bhutan. So just look at this. You can play this. Thank you. Thank you so much. And over to you, Dr. Abha.
So now we'll hear from our panelists, and we'll really get to hear what their experience and views are. May I start with you, ma'am, Dr. Kochhar? I heard you say once that joy is such a spontaneous emotion, and I truly agree with it. But it's really getting lost in the healthcare. With your 4 decades of experience as a teacher, as a practicing clinician, as both a wife to another clinician, can you please share what you have observed and what you're seeing in our healthcare system right now?
Yeah, so I would like all of you to imagine that little girl who was so full of joy, spontaneity, enthusiasm, zeal, and very organically connected and what we call immersed in that prayer. How many of us as young doctors retain the same kind of spirit of exuberance with the vigor, with the verve, with the vivacity? So that is, I from AIIMS, I have been teaching here for about 42 years now. we get so-called cream of the cream. We get, I mean, it is one of the toughest screening examinations where lakhs compete and one would get in. And it is the duty of us medical teachers that through their navigation of the journey to become a good doctor, and when I say a good doctor, mind you, as Santosh also said, we don't mean the KPI should only be, the metric should only be the marks. They are for that entry level, okay? But now we would like them to retain, to redeem the paradigms lost. No, they are so happy and enthusiastic, sir, when we have the orientation session with them. They are so creative, they are so joyful, if I would say, and it is the charge of a medical teacher to see that the smile is there, though it may be at the corners. But you know, and then what Dr. Pandhare said was a very important thing, कि अगर हम ये सोचें कि हम साधन हैं और patient is our God, and the act of whether we are learning to be a doctor or whether we are delivering health services. And when I use the word doctor, I mean healthcare provider. I mean also the lab staff who smiles at the counter when a critical report is being given. Many times we can't change the outcomes, but the process has to be there, and India is, as sir rightly said, is the pioneer that even Abha would know when we are talking of palliative care, to retain the dignity of dying. The outcome we can't change. So as a medical teacher, my charge would be, A, to see that the smile and the joy, like we had that little girl, is retained. And second, it becomes something very, organically, as an outpouring of love and affection for your patient, for their family, and also for our colleagues, so across horizontals and verticals. There is no unch neech. Many times I tell my colleagues कि AIIMS आपको भी तनख्वाह देता है, मुझे भी तनख्वाह देता है. So nobody is the boss and nobody is the servant. We are all for a common cause, that is to heal the society, to heal the country, and improve the health literacy, and also the word health economics, functional outcomes, both of the patient and the doctor. And the general ecosystem would improve if we find more joy in our work and we don't get into the nitty-gritty of things like he earns more than me, her sari is more beautiful than mine, no, or her nail polish is more beautiful than mine. So style quotient apart, the spiritual quotient is which will bring a sense of glow and a smile, and that would be sustainable and eternal. Thank you.
May I ask you a follow-up question? A few weeks ago in a webinar, you shared a story of one of your students. Could you retell that story to the audience here?
So, taking from what I already said, Gaurav came very enthusiastic to us, but then Gaurav had problems. Gaurav was, if I would say, unique, and maybe many of us may say he was odd. We use stigmatizing terms. The lexicon is such that we deal with a lot of stigma as doctors. Even I remember mine, Abha has also shared her story. थोड़ा सा भी अगर हम dress sense में, बातचीत करने में, if I say namaste and everybody says hi, maybe I'm considered odd. So he was being singled out or being, as they say, othered. And he used to come to me and I used to tell him that, Gaurav, diversity tolerance is the first thing which we see in patients. Thankfully in AIIMS, in the beginning, the students came from many walks of life, from many states, different cultures. And the initial transition period is when they need a lot of hand-holding. Sometimes we call it having a bike with support wheels, and dheere dheere phir teachers get away and the student takes it on his own, because so many taboos they break. In the dissection hall also, they are seeing cadavers, and normally there's a process that students of age 4 or 5 are asked to shun from excreta, to shun from body fluvium, and here young students in their first year, second year, third year of medical school have to deal with sputum, with stool, with urine, with semen, with pus, with gangrenous limbs, and so much, is there, and whether they retain that identity of self. So Gaurav was being supported, and we also said, Gaurav, this is your mission. This is now the culmination of all the midnight oil which you have burnt all these years, passing class 12, cracking the AIIMS entrance, and now this is the time when you should enjoy. And then we all know that when we reach one destination or one goal, the journey begins to the next one. So then Gaurav was getting some support, and I think then he made it his mission, and I tell many of them that if you have been taken care of, you have been mentored, it is your duty. And then he comes to me after I was his mentor. Then after 2 years he comes to me with another young kid who was in great distress. Ma'am, isko hostel khali karwa rahe hain because iske marks अच्छे नहीं आए, 2 बार fail हो गया, निकाल रहे हैं, and things like that. So then we used to all of us get into this with the student union. Director sir say unka discretion pay, compassionate grounds, and this, because many of us are having very unique situations, in life, in society, in family, personal health, psychological health, financial health. And then Gaurav comes to me with this child, ma'am, isko aap sambhaliye, and then he says, isko na ghar mat jaane dijiye, क्योंकि अगर अपनी फैमिली में गया इसको डांट पड़ेगी and he may commit some act of self-harm, यहाँ हम सब संभाल लेंगे. So I really found that very reassuring, that is fostering a culture of care and cheerfulness yet has some time to come, but at least care and compassion are quite robust there. And then it is like this, that one who has been saved takes it upon himself or herself to save so many others. I think we got the hang of the general story.
Thank you so much, ma'am. Thank you so for beautifully bringing out the kind of mental distress, both personal but also because of the way medicine is designed, brings out in some of us, and how we really need to have a support system which helps save Gaurav. That's not his true name, but also the one who gets saved also then reaches out and tries to save others. And I think that's quite profound. Sir, may I ask you the next question? You've really been a leader, leading an institute in Hyderabad, but now leading AIIMS Delhi. In your experience, and you've also gone through the journey of a medical student, clinician, and now a health system leader, in your own lived experience, what are some of the key triggers for burnout and stress that we see within the medical fraternity?
Thank you, ma'am. First of all, namaskar to all of you. Thank you, Dr. Santosh ji, that you have been kind enough to remember us right from Hyderabad. Well, when I look into the topic today, I have 3 things to do. One, spirit of medicine. What is the spirit of medicine? For me, the medicine is, there are people from the community medicine here and the health leaders, the world health leaders, physical health, mental health, social health, and spiritual health. That's why the people like our teachers like her are bringing the spiritual health to the medical students and doctors in the institutions. So that's a component of the spiritual, the spirit of the health. Now, what is the joy of work? Sir talked about the inner peace, inner joy, and we have been speaking about that, consider the patient as a god, and then service as a god or something like that. So if we have that, the patient is my god and it is the best of the treatment which I have to give, then there is that joy, inner joy, that's definitely there. But definitely there is challenges for us in the institutions, in any institution. It's not just the medical college. In most of the hospitals, we have deficiencies, whether it is human resources deficiency, equipment deficiency, workload is very high, burnout is definitely there. What can we do? We can't look into the country and say that, we have less number of doctors, nurses, technicians, and we stop doing our work and say that, my job is over. I will not do more than 8 hours of the duty in a stretch, and I would not do 24 hours more than that. Then it is not going to happen. That means, before we think of how we can change the ecosystem, is there anything which we can have the resilience within ourselves? the joy of work again. If we think that way, then instead of abandoning our duty, not looking into the work-life balance and all that, you have to balance to the life, there is only life. It is our life and the patient's life. So it's a work is always there. The balance is always 100%. We are doing only work because the work is giving the life to the patient. So that's the work-life balance for us. And then those who are from the Karnataka, if you go to the assembly there, it's written Kaya Kave Kailasa, this great Sir Vishweshwaraya's saying, which meaning to say that, the work is worship, If we take that work as a worship, saving the patients, have the joy inside to give that health, then I think we will be balancing initially until and unless we get into that kind of increase in numbers of all our ecosystem which is there. The other thing is that, being a doctors, definitely we are always exposed to the more work. We need to distinguish between what is that. The stress is, I think, physiology professor is there. We have been our students, and she is our physiology teachers at AIIMS. We need to distinguish between what is eustress and distress. If I work, say, more than 72 hours, if I save some children, if I am able to save some lives, it's a eustress. I'm happy that, I go home or I go to the hostel and I come back to the teachers, parents, and say that, well, I did such a wonderful surgery, I saved someone, but you don't feel that you have worked 24, 48, 72 hours. So somewhere we need to distinguish and then, bring that stress into the eustress, put it to the positivity, and then say that, we have been happy. Because we can't, go into the ecosystem. It's not going to change in one day. We need to be, adopting to the things, whatever is there, and feel happy about it, and then do that, get the motivation from the great people. There are people who are motivation for all of us here, every one of us, which in different streams or something. The burnout is definitely a problem. In the institutions, we have ecosystems. For example, for our undergraduate system, the students, we have a wellness clinic. Unheard of, the wellness clinics in medical institutions for decades. Madam is part and parcel of that. It has everybody. It has the medical teachers, the first MBBS teachers. It has the senior students. It has a psychologist. It has a psychiatrist. And then it is 24/7 at the hostel. And then anonymity is maintained, and then they are taken care of everything, whether it is the social support, the mental support, spiritual support, or the psychiatrist and psychologist who is going to give that. That's the component which we are giving it to the students. The other thing is that how do you make them cheerful, especially the students. Now we're talking one by one. We're talking about student first. We have various festivals which are happening. Unfortunately, the market forces and the feeling in the students today is that if we do one big event costing 2 to 20 crores of so-called an annual event and do all wrong things and feel great about it, now we have cut down into that into small, weekly, monthly, small activities. It could be any domain. It could be art, science, sports, music, dance, whatever it is. Any weekend, when I'm going from the office, I see somebody, going to the auditorium these days. So that is the cheerfulness. Cheerfulness and happiness cannot be in 1 week of one whole year for a student. Give that small bits of pieces of the cheerfulness and the joy to the students. Maybe in a day, maybe a weekend or something like that. We are taking care of the students in the AIIMS New Delhi. Then comes the staff members. What is that staff members? What they want is their rights. Somebody doesn't get promoted well on time. Somebody doesn't get salary on time. Somebody doesn't get their increments on time. Somebody is discriminated because of something, caste, creed, religion, and all that. Somebody feels that, the system is not transparent. So we are giving that good governance and transparency and the rights to the people, the staff members, so that they feel proud that now I'm happy, let us be happy to work more, and then give the best to the patient. So if unless and until I am happy as a medical professional, I will not be making patient happy. My stress and strain will go on to the patient. Efficiency will come down, competency will come down. I will be totally, rude to the patient. And most important thing, madam will agree that, Jadu ka jab bhi said, that what you need is not the medical knowledge or skills. It is the compassion. So unless I'm happy, I will not be able to give that compassion. And look into the faculty levels again. The faculty levels again, what is that the thrill we get as an institution? We talk about the finances. We can't change. As we can't change the ecosystem in the country with numbers, doctors, sisters, we can't produce them in one day. Our patients are not going to come down. The diseases are increasing, in fact, paradoxically. So what is that for these faculty members we can give? It's a professional satisfaction. Financial satisfaction is not going to be there. You know, the bureaucrats are not going to give us the more salary. So only thing is we have to be happy with our own self. Give us that ecosystem of professional satisfaction. You know, you are being accommodated within the institution. You can walk in to the hospital, post-op patient, middle of the night without the hassles of the traffic and coming out from there, here and there. Coming back to meet the people, this thing. Conduct the professional conferences and then meet with the people in and out, you know, within the country and outside the country. Call the people from the great institutions and have an exchange with them, you know, what is that we are doing and what is that you are doing. Go there and then see what is happening. Bring those people here and then say this thing. And then get a small, sometimes the Harvard says, oh, AMC, you're also doing very well, you know. Thank you.
Thank you so much. A big round of applause for sir. You've covered so many dimensions, sir. I hope I am able to remember all of them. But I heard you starting with meaning, purpose, and connect. And having leaders like you reminding the healthcare workers how their work actually is contributing to something bigger than themselves when they're taking care of their patients. I also heard you talking about equity and how you are creating that environment at AIIMS Delhi where very important that we feel we are treated fairly and we are getting promoted fairly. You also talked about safety, where in the middle of the night, people can just walk on the AIIMS campus and it's really safe for them when they're coming to see their patients. You brought forth a lot about wellness and resilience, both with how you as an institution are really putting in structures, institutional structures, where there is a wellness clinic, but also you have this weekly activities with recreation, which helps the individuals move forward and have wellness and resilience. So many important components you have covered, so thank you very much. Sir, may I come to you after we go through all the panelists so that we can hear your reflections? So may I now request Dr. Arora. Sir, we heard about the need for what matters to you conversations, to really speak to the frontline staff and understand from them that what are the issues and what are their pebbles in their shoes. So as a system leader, can you tell us more on how this can be facilitated and what this can lead to?
थैंक यू डॉक्टर आबा सर ने खैर बहुत कुछ अच्छा बोल दिया, काफ़ी कुछ कवर कर दिया जो कि आपके क्वेश्चन को भी इसको कवर करता है ऐसे, इसलिए कि आदमी क्या चाहता है, हर स्टाफ क्या चाहता है, डॉक्टर क्या चाहता है, स्टूडेंट क्या चाहता है और स्टाफ क्या चाहता है और बाकी जितने लोग, इनफैक्ट मरीज क्या चाहता है वो भी इम्पोर्टेंट है वहाँ पे। अगर उनको नहीं सुना जाएगा, मान लीजिए कोई आता है स्टाफ कहेगा कि मुझे 2 दिन की छुट्टी चाहिए और ऐसा लगता है उसको दूसरे सामने जब रिस्पॉन्स आता लगता है मेरी किडनी, मैं तो किडनी मांग ली सामने वाले की, अनफॉर्चुनेटली। मतलब उसका भी घर परिवार है, ये तो सोचने की बात ही नहीं है। एम्पैथी की बात हम करते हैं कि पेशेंट से एम्पैथी बहुत ज़रूरी है, सिंपैथी ना करें, एम्पैथी करें। बस उस डॉक्टर से कौन एम्पैथी कर रहा है? अनफॉर्चुनेटली नोबडी इज इवन सीइंग दैट इट इज़ बिकॉज of the workload which we have, a lot of lack of resources. We can say that 72 घंटे काम करना भी ज़रूरी है या 48 घंटे, बट उसके बाद उसका मेंटल स्टेट कैसा रहता है, वो 24 घंटे बाद क्या सर्विस डिलीवरी कर रहा है उस पेशेंट के लिए जो उसके पास एक इस विश्वास से आया है कि वो ठीक हो के जाएगा। ही इज़ नॉट इन हिज माइंड टू डिलीवर दैट सर्विस। सो उसको लेकिन कोई सुन नहीं रहा है। सो जो आप क्वेश्चन पूछ रहे हैं कि वो फीडबैक वो कहाँ दे पाएगा, उसको कोई सिस्टम ही नहीं है। एम्स ने बनाया है, बहुत अच्छी बात है और मेरे ख्याल से इट शुड बी रेप्लिकेटेड, जैसे मैम काम कर रही हैं, इट शुड बी रेप्लिकेटेड एवरीवेयर in all countries. If a person says that he is psychologically affected, he is given all support. उसको छुट्टी मिलेगी, उसका कोर्स भी एक्सटेंड होगा, सब कुछ होगा। यहाँ सिस्टम ही नहीं है इस तरह का। सो व्हाट मैटर्स के बारे में तो कोई बात ही नहीं कर रहा है। उसकी तो बात, उसको बस ये है कि ये मरीज आया है और इसको आप इलाज करिए और अवेलेबल रहिए, कुछ हो गया तो जिम्मेदारी आपकी है। वो जिम्मेदारी से डरा पड़ा है बेचारा कि मेरा मतलब मेरी तो डिग्री चली जाएगी, मुझे तो फेल ही कर देंगे, मुझे तो पता नहीं क्या होगा मेरे साथ इसके बाद अगर इस मरीज को कुछ हो गया तो। अपने बारे में वो बिल्कुल नहीं सोच रहा है, तो फीडबैक की बात कहाँ से करेगा? सो जो आप कह रहे हैं, अगर वो लीडर कोई अगर अस्पताल में हो, जैसे अब सर हैं, सर ने ये सिस्टम बनाया कि लोग आके बता सकते हैं एटलीस्ट कि भाई मेरे को ये समस्या है, मैं इसका समाधान करूँगा। मैडम ने सिस्टम में बता सकता है कि भाई ये मेरे लिए प्रॉब्लम आ रही है, मेरे को कोई तो सुने। सो जब अगर वो फीडबैक मैकेनिज्म बन जाएगा और वो थोड़ा सा ऐसा होगा जिसमें कि उसका नाम ना आए, इट शुड बी एनोनिमस, it should be kind of done in a way that he can just fill a form and put it somewhere. एक बॉक्स बना दिया, पिक्चरों में आया था, सर ने बताया कि वो झप्पी मारी उसने बड़े अच्छे से, एंड इट वाज वेरी इफेक्टिव. पिक्चरों में और भी अच्छी अच्छी चीज़ें बताते हैं, दिनचर्या से हमारे पता लगती है कि एक ऐसा बॉक्स बनाया जाए जिसमें कि समस्या वो डाल पाए, उसका नाम ना हो. वो एम्स के डायरेक्टर के पास पहुँचे, नागपुर में एम्स के डायरेक्टर के पास पहुँचे, मैडम के पास पहुँचे कि मैं कोई डिप्रेस्ड है तो उसके बारे में एक लेक्चर शुरू किया जाए. तो अगर वो सुना जाएगा, अगर उस बंदे की बात सुनी जाएगी कि भाई हाँ, कि भाई हमारा भी ज़िंदगी है, और उसको जब हियर किया जाएगा कि भाई हाँ मेरे को छुट्टी चाहिए तो मिल जाएगी. वो लिखी तो है कि 40 दिन की छुट्टी मिलती किसी को नहीं है अनफॉर्चुनेटली. बेचारा वो 3 साल में, मतलब आई हैव बीन रेजिडेंट माई सेल्फ. सो सर्जरी में मैं रेजिडेंट था, 3 घंटे में सोता था खाली, 3 hours इन नाइट, एंड आई डिड अ 72 hour शिफ्ट, सो आई कैन रिलेट टू दैट. वो रियली रियली ट्रॉमेटिक है. खाना आया, खाना ड्रॉर में देखा, पता कोई और ही खा गया, मिल ही नहीं रहा है, एंड यू कांट गो डाउन टू हैव फूड. वेरी सैड, लाइक बट अभी बहुत चेंज हुआ है, एंड दैट व्हाट मैटर्स इज रियली कमिंग इन प्लेस. हम लोग 8 रेजिडेंट होते थे, अब 24 हैं. जहाँ 24 थे वहाँ 48 हैं. सो NMC हैज़ डन अ वेरी बिग जॉब इन डिलीवरिंग दैट थिंग टू द एटलीस्ट थिंकिंग अबाउट डॉक्टर्स ऑल्सो, दैट हाँ भाई लोग चाहिए. क्योंकि अभी भी हम करीब आधे उस चीज़ पे रीच कर पाए हैं जहाँ पे कि हमारी वर्क स्ट्रेंथ होनी चाहिए, डॉक्टर्स होने चाहिए, नर्सिंग स्टाफ होना चाहिए, बट एटलीस्ट हाफ पे तो पहुँचे हैं. पहले तो 1/10 थे हम. सो अगर ये फीडबैक मैकेनिज्म हम बना दें और हम इसको एनोनिमसली डील करें, एंड द लीडर कम्स अ स्टेप फॉरवर्ड टू एड्रेस दैट इन अ वेरी डेली बेसिस. जैसे सर ने कहा ना कि पूरे साल का इवेंट है, लेकिन एक बार अगर अलग करें तो बहुत ही अच्छी चीज़ है वो, रियली रियली, बिकॉज वो डेली चाहिए उसको रिजुविनेशन. वो बेचारा मरा पड़ा है, उसको तो कुछ तो चाहिए. ही इज़ टू बी एटलीस्ट, उसके TT खेलने की जगह तो हो, उसके बाद कहीं अच्छा बैडमिंटन कोर्ट नहीं बना पा रहे, कुछ कैरम तो लगा दें. सो बिकॉज मैं ग्रांड मेडिकल कॉलेज ज्वाइन किया था, तो वो कॉमन रूम मुझे इसलिए याद है जहाँ पे वो रैगिंग हुई थी, वहाँ पे जो दिखाई गई थी मुन्ना भाई MBBS में, बट मैं वहाँ पढ़ा नहीं. फाइनली आई वेंट टू इलाहाबाद, बट दैट इज़ अमेजिंग, दैट कॉलेज इज़ अमेजिंग. वहाँ पे कोई भी तरह की क्या नाम है, आफ्टर फर्स्ट ईयर द सीनियर इज अ मेंटर, ही टेक्स केयर ऑफ यू. दैट सैडिस्टिक एटीट्यूड हैज़ टू गो अवे इन कॉलेज, इन द सिस्टम, इन द सर्विस. अदरवाइज बिकॉज मैं निकल गया हूँ तो अगले वाले को उतना 24 घंटे ही काम, मैंने 72 घंटे किया है, तो ये भी 72 घंटे कैसे नहीं करेगा, हैज़ टू गो. ही हैज़ टू बी हर्ड. द टाइम इज चेंजिंग, पीपल आर रियली रियली साइकोलॉजिकली नॉट दैट स्ट्रॉन्ग नाउ. पहले हम लोग थे, हमें तो फ़र्क नहीं पड़ता, हम रात को 2 मैगी में 4 अंडा डाल के खा लेते थे, काम खत्म, उसके बाद पूरा दिन चल रहा है. बच्चे आजकल ऐसे नहीं हैं, जो आ रहे हैं वो कुछ सोच के आ रहे हैं कि मेडिकल सर्विस, मतलब हम डॉक्टरी कर रहे हैं 5.5 साल, फिर 5.5 साल के बाद 3 साल PG, उससे पहले तो रुकना बेकार है. 8.5 साल के बाद आप अगर जा रहे हैं, उसके बाद आपको ये देखना पड़ रहा है कि आप 3 घंटे में नहीं सो पा रहे हैं, तो सोचता है मैं इंजीनियरिंग ही कर लेता हूँ ना, डॉक्टर बनने की जरूरत क्या थी. 4 साल बाद ये नौकरी बढ़िया मिल रही है मुझे. मेरा बेटा तो बना इंजीनियर, तो आई कैन रिलेट. वो मेरे को देख के कहता कि छोड़ो यार बेकार है, ये कहाँ चक्कर है पड़ना है. सो आई एम जस्ट टेलिंग दिस शिफ्ट हैज़ टू, दिस चेंज हैज़ टू कम, बिकॉज वी नीड पीपल to be available to treat us, good doctors to be treating us. When I lie down on bed, I should not be thinking that हमने ऐसा माहौल बना दिया कि कोई डॉक्टर ही नहीं बनना चाहता. That's wrong. And अच्छे लोग डॉक्टर नहीं बनेंगे तो फिर कॉम्प्लिकेशन रेट बढ़ेंगे भाई पक्का से. तो वो शुरुआत इससे हो जाएगी कम से कम कि what matters and how he can have a feedback system available for him or her in the system, in the colleges, in the postgraduate institutes or otherwise. Thank you.
Big round of applause for Dr. Pankaj. Thank you so much. Speaking from the heart, I really like the way you emphatically said that it's high time that doctors are heard, healthcare providers are heard. And if they're not heard, very soon we will lose all good people who may have wanted to be a doctor, but they hear all these stories and they really don't want to join this profession. And you also shared very beautifully some of the impediments that we are very much aware of, and I've experienced that, lack of sleep, lack of adequate food. And they need to be heard. They need to be heard on a daily basis. We may not solve all the problems now, but at least we are talking about it. And if we start talking about it, I'm sure we'll find solutions as well. So with that, I want to move to the next panelist, and I want to ask Sir, that you have been a health system leader, you've been Secretary of Ayush, you've been Commissioner for Ayush, you also have a lot of family members, including your daughter who is a medical doctor. You've seen really the different actors in the ecosystem who are there. Can you share what your views are in terms of what are some both barriers to joy, but also what can be the roles of these actors in addressing some of these issues?
Yeah, thank you, Dr. Abha. And I would like to thank Dr. Santosh for making me a panel member today. And I'm very happy about it because I could not become a doctor, but I'm sharing the stage with a lot of doctors. Yeah, I know that. I know that. So easily, actually, my entire family has got a lot of doctors. Therefore, so I understand the life of a doctor very well, both male and female, in different what is called specializations. All specializations are there in our family. So I can understand what are the difficulties and advantages of each and every specialization and profession. So I would like to state that, basically doctors cannot be viewed as a separate entity or isolated category. जैसे माहौल समाज में है वही रिफ्लेक्शन हमारे हॉस्पिटल्स में भी दिखता है. And also the same, the people who are outside the system, doctors, and they are inside the medical system also. So we can't expect what's called totally different scenario inside the hospital. But what is more important is that, again, I would like to draw a comparison that, even in services, we feel that, I was not able to do the best of my ability because the system did not allow or permit me. The political executive or the senior or the juniors or the subordinates or the staff whom you administer, somebody or other is creating problems. So because of which we could not really perform up to our optimal level. So same situation is there for doctors also. So the ecosystem in which the doctors are working should be again considered as a separate ecosystem. I understand, because unless until a doctor is healthy, he cannot treat the people and then make them healthy. So that's more important. Is the doctor, so that's why I said medical doctor and the doctors of the society. There are two types. All these people like, Madam Kehri, the spiritual gurus. The spiritual gurus are doctors of the society. Like they try to spread the goodwill, good message, tolerance, empathy, sympathy, and all those things. Definitely, they are all parts and parcel of our, cultural system and ethos. Definitely in family system also we learn them. So if we understand the true meaning of our familial system and the learnings what we do from our grandparents, parents, mamas, nanas and all, and definitely it will help in the administrative system or the medical system or any other field in which we are working. So that, we have to understand that there are limitations for everybody and there are strengths and weaknesses for everybody. So in the same system, how somebody is able to excel and then deliver goods non-stop, continuously. He is also working in the same system. She is also working in the same system. So of which we complain a lot, how it's possible. So there is something to do with our personal perception and also situation. Definitely. Situation को हम बदल नहीं सकते ज़्यादा, because the family in which we are born, the parents and the husband or wife, the children and other things, each one is a different one. So that every family who has got 2 children is happy. No, it is not possible. It cannot have that. So the ecosystem has to be, congenial environment has to be created, and by and large it is the responsibility of the organization, whether it is a public or private, in which they are working. So शांति और अमन रखने की मतलब importance is, responsibility is with the organizers or the administrators who own this property or who own the health system or anything. So in India, most of the hospitals are owned by the government system, and then government hospitals are the most visited by the people, because we are a populous country and most of them are, still India has got below the poverty line, according to official statistics, maybe 33%. So, and again 33% of 140 crores. So how much it is there, and how many hospitals are there, and how many doctors are there, how many specialists are there. So naturally the system is bound to be under stress and pressure. So the stress and pressure is bound to increase even if you start double the number of hospitals existing today. Definitely by the time the population also would have grown, and then problems also would have gone, and then on top of it we are getting problems because of anthropogenic factors like, we are felling the forest, we are, removing the trees, green spaces are reducing, climate change, we are using, still coal and all these fuels, conventional fuels. So they are adding to the population and adding to the problems of the people. So my perspective is that, so there should be there is a need for systemic improvements from the government at the policy level and also at the administration level, and the professionals who work, they're medical professionals, and then paramedical staff and the support staff and other things in the system. So everybody has got a role and responsibility to play, and they have to be discharged. So as far as joy, what is depriving the medical professionals from joy is the entire ecosystem and the various permutations and combinations which are working, or situational analysis has to be done for everybody. It is different for me, different for you, and different for somebody else. But one thing I would like to say as a what is called Ayurveda and homeopathy are Indian medical systems, what is called commissioner or head of the department and secretary. So what is understood is that, all the people who are working in Ayurveda or Indian medical system, 90% of the people, they could not become allopathic medical doctors. So they became, alternatively, they choose to become a doctor in other systems. They don't have a personal liking or inclination towards that system. Jabardasti, matlab, just to become a doctor, they have learned. But 50 to 60% of the people over the period of time, they are, very much attuned to the system. They enjoy the work. They like the system because once they understand the, what is called strength of the system, they are able to understand. But when I was commissioner, what I faced is that, allopathic doctors shortage tha, bahut shortage. And the recruitment करने के लिए पैसे नहीं है government में. So they are putting lot of doctors on outsourcing basis, monthly remuneration and all. Not many doctors are coming forward. So whereas PHCs, what is called area hospitals and other hospitals are increasing, and then patient load is increasing. So the medical commissioner or DM and HOs at local level, they have given an order saying that all Ayush doctors also should prescribe English medicines. And our Ayush doctors took it very happily, and they enjoyed that because they could not become allopathic doctors, but they are prescribing English medicines for which they are not authorized. And I wrote it to the commissioner and government saying that if something happens wrong, joy has given. Yeah, they got the joy. So, but technically and as per rules and as per morality, they are not supposed to do English medicine prescription. So this is the dilemma in which there is a shortage, there is an enthusiasm, there is systemic defects, there are some strengths. So we need to capitalize on the strength and then eliminate the weaknesses and improve the quality of the workforce, and then mentally, physically and emotionally we have to support them. And we have another system like in All India Services, about 10-15 years back, institute like Isha Foundation, Art of Living, and Brahma Kumari's institutes, they became our training institutes. 1 week retreat, like we have 1 week training programs, in-service training. Every year we have to attend one training program. So 10-15 years back, they've introduced this. Many people wondered why, now they want us to become spiritual because we are nearing the retirement age or what. So what we thought that, no, it is not like that. Basically, they wanted to create an environment in which the stresses are reduced, tolerance limits are increased, and then, understand the, how the world and different systems are working, so that our capacities can be increased. So I'll stop at this stage.
Thank you so much, sir. Big round of applause.
No, I have not talked about my daughter. I will tell also later on. Thank you.
Yes, sir. Big round of applause for sir. Few things, you covered a lot of points, sir, but few things which I definitely heard, that you can't have a happy and healthy doctor. We really can't have a happy and healthy patient. You also said the responsibility of joy is an organizational responsibility. So we need to move from expecting the individual to find solutions to all the problems, but the organization to address it. You also brought forth it's a complicated system. There is an increasing population, we have a lot of health issues, and lead us to step in and to continuously look into how those issues can be addressed. And very importantly, you brought in wellness and resilience, which we heard from Dr. Srinivas as well, and how that can be incorporated in how we're taking care of our healthcare workers. So thank you so much. Dr. Santosh, before I come to you, may I put a question to Ms. Minara Chaudhary? She's connected with us online. Can we see her on the screen, please? Yeah. So Minara, you've been listening into the discussion, and what I wanted to ask you, you have a lot of experience with IHI's Joy in Work framework. Can you, based on what you've listened in, can you share your views on how it could be potentially applied, and particularly focusing on how do we create physical and psychological safety in work environments, and how do we create more teamwork and camaraderie in the working culture in our healthcare system?
Thank you so much, everyone. I hope you can hear me, and it's a great honor and pleasure to be part of this esteemed panel, and thank you, Dr. Santosh, for inviting me. In terms of Joy in Work, I think one of the things I've heard during this panel, but generally as well, one of the first things we need to do is to name the problem. What is the problem that we're actually trying to solve? So if the problem is around burnout, let's name it. Let's say that there's burnout in the workforce. If it's around equity, let's say that that's the issue. So the first thing is to name it. Let's say what it is we're trying to solve. The next thing is to acknowledge that there's a problem. Because until we do that, we're not really going to be able to address those solutions and get to the heart of what it is that we want to do. So the second point, acknowledgement. The third point then is to start to learn, to listen and to hear what others are saying. What are our medical professions, our nursing, our midwifery, our allied health professions saying about the healthcare workforce and the healthcare environment? What can we learn from them? And this is where asking questions about what matters to you is so important. Now, translating what matters to you into different contexts can also be challenging. It may or may not be relevant in every situation and scenario, but there are adaptations which we can make to understand from our workforce what's important to them. What is it that keeps them up at night? What do they worry about when they think about being a clinical profession, being a part of a clinical profession and providing the best care always? Why is it that they're in this role? So really asking what matters to you, but in a way that's customized and tailored to suit the local context. And I think that's really important. Now, once we've gathered that information, we also have a lot of data and a lot of information that's going to help us to truly understand what's the current situation of where we're at. So let's use data, let's use the opinions of professionals, and once we've gathered the information from our workforce as well, we've now got a real and true picture of what's happening within our system. And from that, we're also going to be able to understand what those challenges are. So let's work on the challenges. Now, when we think about any system, it may be a hospital, it may be a larger system, it may be across the whole country. There are things that we can do that are within our control, and there are things that are strictly outside of our control. So, for example, let's think about a ward, let's think about a unit. Now, if some of the issues are around communication and learning more about teamwork or working as a team, those challenges are well within the power and domain of the healthcare professional team to resolve. That can be done from today, from tomorrow. We don't need to wait or seek for permission to do that. However, there may be other changes around burnout, which is more related to the doctor-patient ratio or the nurse-to-patient ratio, having insufficient staffing to manage the workload. in which case clearly that requires a system level solution, which is well beyond our local remit. That's going to need external intervention, perhaps even. So we need to think about that differently. So we start to look at, and Abha earlier mentioned pebbles. So some of these things, by pebbles, small stones, some of these things we can shift. It's within our power, and we can make a real and significant improvement to our healthcare environment. But some things we can't do, and they're the big rocks, they're the big mountains that we have to shift. But we can do that. It will take a bit longer to achieve that. So the join work framework really talks about how we can make those small changes today, tomorrow, the next day, to make a difference in our workplace, but also acknowledge and recognize that there are things that we alone cannot shift, and we need external support to do that. And we can use improvement methods and approaches to make that happen. And I think globally that's what's happened, but in India, that's also completely possible and feasible to make those small changes that make a huge difference. I hope I've answered your question, Abha.
You really have. So big round of applause for Ms. Chaudhary. Thank you so much for beautifully starting off by saying that it really needs to start with what matters to you. What matters to you in terms of why you are in this role as a healthcare provider, but then also what are the impediments to joy, and gathering that data and then segregating it to identify which are the issues that are within your control, which are the pebbles that you can act upon quite soon, but also identify the boulders and not get overwhelmed. They will move, but we'll need a lot more energy and a lot more coalition, and we can still solve for those, but not get into a paralysis that nothing can be done because the problems are so big to be solved. So thank you so much. With that, I'll come to Dr. Santosh. Dr. Santosh, you've been in the National Medical Commission, and I would want to hear from you that how can medical education, right from the time when we have these students joining in, can be nurtured so that we are able to create healthcare professionals who are self-aware, resilient, and compassionate.
Thank you, Dr. Abha. I think we are all here to listen to the chair, so I'll not take more time. I'll try to be as precise as possible. And I'm seeing the watch as well. The clock is ticking. So quickly, a couple of things. What Dr. Srinivas has just sir has told, the doctor has to find happiness in what he's doing. He has come to a profession where he's probably doing seva or service, not business. And he has to feel that happiness in that. By doctor, I just don't mean doctor, and which is very, very important, which I also want to underline. Equity in the system is very, very difficult. Most of the time, doctors are gods, rest everyone is dispensable. So the healthcare workers, physiotherapists, optometrists, ASHA workers, ANMs, staff nurses, most of the time who are, everyone needs to be respected in the system. Most of the time, doctor is the one who gets the pat on the back. Staff nurses might have done stupendous amount of work, but probably they are relegated many, many times. We really need to understand this part of equity. I just want to underline doctors just doesn't mean doctors literally. It is the whole healthcare system. Having said that, one of the most important things what Dr. Srinivas said, again I want to stress on that, it is the ikigai. Finding the happiness in what we are doing and finding excitement, finding that. How can we bring this is through only teacher, only through teaching, only learning. So until and unless the teachers who are teaching the medical students or the healthcare students have this passion of ikigai, we cannot instill this in the medical education. We have started a small experiment in NMC called the yoga introduction. We have started very recently. Yoga doesn't literally mean asanas. It means ahara, vihara. For example, when we were medical college students in Vishakhapatnam, I know we had a beautiful beach. So we could go and look at the beach and all our stresses are gone. But then, most importantly, all our education, used to start from 11 or 12 in the midnight. Go to the library. Sit till 4 in the library and study. 4 o'clock, eat a nice dosa. And then go to bed. Dosa, you have to travel 15 kilometers. You are ready to go on a bike for 15 kilometers in the midnight, have a dosa and come back. Now look at our lifestyle. Having dosa in the midnight, sleeping at 4, getting up at 8 and running for the rounds. Hardly you sleep for 4 hours. And most of the times eating in the midnight, which is the most unusual time. And this was our lifestyle. No one told us what should be the lifestyle. No one taught us. We didn't have a wellness clinic like AIIMS because we were from some Andhra Medical College somewhere, kahin pe. Koi nahi padhata tha. So the problem is no one in the system, actually this needs to percolate down. And this yoga, ahara, vihara, what we need to eat, what we need to talk. Alcoholism is rampant. Smoking is rampant. I'm sorry to say, our seniors used to bring prostitutes to the hostel. Oh, this is rampant. I mean, let's talk truth. So how much of reforms have to be brought into the system? And I think it's a very, why RG Kar happened? And I think we need to look at this very, very closely. And that's why we brought yoga through in NMC. But not just NMC, Allied Medical Sciences, Paramedical Sciences, every board requires this. A huge amount of requirement. And now look at the world outside. So many attractions, so many distractions. And I think this is very, very important that we look at all these things. And most importantly, as doctors have pointed out, Dr. Arora, someone who might have faced a sadism in his medical student life is also repeating it for his students. There needs to be a lot of healing done. Lot of healing. Otherwise, he will live the same experience all his life. And we have seen our professors, some of them with anger management. Their clinical skill is excellent, but their anger management issues, we can't deal with that. So, a lot of reform in medical education needs to happen in our country, where we are producing 1 lakh doctors every year. Imagine what sort of doctors we'll produce if he has anger management, personality disorders, all sorts of things. So it's very, very important to look at all these things. So Jadoo Ki Jappi is mandatory. You have to make it a part of the system, curriculum. A huge change in the curriculum. Every day does the professor give a dose of dose in his class. What is dose? Dopamine, oxytocin, serotonin, endorphin. Is he able to give that? Is he able to make the class smile, happy, cheerful, all the students? And as Madam has talked about Gaurav, some personal touch to take care of the student's life, his lifestyle. Can we look at that? I think it's very, very key. So it's damn important. And I really feel, lastly, not taking, work is worship. I'm telling you, I thought Dr. Srinivas sir will run away from Hyderabad.
He's come to Delhi.
But he has been pulled. He has been pulled to Delhi, but we thought he would run away. The kind of stress that we deal in India. When he was trying to correct the ESI Medical College, some of the contractors tried to lock him inside the kitchen and kill him. Literally, the LPG was blasted, but there was a sajish to blast the LPG. Imagine how many doctors are facing or how many healthcare workers are facing difficulties on the ground. Or the kind of stress that you have to deal with in the system. So, resilience needs to be built, a lot of resilience. And I think this is very, very important that our education can only address this. This has to become a part of curriculum. Teachers, teaching staff, students have to be taught how to build their personality, lifestyle, how to address themselves, and how to build this resilience. And I know Dr. Srinivas has brought Heartfulness Institute in ESI in the curriculum. And I'm sure he's doing that in AIIMS also now. So very, very important to bring this curriculum, like IHI is doing, Joy of enjoy in healthcare. Very, very important. So I think we need to have this as a part of our curriculum. I think that is what I think we try to do a little bit in NMC, but there's a lot, miles to go before we sleep and miles to go before we sleep.
Big round of applause for Dr. Kraleti. Thank you. Lot of healing required in this system. And I think what you said, how we are interacting with each other, particularly how teachers are interacting with students, and we need to break the vicious cycle, which both you and Dr. Arora mentioned. Then only we'll start having a culture where all the hormones, the positive hormones, are released when a teacher comes into class. I do know ma'am wants to say a few words before I come to Dr. Pandare.
Just a few things. Dr. Santosh referred to yoga. Now, yoga is not just asanas, it is a way of life. So, understanding the very basic traditional wisdom, jo sir ne bola ahar vihar, in our modern medicine we can call it seasonality and locality of food. The economic issue also comes there, as well as the circadian or the body rhythms. And each one of our tissues has a physiological clock. Muscles have a different one, liver has a different one. This we call chronobiology, and also phenotypic manifestation of that, just to use a bit of science. So everything, sir, which was our ancient wisdom is now being validated by science, and it is the charge of each one of us in this country to do that, so that the Ayurveda and the other systems of medicine, Ayush, are not considered secondary or subservient, but in true complementarity. So the value systems, how they are nurtured at home, the ethics, how they are nurtured in medical school, because they spend many more hours of their young, impressionable, vulnerable lives with us in the medical school, whether they be MBBS students, whether they be postgraduates. So all the more important the charge on medical teachers. He said about anger management issues. So today the world is becoming more equitable or democratized in the sense that our youngers, many times we learn from them. So if we can make that kind of a dyadic relationship, that yes, you will teach me how to get a premium LinkedIn thing, and I will teach you life skills. So life skills navigating is always there in our traditional wisdom. The smart ones, like maybe some of us, can just put it, translate it into the modern language and say that yes, this works. Instead of waiting for 40 years more for the West to bring us on a platter the very same things which are intuitively, they are part of our imprinted race memories and our ethnicity. So we always have it in us. Now the issue with the policymakers and the governance and the stakeholders there would be how to make it easy and not make it something like a change, but something unmasking which is intuitively built in us. Thank you.
Big round of applause for ma'am. Thank you, ma'am, for saying it's unmasking, which is intuitively there in our culture and values. It's not something that we need to bring from outside. We've forgotten it, but we need to bring it back. And with that, I want to come to the chair of our session, Dr. Pandare. So based on what you have heard and in your role as a national leader, what national policies can really embed healthcare worker well-being within our ecosystem, and any other views that you would also want to add based on the discussion?
Yeah, thank you. And after this distinguished contribution from every panelist, I think everything has been summarized. So there are three sectors, and two have been touched upon by most of them. Is there are national policies, there are systems in place by government or the institutions, increasing the number of seats for medical doctors or other healthcare providers. So as far as this joint work and rekindling the spirit of medicine is concerned, government and policymakers can support this concept by taking some policy decisions, which I'm sure last 5-10 years we are observing that the government is much more concerned about. It's not that they're doing it for the joy of work, they're doing it for the service of the countrymen and increasing the number so that everybody gets the proper medical service. But that is helping in creating this kind of or taking care of these kind of worries. So as a policy maker, government or any policy maker will have to look at the structure to be in place so that it supports this kind of concept or these requirements of the healthcare providers. That is one sector which on the background of today's context. Second is what institutions can do, like Dr. Srinivasan is the head of institution, or most of us are leading some of the organization. So what do we do so that the joy of work is protected, is nurtured? So there are a lot of things. I would certainly share a couple of examples. Is like Dr. Santosh has rightly said, there is a very wonderful book which I appeal everybody to read. It's more about, it starts from bringing change in the hospital for iatrogenic deaths or near misses or mishaps in hospital infection. But the name of the book is very mysterious. The name of the book is Why Hospitals Cannot Fly. That's the name of the book. It's currently not available in India, but it's one of the best book. And the book is written by a consultant who was consulting to airline industry for preventing accidents. And then he was appealed to help hospital industry on the same background. And you'll be surprised to know that this hierarchy, this discriminating like optometrist or a nurse in charge or a physiotherapist, not listening to them, not giving any importance to their views. So he finds out that break the hierarchy in the medical system. In any hospital, if you want to take care of a patient, break the hierarchy. And that's what he suggested in Northwest or Northeast something airlines, where there are frequent accidents, and he suggests that the language what a co-pilot and pilot speak should be same. When he says language, it's not about English or Tamil or Marathi, it's about exact meaning of the words. Mayday, Mayday means what? What do you mean by Mayday? So both should understand Mayday is what. Or there is no word they utter for themselves that sir. They only speak to each other by first name. They will only speak. That's the kind of changes he brings in the airline industry, and the accidents are stopped. That's only possible because he breaks the hierarchy in the cockpit. And that's what he suggests, that break the hierarchy in the medical hospitals and etc. And then the hospital care will improve like anything. It will fly. That's the name of the book, Why Hospitals Do Not Fly. So that is something I think institutions can do, certainly. What we have done in our institution for that, there are 3 to 4 festivals, sir has mentioned about it. On that festivals, we have every single management leader or a senior doctor will invite at least 6 to 10 class 4, class 3, class 2 workers for breakfast at home. He will personally call them, his families, and then invite them. That breaks the barrier completely. Even a wait sweeper is invited by me at my home, even being a medical director. And the invitation is not like the HR person is giving them the invitation, aapko Dr. Pandare ke ghar pe sham ko 6 baje jana hai. No, I am supposed to invite him, call him, take his mobile, अरे भैया मेरे घर पे आज नाश्ता है, शाम को जरूर भाभी को लेके आना. I am speaking to a wait sweeper. That breaks the barrier. This is the culture
in my organization way, which is not sufficient, but we are doing it ourselves. Same is Diwali, Holi, etc., etc. Another thing which, what you demand in an institution, people give. If you demand that, if a management is demanding that we want discipline in the organization, people gradually will start fall in line. You will have to do some, take measures, but people. So do you demand honesty in your organization? Do you demand coexistence in your hospital? Do you demand no backbiting in your organization, no gossip in your organization? When I say demand, the leader of the management should create processes and practices such that these demands are generated. To simplify it, I will explain to you that in our outpatient department, at the entry of the outpatient department, there is a big board displayed that only speaks about honest examples of people who have expressed. Like किसी ने किसी पेशेंट का सोने का चेन पीलो के नीचे रह गया था, and that lady, the lady forgot it, और हमारा ward boy has returned it to the lady. So his photo and congratulations. If somebody has gone out of the way to serve the patient, help them, photo. So whatever you want your people to do, you should felicitate that, you should appreciate that publicly, internally, whatever. So whatever you demand, is people will definitely give. Another thing is, suppose there is an emergency after 72 hours of work, some resident or some gynecologist is rushing for cesarean section. What others duty is there? There is an incidence that there is a, for example, there is the case has gone wrong and the anesthesiologist is pareshan hai, ki I may lose the patient on table. So what a surgeon is supposed to do, what a administrator is supposed to do, what a ward boy is supposed to do, what a husband of anesthesiologist is supposed to do? Sit at home? No. He should bring a flask full of tea to give it to his wife. Ki tum kaam karo, I'm just here, I'm there, just around you. Have a cup of tea, I'm there. If you need anything, I'm there. My doctors do that. A gynecologist's husband is a radiologist who doesn't have emergencies, but he always comes with her to drop her. He sits at the waiting, brings a cup of tea. After operation, he says, "Ki ho gaya kya? Wonderful. Have a cup of tea. Chalo ghar pe." See, everybody has duty to perform in each situation, which may not be very valuable duty, which may not be very crucial duty, but giving a support or just by the side of, in Marathi we have a wonderful word, I don't know anybody in Marathi who knows, we have a wonderful word called salagi dene. I don't know anybody understands Marathi. Salagi dene means just to let him know that I'm there, don't worry. Just to let him know. मैं हूँ भैया, चिंता मत करो. So how do you express that? How do you present that yourself like that? Yes, I'm there, don't worry. An administrator, whether a medical director calls a gynecologist after she is going home at 2 o'clock in the morning for after cesarean section, even after full day's work, I think medical director calling at 2 o'clock कि हो गया क्या मैडम, all well ना, आप जाके सो जाओ अभी, बहुत काम हो गया, enough. She will not ask for a pay rise, she will not ask for unusual demands, nothing will come. She will be very happy कि मेरे medical director ने रात को 2 बजे मुझे फ़ोन किया और पूछताछ की. So this has to come in the organization. So organization need to be very sensitive about all these things. I don't know how many of our hospitals have a very, very strong, mature, wisdom-oriented HR department. Hardly anything. We have marketing department, we have recovery, we have billing. We have maintenance also. सारे equipment चलने चाहिए, AC भी चलना चाहिए. आदमी नहीं चला तो चलेगा. Equipment का uptime. What about uptime of a human being? How is he recoiling back? Not breakdown maintenance, absolutely. In our organization, we have a concept called, for doctors, we call them Doctor Karyakarta. So whether he has become a Karyakarta who doesn't need maintenance now. Maintenance means mental, psychological. So we try to, a fresher comes and we try to take him to the certain level that now he is maintenance free Karyakarta. Maintenance free Karyakarta. So now he is supposed to maintain others, take care of them whenever required. So this is what should be the journey and demand from institution. There are a lot of things an individual can do if the organization is not that vigil, not that resilient, not that vibrant. An individual again can bring that and take care of himself. See, one of my guru has said me, तू घर पे जाता है ना तो बेल बजाने के पहले दरवाजे पे खड़े रहने का 2 मिनट आंख बंद करके कुछ नहीं करने का, दरवाजे की बेल नहीं बजाने का, सब बाहर छोड़ने का दरवाजे के बाहर, देन बेल बजाने का.
Thank you. Big round of applause.
Simple act.
Yeah.
Just 2 minutes. How do I convert my requirements in such manner? So just stand by the side of your door, बेल मत बजाओ कि अभी घर जा रहा हूँ. I'm not bringing the entire stress inside my house. Baggage बाहर के बाहर जैसे जूते चप्पल निकालते हैं. So smaller, so these things we should teach to our people. We should demand from them. We should always look out for example, in my cabin, it's a small cabin, when people go back, there is a poster on the back side of cabin, if you are not inspired, please stay back.
Beautiful.
वो झगड़ा करने आओ, वो गाली देने आओ, वो पैसा मांगने आओ, salary rise मांगने आओ, whatever he comes for, he should get inspired and go back. So that they read it. Oh, sir, I am inspired, huh? Don't worry. So my job, if he enters, while leaving, he should be inspired. In whatever situation. Even if I punish people, they are inspired. कि नहीं sir, आगे से नहीं करेंगे. Thank you very much.
Yeah, apologies, sir. We could have listened to you. Apologize. I can't say anything that can conclude better than this. A big round of applause for Dr. Anand Bhandare. So we need a session on how hospitals can fly. We need one more session maybe as a follow-up to delve deeper into all that you have said. So big thank you. And since we are short of time, could we have a group photo, Rao? Yeah, with the poster. Thank you so much, sir. Thank you. Can we have Miss...
Santosh, are we going to get any kickbacks or
One minute.
royalty
We'll get the
apart that?
speaker on the screen as well. Sorry. Just 1 second, if we can wait, we'll get Ms. Chaudhary on the screen.
Guests to please kindly stay for one minute. I request Dr. Kaul, sir, please. Dr. Anil Kaul, who was our former Dean of Rishiyud University and now the Dean of PHFI, IIPH at Hyderabad. Sir, may I request you to kindly honor our guests, please, sir. First, the chair, Dr. Bhandare, sir. Big round of applause.
so sure. Thank you so much.
May I request Dr. Anil sir, Anil Kaul sir, kindly felicitate Dr. Srinivas sir, the AIMS director sir, who is here. Big round of applause. A small token of appreciation from Sushena and Rishi Hood and IHI, all three organizations. Again, I request Dr. Anil sir. Dr. Anil, kindly felicitate Dr. Arora. Thank you for your inputs. Big round of applause, big round of applause. Put your hands together. Yeah. De dijiye. Thank you. May I request Lakshmi? Lakshmi, please join. From the World Bank, Public Health Consultant. Felicitate Dr. Kocha ma'am. Big round of applause, big round of applause. Lakshmi is a consultant with public health, with World Bank, a public health consultant. She is working to set up good medical colleges in Northeast India, across Bharat. Thank you, Lakshmi. May I also request you to felicitate Dr. Nalini Mohan. Big round of applause. Yeah, please. Thank you, thank you. We are the organizers. Thank you. Thank you so much. Sir, I request Kishore, Natasha, Geetanjali, kindly join for a group pic and then we move out. Quickly. Come. Yeah. Sir, I request Anil Kaul sir, आगे आइए sir. बोलो यार, smile while कुछ cheers ऐसा कुछ बोलो. Yeah, something to bring joy. Thank you, Natasha and Geetanjali especially. Big round of applause for both of you.
So basically what we work on is systematic reviews and evidence and gap maps and also policy briefs. So when you'll have to take evidence to policy implementation, so there are a lot of steps that are involved. So we do research. So what happens then? One thing is that you publish that research. The other aspect is that you communicate that research. The other aspect is that you take that to policymakers. So we are working mainly on this knowledge brokering projects, that is knowledge translation projects, along with carrying out systematic reviews and evidence and gap maps. I'll just brief you all about systematic review. I'm sure you might have heard about it. However, it is collating evidence from primary studies on a particular topic in order to strengthen your evidence on that particular topic. So if a study comes, results come from one study, you cannot rely on that result. But if it comes from pooled evidence, from collated evidence from various studies on that particular topic, so the reliability is higher for policymakers to understand, okay, this works. For example, there's drug A and there's drug B. So what works for diabetes control? So if there's single RCT on that particular topic, it's very difficult to trust whether that drug works or not. However, if there are 10 RCTs on that particular topic, we pool that evidence and says that drug A works better than drug B, then the understanding is better. But how do you communicate this evidence to the policymakers is again a challenge, because they don't have time, and you will have to have these guidelines on how do you communicate this, and there are various steps that are involved on how do you engage them through your research process. So this is one aspect that we work on. The second aspect that we work on is to carry out an evidence and gap map. So suppose if you're a student, so you're confused. So what kind of research that I'll have to carry out? And if I want some information on mental health or on educating mental health, so where do I go and look for? Of course, we have Google, but then do we have some collated information, or is there a platform where I get access to all that information is the question. So we came up with this evidence and gap map, where this map helps us to identify all the studies on that particular theme or a sub-theme on a particular topic in a single map. So you just click on that bubble, so you get access to all this data. So how do we create this evidence and gap map? Is a session that we have tomorrow in the morning from 9 to 10:30. But for today, we are going to carry out a session on knowledge translation products, that is knowledge brokering. So we'll take you through different examples that we have worked on, and also you'll have some activities to carry out. So I'm Bhumika. So I'm the director of Camel South Asia. So we are the Global South organization for Camel Collaboration. So we are based in Delhi. So the main area of our work is to work on evidence-informed policy decision, that is to carry out systematic reviews, maps, policy briefs, and all of that. But then our focus area is mainly public health or social sector. We do not work on clinical issues. So there are other organizations like Cochrane and JBI, they work particularly on clinical issues. So now I would like to introduce my team. So Ashma Mohan, she will be leading this session. So she's the Director of Comms and Policy Advocacy at Camel South Asia. Now we have Suchi Malhotra, so she's the Director of Research. And we have Neha Gupta. So she is the lead evidence synthesis specialist at Campbell South Asia. So now they'll take you all through the examples that we have carried out. Ashima, over to you.
Thanks, Bhumika. Good evening, everyone. So since we are a handful, I just want everyone to introduce themselves and their research area, just one particular research area, so that it's easier for us to, punch you into groups for, the interactive exercise. So this is going to be an interactive session. I don't like talking a lot, and I also don't like lengthy PPTs. So yes, we are going to do a lot of brainstorming in terms of what is knowledge translation and how we are doing knowledge translation in our daily lives and how we can, maybe make it better. So can I start with you?
Hi everyone, my name is Mariam. I work at the Center for Strategic Communications for Public Health at Swasti. I work actually in a very similar field where our research teams give us data and very technical words, and we have to be like, simplify. So I'm here to learn from you guys and from you all. Yes, primarily health, but I have worked across a lot of cross-cutting areas.
Hi everyone, my name is Pragya Verma. I work for NHSRC under Ministry of Health, and I am new to the field, and I am here to learn about research and knowledge translation.
Hello everyone, my name is Disha Agarwala. I work with Maternity Foundation. So we basically have a digital tool which helps midwifery for capacity building. So yeah, that is one field that we are working on, as how digitalization can help in capacity building in terms of midwifery and maternal health. Thank you so much.
Hi, my name is Dr. Shikha Bhasin. I work for Center for Catalyzing Change across reproductive health rights and knowledge management, as well as on adolescent health and well-being. Thanks.
Hello, myself Dr. Himank Agrawal. I am running my own startup which is based on treatment therapy for varicose veins.
Hi, sorry, my voice is gone, but my name is Mary Moyana. I am a Programs Operations Officer for Research and Innovation at the World Health Organization here in New Delhi at the Southeast Asia office, and so excuse my voice.
Hello everyone, my name is Dr. Naudibia. I am a faculty in community medicine in Medical College in SGT University, and my research area has been infant and young child feeding. Hello everyone, I am Dr. Priya Kataria. I am assistant professor in Department of Community Medicine in SGT University. Mostly I work on non-communicable diseases with the focus mostly on type 2 diabetes.
Good evening everyone, I am myself Dr. Ajay Saini. I am assistant professor in community medicine, NCR IMS Medical College. So basically I am in teaching profession, so I am gaining knowledge with you people because I want to teach my UG student and the PG students. Thank you so much.
Hi, I'm Ben from Health Promotion Board in Singapore. I'm looking at digital health in relation to broad digital solutions applying to seniors in the Singapore population.
Hello, my name is Abhijit Jose. I'm a technical officer for aging at WHO Country Office for India. And my interest areas are aging, long-term care, and ethics. Thank you.
Hello everyone, my name is Dr. Linda. Currently I'm pursuing my public health degree in IHMR University. My implementation research is on substance abuse, focusing on adolescents and especially of IVDU.
Hello everyone, my name is Dr. Nadine. I'm from Yemen. I'm also prepare my master degree in public health IIHMR TDR scholarship. My implementation research will be in TB Yemen context.
Hi everyone, I am Dr. Kishore. So I have completed my MD Community Medicine. So I am a fresh graduate from the MD Community Medicine. And my focus areas multi-morbidity and occupation and environmental health.
Oh, yeah. My name is Fibion Mkwati. I'm actually from Zimbabwe, and I'm studying at Ashoka University. I'm doing my master's in public health. I'm interested in genomics and surveillance.
Hi, I am Shirish Rao. I am a medical doctor as well as a researcher at Association for Socially Applicable Research. My areas of focus are related to health systems, policy, surgical care, and human resources for health.
Hi, I'm Parth. I am currently doing my MD in community medicine from Maulana Azad Medical College, and I also work with ASER. I work on cancer equity and access to palliative care, access to cancer care, and opioid access in India.
Great. Everybody's from health here. All right, so let's start the presentation. So the process of knowledge translation, it can be broken down into 3 clear stages. First is curating and summarizing the evidence, which is the research findings. This is where evidence is prepared for use and it is made sure that it is simple and clear and okay, sir, thank you. I'm getting a bit distracted. Yeah. So it's made sure that it is simple and clear and accessible to people who it's jargonless, basically. For example, you are translating a very, very technical document, and to read, like if I want to read, if I'm a non-medical person, I want to read about cancer, for example, right? So you would think about simplifying a very technical and medical language into something that normal person can understand, right? So first is curating and summarizing evidence and research findings into accessible languages, formats. For us, the kind of research that we do, for us it's policy briefs, it's blogs, it's, like translating technical reports into policy briefs and other kind of products, infographics and blogs, etc. Then second is active user engagement. So translating isn't one way, it involves basically feedback and co-creation. So here I would also talk about stakeholder engagement, that you engage stakeholders early on the research and they sort of help you in making the research very, very contextualized, for the users, for end users, right? So that's what active engagement with intended users is, that you involve everybody from, yes, policymakers have to be there as stakeholders, but you involve practitioners, you involve people living with the people living with it. So, and communities, obviously, where the research is being done or where the sample is being taken, because it's very important for them to understand what the research is about, and very important to simplify and tell them that this is the research, this is the outcome, this is how it will affect you. So the end users or the direct primary beneficiaries need to be sort of, the main stakeholders. Then the third one is use of evidence in decision making. The end goal of knowledge translation is use, not just awareness. So, like I said, if you involve stakeholders early on, it sort of gives them ownership to the study or to the end product. So, which means that this evidence will be utilized because they've also been involved since the very inception of the research, and the evidence that has come out, it has come out with their inputs and or with their strategies or with their like sometimes they can help you course correct the research as well if the stakeholders are involved from day one. Oops. What did I do? So policy engagement and knowledge translation. So policy engagement isn't just about creating documents, it's about also creating relationships, and it's about interaction. So basically, products. Here we'll talk about products and processes. So products are basically ongoing activities, consultations, workshops, continuous dialogue. Here again, I'm going to talk about stakeholder, involvement. For example, I'll give you an example of a systematic review that we led. It was on wilderness and adventure therapy interventions. Do they help reduce offending in youth? And we formed an advisory group right at the inception, where the stakeholders were obviously the funders. Then there were practitioners who were implementing the programs. So for them to be in these kind of expert groups throughout the research is very, very important, so that, like I said, they can course correct you because they're working on ground on the programs. So processes are activities like these, and they end up in making products like policy briefs, guidelines. EBDMPs are evidence-based decision-making products. I'll talk about them a little bit more a bit later. So it's a synergy between these two that sort of helps in policy engagement and effective engagement and sustained interaction, which in turn leads to policy impact. Feel free to ask questions. There are no rules here, just you can ask questions anytime. So, yeah. Yes, Mary.
So, translation products can be for policy engagement.
Yes.
As well as community engagement.
Yes. Yes.
Do you have any examples?
Policy engagement is, policy engagement. We've done policy briefs for the policy makers. For community engagement, we've not as such, practically done. But I know that. Sorry. Yeah, for plain language summaries, which we've done in both languages, we've done in English as well as in Hindi. And also, that's the only thing that we've.
Just to add, in every systematic review that we carry out, so it's an important aspect that we develop plain language summary. It's going to be just 2 pages where we summarize the overall scientific evidence into plain language. And other aspect is that we also provide research implications and implication for practice and implications for research. So this information can be directly used for the practice, or also use the recommendations to carry out new research. The plain language summary, we translate that into local language. So based on the place where it's more relevant. Suppose you're doing it in Karnataka, so it's going to be Kannada, or Tamil, or Hindi. Again, it's our national language.
I didn't realize was knowledge translation is that sometimes we do translate research to participants into infographics. So we explain the research findings via infographics. Or I think in a project I did before, we made a song out of it so that we can better reach our audience as well. So I just wanted to add to that. Yeah, thanks.
So that's interesting because in the last evaluation conclave, what we did was we made sort of a model of the whole process that goes into our research and methodology and everything. So we made a sort of a model for that, and that was like one of the most creative knowledge translation bit that we've done. And that model had everything. It had methodology, it had, I wish I could show you a picture, but it had methodology, it had end result, it had inception, everything from beginning till the end. So that was one of the most creative knowledge translation things that we've done. But yes, if you see our reports, we try to do infographics. Obviously, data can be quantified, and it is easier to show that in infographics. But qualitative data, we are still, sort of figuring out how to, make infographics of that. I mean, we do dialogue boxes and everything, but that is another area that we are working on. Yeah.
I'm sorry if you're going to cover this later, but do you feel there's a line you try to maintain when you're translating data? So for example, when we're simplifying data, if it's like really complicated data, but it's also, there's this thing where when people see scientific data, it seems like, oh, that must be correct, right? There's that preconceived notion. So how do you toe that line when you're simplifying data to ensure that people still think of it as serious information that has come, but it's not too complicated for them to understand?
So when we work on policy briefs, we do show infographics of the results. And also, like, there is a section on how policymakers can utilize the evidence, So I think that's what one of the things is that, yes, most of the research that we do is demand-driven. There is already a policy in mind where, this evidence is going to feed into. But yes, it's basically sort of, even if like policy briefs are a shorter version, policy papers, which are a slightly longer versions of, policy briefs, they have, they are like about 10 to 12 pages, and they have a little bit more infographics on the results based on outcomes, based on interventions. So this is how it's highlighted in the reports, at least. So we obviously, like that overload of information is there, right? We give links to individual studies also, obviously references are there of all the studies. But yes, the whole point of a policy brief is to concise all the information and present them to the policymakers, because they don't have time to read long reports. All right. So, what forms does knowledge translation take? The first is direct interaction, where policymakers, like it's demand-driven, where you have a conversation or a inception meeting with the policymakers, and you sort of hash it out that, okay, this is the research that we are going to do, and these are the outcomes that we are looking at, and these are the knowledge products that we are going to, that are going to come out of it, be it a blog, be it an evidence portal, be it a policy report. Second are the bespoke evidence services, which would be commissioned reviews or synthesis tailored to a specific question, issue, or context. This may be like this could be long-term studies or case-by-case ad hoc studies as well, research studies as well. And the third is evidence-based decision-making products. So, like I said, EBDMPs are, again, they are infographics, they are policy briefs, podcasts could be, another knowledge product that is coming up. And yes, knowledge can also be translated through webinars, but I'm not pretty sure that, that's more of an exchange, knowledge exchange platform than a knowledge translation platform. But these are, the EBDMPs these are pre-developed tools, and they translate the evidence into formats that align with decision workflows, such as, again, dashboards, toolkits, portals, etc.
So, what are evidence-based decision-making products? So, they are structured tools explicitly designed to integrate high-quality synthesized evidence into, decision-making, basically. And here I would talk about an evidence portal that we built recently. An evidence portal is sort of a platform where there is curated evidence on a certain program or an intervention. So recently we did an evidence portal in collaboration with CGIAR. It is on the intersectionality of gender, climate change, and agriculture. So I'm going to talk in detail about that in a bit. So EBDMPs, they help decision makers, they do help decision makers see the gaps, where the gaps are in the research, because the gaps are highlighted. And also, like I said, how they can utilize the evidence is also highlighted. So like that's a step further, that this is where the evidence can feed into these legislative frameworks or this policy. And why they are important is that they provide transparency, accountability in decision making because of the stakeholder engagement, because stakeholders are also involved in these evidence-based products from the very beginning. And they help minimize the bias and ensure that decisions are evidence-driven. So I'll start with the first example of EBDMP. So this is the CGIAR evidence portal that I was talking about. Here what the main, like I said, it was the intersectionality between gender, agriculture, and climate change. And we had a couple of inception meetings with CGIAR where we thought how we can best, sort of build a platform for their CGIAR. I mean, this website will sit on the CGIAR gender platform as well, where all the evidence is curated, regarding the intersectionality. So we came up with 7 main questions, and then it was like a bottom-up approach. So we first came up with 7 main questions. Each question has about 4 to 8, maximum 8, minimum 4 sub-questions. So each question has been broken down further into 4 sub-questions or 8 sub-questions. And then we have done research on each sub-question. We found studies related to each sub-question. And we've also done, I'll just go to the next page. So this is how it comes. That is the second level where the sub-questions are. And this is the third level where we are putting long and short summaries of the reviews or the findings. And then we are basically synthesizing both. If there are 2 review summaries that we found for 1 sub-question, then we synthesize both. And we've also made a policy brief for each question. So once we all completed all these, then we sort of saw what kind of thematic areas came out of this kind of research. So the thematic areas were adaptation, resilience, governance, innovation, and livelihoods. Those are the thematic areas that came out of this exercise and this whole portal. So it will be launched soon. So, and we had a lot of back and forth. The main stakeholders, CGIAR, of course. So we had a lot of back and forth with the funder on how it should be. And so the process of iteration is I think the best, because you know exactly what they want, and then in the end it turns out to be a good product which they are happy with and which is relatable to them. which is the main thing, right?
So I would just like to, since there are a lot of people on health, I would just like to give an example on health. So this is the portal where if you want to look at this gender and climate, you can directly access. Similarly, imagine if we have such portals for various diseases, like it could be tuberculosis, or it could be anemia. So on health sector also we can have this evidence portal where it is accessible for the doctors who are into practice, and also for the community where they get direct access, where the information is reliable. The other aspect of these portals are all the information that we have provided us based on some scientific evidence. It's not just that, see, now there's this Instagram and Google, there's a lot of false information that's going on, and people just believe that randomly. But if we have such portals, how helpful it will be for day-to-day basis.
Just for my understanding, 2-3 questions. A, are you collating other studies, and this is just collated other works? Is there any primary data collection that was done under this project, and do you showcase any indicators on a dashboard within such an evidence portal?
Not really. Like, these are only based on, this is only based on systematic reviews. So, Suchi is going to talk about it. We've done another portal on CAP, on another project, CAP extension project, which we'll talk about in detail. So the main, I mean, this is the main, why the portal would work is that it sort of cuts through complexity, in the sense that if you want to find evidence on, like I said, intersectionality of gender with climate change, agriculture, it can be found on this portal. And it offers, like different levels to different users, from the policymakers to the researchers. Like we've also mapped some keywords that thinking about what people would be interested in. Policymakers, obviously, like policy brief is one downloadable item from the portal that everybody can access, and it is obviously more used to the policymakers. Researchers obviously can see we've also provided access to all the included studies in all the systematic reviews. So they can, in case they are looking for evidence on similar studies or similar data, they can go to those studies. And it's obviously going to be updated with new questions and with new evidence. We are planning to update it every 12 months or something like that.
What kind of a criteria do you have for the selection of studies? Like, do you have criteria in terms of the cutoff of the publication date, or any other cutoffs to the criteria for the study?
We usually do have inclusion criterias, and for this it was, like we did a sort of a initial round of search, and then it was a discussion with the policymakers, with the main funder stakeholders, and they had some priorities in mind. They wanted to look at studies with more data on adaptation, on resilience. So those are the sort of, then we broadened our search criteria. So that is the kind of back and forth that we did. So this is another example of stakeholder engagement.
So this is another like a case study for knowledge translation and stakeholder engagement. So we all know that Anemia Mukt Bharat guidelines are into revision now, and Anemia AMB 2.0 will soon be coming. But so ICMR and Niti Aayog, they wanted evidence-backed guidelines, and for that they conducted a stakeholder engagement exercise first, and they invited various institutions across the country and they brainstormed on the areas where evidence needs to be identified, where that which interventions work, which interventions don't work. And broadly, these interventions were categorized across 4 broad domains. So first was the supply side interventions, then your point of care diagnostics, your treatments and all that, and then demand side interventions. And the fourth one was the external, they could be triggers for anemia. We don't know. So for example, obesity, indoor or environment pollution, etc. So Campbell South Asia worked on demand side intervention, which included behavior change communication, social media interventions and WASH interventions, which also kind of is in continuity to the behavior change communication model. And so we applied all the principles of evidence generation. So this was an example that how stakeholder engagement can generate ideas and interventions for guideline revision using systematic review approaches and principles, how evidence is identified, which is lying around across various databases. And so we used Aware, Agree and Act, the trans-theoretical model principle as a framework, and we used various approaches to identify the relevant evidence in the behavior change communication, social mobilization, social media interventions. And we identified a couple of studies across low and middle income countries, which was very helpful in identifying various mechanisms for implementation of the program on the ground. And through our thematic synthesis, we were able to identify that there was evidence on availability and accessibility of the supplements, equipments should be there on the ground. We identified some programmatic and implementation challenges in regard to the behavior change communication, and also knowledge communication and engagement models, channels, who will deliver the communication in ground and how it is being delivered. And with more quant methods using effect size data extraction and generating forest plot, we were able to show that yes, behavior change communication has a positive impact across various outcomes in anemia reduction. And similarly, WASH interventions also. So this was an example of that how stakeholder engagement resulted in generation of ideas. These generation of ideas, when systematic review and evidence synthesis principles were applied, how evidence was generated, then this evidence was shared with the ICMRs, and soon these evidence what has been generated in this process will be included in the upcoming guidelines of AMB 2.0, which is an example of knowledge translation into policy, engaging policy. Thank you.
Okay, I am also sharing one of the example that we also worked for FCDO. That is also one of the knowledge product that we worked. Just to give you a brief background, what happened, there was like a very much increase in conflict and atrocity. And then there was like they were like FCDO was really want to start their international development strategies. And when they were working on their international development strategies, they have started their conflict and prevention hub. And they have an office on conflict prevention. So when they were building this conflict prevention, they really wanted to have a mapping of evidence which is available on prevention strategies for conflict and atrocity. Then they realized that there should be a need to have these kind of mapping of resources. So we started working with them on 2023. We started working on the map. that was like one of the mapping of all the evidence which is available on prevention strategies. So they can be prevention strategies in terms of safe environment, preventions are like peace education, peacekeeping operations, then sanctions. There were like a lot of socio-economic foundation kind of like, so if you have a job training in the conflict atrocity side, how that actually helps you to reduce the conflict and preventions. That's how they have demanded this kind of mapping of the evidence. And the main reason of mapping this is just to help the UK governments to see where they can actually pool their resources. So if I'm being a government and I have to make a strategies on, because there were a lot of like Yemen, Syria, Palestine, if you realize, and the recent conflict that we also have like Pahalgam, with the relationship that we have with from a long standing. So what kind of strategies a government can actually pool their resources on? They come up with this. And when they really want a very much robust evidence on such, and the main thing is also to help the UK government also to have the strategy, and also the one purpose is also to have this global resource. It's online available. It's also in CSA website. They have also published, they will just like put it in their UK government website. So this will be a resource pool for all the practitioners, researchers, policy makers if they were working on. When we did this map, they were also realized that yes, we map all the resources, but how a policy maker understand which strategies are very much effective for them to pool their resources on conflict and prevention. And then, so what we did is like we map these evidence. If you really see the below one, which is like this one. Yeah, so if you really look into this one, these are the matrix. So this how the maps looks like. Most of the time, the bubbles, all the safe environment, the interventions that a government can pull into, how those interventions is actually, those interventions can actually help you, okay, it's working. Okay, those interventions can actually help you to reduce the outcome. Okay, so reduce the outcome. So there were a lot of outcomes that we also planned. What outcome? First was also violence and atrocity prevention. We map all these evidence, the bubble in the map, because this is a screenshot, but actually if you look into the map, when you go to the online platforms, the bubbles will actually tell you the size of the evidence which is available on that specific topic. And the color of the bubbles tell you how much confident are we with those evidence that we found. What we did after that, when we done with the all mapping, they also come up with the plan, next thing that we did with when we prepare this portal for these conflict atrocity. They really want to see what all evidence which is very much effective. And what we did is like we also make not just mapping of the evidence, but also we talked about how much this is very much effective. This is the adverse effects that we found. Like if I pool so much money on peace education, will it actually helping it to reduce the conflict, or just like it will have an adverse effects? Then we bring up these in the portal. What we do is like we actually bring up two main evidence synthesis products. One was the map with the cell-wise summaries to it. So if you look into the screenshot here, which is talking about how the peacekeeping operation has a very small effect on civic participation or education, how these are very much effective. So we bring up the short summaries. So if I really wants to pull into my effects, like I really want to see how, if I'm pulling so much efforts on giving education, job training to youth who are affected by conflict atrocity, or also making sure the rehabilitation of ex-combatant, how they are so much effective to reduce the violence and conflicts. Because ex-combatant, if we are actually thinking of their skill training, making sure that economic is taken care of, economic opportunity is given, they will not go back to conflict setting again. They will not engage into conflict. So there were like evidence which is talking about pool your resources into such sector, pool your resources into making more peace education programs. And then there were a lot of peace education, what we find like a lot of coming together Palestine groups and also other like the conflict groups, and then you bring them into talking about the peace. how your perspectives it. And then we find that these kind of interventions are very much effective. And what we did is like we bring up these portal online, like it will be launched soon in UK government website. So they have this one thing which is like also mapping of the evidence, how much effective. Second, also we come up with the guidebook which is also talked about which all our interventions are very much effective, which is also saying moderate effects. Matlab, if you really wants to pool the money into such kind of intervention, you can also see that there is a moderate effects, there is a small effects. These interventions are effective, but then yes, it does not give that much. So that's how we bring up these kind of global resources to be used. What we did is like why we bring up this portal, like why this knowledge product was like planned on, because there was also we have this mapping thing, we have everything, maps is already available, but there should be a platform which is like a visual representation of all the resources coming together and bringing it, that you can find all the output on this area with looking at that portal, looking at that visual website. So we have made this website where you actually look into the website, you see what's the evidence base talking about, you go it, you will find where the intervention types and outcome is, what it is talking about. So you will have these summaries, which is like a 2-pager summaries, which talk about what's the evidence we found, it's from how many studies. The evidence is from 5 studies, from 10 studies. Studies by mean we say primary studies on that area. And then we actually collected it. There were more than 400 studies that we found on these areas, and when we actually mapped all the studies. Very much important thing that the main reason of coming up with the portal is like, obviously, you have an access. See, a researcher, policy maker working on this, like you will have an access to this outputs. You will also, like for all researchers, policy makers, practitioners will have access to this portal. And then when we were working on this exercise, we also worked with the Alliance for Peace Building. We also worked with US Memorial Societies. So they were like stakeholders who were involved into. So that all these were actually, and then we will also have the UK, like after this will become, there will be also a stakeholders meeting which will be arranged, where we have a representation from all the stakeholders who are working in this peace building areas, and then they can also see how they can best use these resources when they're pulling up their like implementation. If you really wants to have a program on this areas, which evidence is talking about. Yeah, thank you. Any question you can reach out.
Yeah, I have a bunch of questions. The most basic one, roughly if you can give an idea, how much funding does this take to do all this work, and how much time does it take? Just to begin with that question. I'll think I'll list out my questions. The second question is, off the top of my head, does the Indian government really use things like this because I can think of multiple policies which are not evidence-backed. The third thing is, once you do the view, when do you update it? Because you showed the example of Anemia Mukt Bharat. Now the guidelines are completely outdated based on the recent evidence of 2023-24. So when do you then update the evidence, and then do you push the government to update the policy, or it's just the government's responsibility alone to reach out to you and say, update the review? So what is your role in that then? So you're the initial questions.
So this relationship or these ideas that are not built overnight. So we've been working with FCDO since past 6-7 years, and then we've been doing a lot of work with the UK government. This is the work of Campbell Collaboration. Now Campbell Collaboration we have established in India via Campbell South Asia to do such work for our country and for LMICs in South Asia. So now we do not have such funding from Indian government for sure. So as of now, but then they're in the process of thinking on these terms. For example, the government took that initiative of calling all the institutions for the brainstorming session on anemia itself is a big change that the new government is thinking about, involving stakeholders and having that session to revise the guidelines. That itself is a big change. And such portals. So earlier when we started doing the systematic review, So there was no support. So why is the systematic review? Randomly the decisions were made. But then in health sector, at least they realized that they just can't implement any guideline without any evidence. We need some proof, or we need primary research for that, and we need systematic reviews. But same thing is still not the same for the social sector. But in the other countries, the Western countries, it is for all the social sector, it's all evidence based. So what we're trying to do is to bring such research methods in LMICs and South Asia as well. And now Wellcome Trust has funded this program called as Evidence Synthesis Infrastructure Collaborative. So where Cochrane, Campbell and JBI together, they formed this global network in order to promote evidence-informed policy decision. And through this, they're also promoting some funding for LMICs and South Asia as well to take up this work where most of the policies are implemented based on evidence. So they are happy to support India and South Asia as well. This is with the funding thing. Yeah.
Say, for example, why is access to palliative care poor in India? And then, those questions and sub-questions. Average budget, how much, does it take? Just trying to get an idea.
So the average budget to conduct a systematic review is between 60 to 70 lakhs.
Okay, but suppose there is already data.
Mm.
And what your organization does is to translate into this kind of a thing.
Yeah.
There are systematic reviews, or even there is amount of evidence that is there, and we just have to translate into something that policymakers and community can understand. Then how much does that take?
So it depends upon funding agency and also the needs. So there's no fixed amount as such. It's not just that. Yeah. Yeah. Yeah.
Both of us are a part of the Lancet Citizens Commission.
Okay.
And we did a review on telehealth barriers for human resources in India. And we did that for free, and it took us months.
Yeah, systematic review looks like a literature review that can be carried out but it's a lot of process, and at least now I don't think so people say that they do random review and call that as a systematic review. Now it's no more, but it was like that earlier. But these products are also innovative, and it also depends upon what the funder and the researchers want, and it comes with a lot of discussion. Interested, yeah. Yeah, these are the new initiatives and these are the innovative methods that we have developed and then convinced the funders that there's a need for this, and that's how we've been working.
Hello everyone, my name is Ashwini Dudeja. I'm from One Infiniting. So I'm working for rural and tribal women development in the sense of, so I'll take few seconds quickly. So even in India, more than 10 million families, they are still cooking food in mitti ka chulha because they don't have money to refill LPG. Similarly, I'm working for Asia overall, Africa and Latin America. So I already have developed the product. My market is, my products are already going in NGOs. But the demand is high, supply is less. Why? Because of less funding, because of less actions. And why we are here? We are sitting here for actions. So other thing is that I'm going to make something world's smallest and slimmest something induction. Why I'm using this word something? Because I'll patent that product. So, and that's for again Asia, Africa and Latin America. So, and it will be lightweighted and solar based something, you know. So what my question is that can I get grant funds, because the market is high, demand is high, supply is less, and the technology of the demand is also high, which I'm going to make it. It will have a different energy storage altogether for the public. So
we are not the right people to answer that question because we are not a funding agency, but we are trying to, try to make we're using research to make it accessible for policymakers, for the government. And
I know, because it works from here only, head, policy making, research, and then it goes to implementation. Yeah, it then goes. Yeah, that is how it gets funded. People work on policy, people work on research and policy first, and then goes to implementation. You know it very well what I'm talking about.
so we are not, we want to get into that discussion for sure because
Yeah.
it depends upon how you convince the funders, how you take your ideas to funders. So there's a lot of effort goes into it, and it's also very political as well. Like what funders are concentrating or what are they interested
Yeah, that's what I was looking for guidance from you. You know that if you have any connect or something like that, or where I can work in that. But anyways, it's okay. No problem. No problem. I understand that people must be laughing on my thing, but I'm taking practically action on this for the environment, for the people. Thanks.
So what I was really want to suggest is like basically what you can do is like how we also there like stakeholders engagements advice. So obviously you coming up this platform is like you are looking for stakeholders who are also working on the same areas, and then you can actually come up together because you also have like you really want to look for something good for people, and then you have that with AIM. You can actually look for stakeholders who are working on it, and then bringing up people together working on that area can actually have like you really wants to work with for women's, for rural women's, then you have a target.
There are some people who are working in the same domain, but there are more than 2,500 people there, and it's very much hard to recognize it.
True,
That is why I asked the question in the public domain. Are you getting my point?
No. That's what I think. That's very good that you have asked that. Like maybe if like people have been interested in this area, they can actually reach out.
And
Like,
yeah, and you should always think that at least if somebody is working, or few people are working on actions, rather than talking on status, or asking questions about services and all. It's not only about taking funds. It's about action that what I am doing on the ground. Thank you.
Thank you very much.
Thank you. Continuing on like how knowledge can translate into this. So like I understood like in terms of like lot of systematic reviews is like one of the ways of evidence synthesis. But you also said like in terms of like economic analysis, like whether this benefits or not. So what are like the other ways that actually like apart from systematic reviews, like because not all evidence can be generated to systematic reviews, so there are a lot more methodologies that actually generate evidence and that has to be translated into policies. So what are other methods that actually like governments or like the policymakers look upon, and when we create these policy briefs, as like someone had already asked before, like we create like a lot of complex data, there is a lot of modeling data, there are a lot of like risk of bias analysis and everything that we as researchers, academicians understand, okay, this has to be looked in this lens or that lens. But when you explain that to a policymaker, that is different. When you explain that to a community, that is different. So what are like the technical aspects of writing such papers, writing such briefs? Because what we create are peer-reviewed publications out of interventions and everything we do. Like even a systematic review is a peer-reviewed publication. But when you translate that into a policy brief, what are the technical aspects that actually have to be there in that, and like what takes that understanding to the policymaker is what I wanted to know.
So we try to be as less jargony as we can. We use simpler words that can be used, but if it's a very, very, very complex finding, then that can be used as an infographic. That can be, like displayed as an infographic. But definitely, if you want the policymakers to read the papers, then the policymakers have to have that sort of understanding, right? That what this word means, or what this sort of language means, or what this finding means. And if you are translating it to the community, or for example, if I walk into a hospital, right, there are these information flyers on cancer, on some disease. They are definitely not very technical, right? They are definitely not, they are very, very simplified. So that is all, that understanding is already there, that they have to be simplified for different kind of target audiences. So policymakers, definitely, it's not like they don't understand technical language. They are obviously, I mean, there are a lot of doctors and PhDs in as stakeholders in the government. So definitely, I would say that yes, we already have that sort of understanding, that guidelines also, when we are developing guidelines, they have to have as simple language as possible so that people can understand, right? They can interpret it, and that level of technicality that is fine-tuned to the audience that we are sort of looking at. So yes.
I just want to add one more thing. So basically, when we look into the evidence, when we say, we also worked on one kind of thing, which is like a toolkit. Youth Endowment Fund, like they really wants to look into they really wants to develop a toolkit where it's also a visual thing. So it's also answer all the policy questions, like is the intervention effective? If it's yes, how cost effective is it? And plus how much quality, also rated quality, but then how much confident are we with the evidence findings? So if our intervention, we did it for education. So if a parent-teacher meeting, how much effective, like to pull your resources into such kind of initiative? How much one-to-one? How much online? So they have a lot of intervention that they said to it, and they really want to look into its effects on it. Same way, we also made a toolkit for youth at risk. So if a sports intervention with a child who is, or like with a child and youth who are at risk, they have offended or they are at risk because they are, because of poverty, because of the environment that they are more into antisocial behaviors, they are more into drugs. So how these kind of interventions are effective? We answer that. How much cost effective is it, and how much confident we are? So we rated like sports, wilderness, the first example that we gave, how much mentoring reviews, having a mentor in the life of a youth, how much that are very effective. So that kind of thing. Even though, just to give you, because you asked how these policymakers, I was working with immunization technical support unit, so in TAGI. So what the role of INTAGI was when I was there, we actually collect evidence on vaccines' effectiveness and efficacy. So how much these vaccines are effective and efficacy, and we also see the cost effectiveness, because a policy maker in universal immunization program, if we want to introduce, so that time rotavirus, pneumococcal, and then HPV, I was not part of it, but HPV was just like we were discussing. How much just kind of these kinds of vaccines to be introduced. Like for policy maker, they also need to see how much cost effective. See, because the money, because of the cohort. So these are discussions. So policymaker needs to know effectiveness, cost effectiveness, and obviously the quality, like how much confident are we when it coming to it. So for policymakers, we have toolkits, we have guidelines, we have portals, all these kinds of development. For researchers, evidence gap mapping. See, from researchers, if they really want to do a research, a student who wants to do a research on it, you can look into if there is an evidence gap map or a systematic review already, like you look into what, and then also for public, for community people, for public, we have plain language summaries. We make sure our evidence, all the evidence that we are generating should have 1 or 2 pages plain language summaries, just to a very simple language which they understand.
Yeah, my other suggestion to you all are in community medicine and you would like to write proposals and get grants, is that earlier the version was to just write your research, your objective and your outcomes. But my suggestion is to also have a dissemination plan. So it's not just about publication for sure, that's outdated. So we don't believe in that. Yes, it is published, that's important. But then what as a researcher we would like to do is, what is the impact of my work? So when you think about it, then you can always plan out your dissemination plan and also budget for your dissemination plan. So after this, what am I going to do? So I'll have this community activities. So I'll have some peer education. It's not always about the policymakers. Everything will not get into the guidelines. So that is one aspect. So when it comes from the demand side. But as a researcher, when you're doing your thesis or anything, just don't end up with this, but then write about this dissemination plan and try to, one of the products at least, like a knowledge translation product you can think of after your research that you would like to propose along with your budget, and that will actually make a difference in also getting that grant, because they'll also evaluate based on your idea on innovation on how you bring about this impact in the community. So this whole, that is the plan of this knowledge brokering products, because we want to promote that it's not about doing research and publishing, but on various methods on how you translate these products.
Also, I think the landscape is changing a bit in terms of knowledge products. Nowadays, we have Instagram, right? Instagram is a very, I would say, influential and powerful tool for any sort of influence that you want to have. There are podcasts where people are not just talking about movies, they are talking about health issues, they are talking about social issues, right? So these are like simplified versions where people can relate to more. Yeah, you have a question.
Thank you. So this has been more like a sensitization for me on knowledge translation. So I have few questions. Like I want to understand what drives the identification of problem areas when we are doing a knowledge translation. Like the foundation identifies it, or it is like on what problem area the knowledge translation has to be done. That identifying that and proceeding with that, and also deciding on which knowledge product we are trying to make, whether it is a policy brief or evidence-based decision-making portal. So that is one question. And another thing is, since we're talking about making this evidence-based decision-making portal, which is not like a document, but it is a website. So I want to understand, because there is some creativity also that needs to go into this. So what are the team of skills and expertise that is needed to make this product? Thank you.
I'll start from the third question because I've been designing these. I've designed these evidence portals. So the first one, the CGI one, I'll go back to that. Yeah. So this one was built from scratch, and what I thought I had in mind was absolutely like that. Like there were a lot of iterations in terms of design. I have a person, IT developer, web developer. I did a bit of brainstorming with him that this is the concept, and this is what. So you need a good IT developer, IT person who's good with building a website, or at least the back end, who's able to sort of brainstorm with you on the ideas, on the design, on the colors, on everything, right? So he's also able to give you some sort of feedback. So at first, I was not sure like how we are going to display these questions. Are we going to, because initially in the proposal we highlighted them as a pyramid, right? So I thought we'll make a pyramid, and then when we made a pyramid, it just looked really horrible. So then we were like, okay, fine, let's try some other designs. We'll split them into these chiclets, and we'll make these different, and then we'll go to another level, and then we'll make these. So this was a big learning experience for me as well. It was very different from building a normal website. Like when I did the website for our organization, it was pretty simple. Okay, this is about us page, this is the content for that, these are the pictures for that, this is teams page, this is our projects page. It was very simple. But here you had to sort of scratch your brain, and you had to think, how do we best, how is it going to be user friendly? Right? That is the main thing that you think about when you're building a website. That user should not have to search for, like, just dig, right? Everything should be there. And they should sort of feel comfortable when they are browsing through the website, or when they're looking for evidence, right? So those are the two driving things that you should have in mind. One is, it should be user friendly, and always do user testing of the pilot website with a different set of users. So yeah, and the colors as well. So like you have to think about, so this green is a CGIAR green, like they have this green on their website. So we just thought about, okay, fine, this is the sort of green that we'll have. The photographs also had to be like, I went on to iStock and I searched for photographs of women in agriculture in LMICs, right? That's how I got these photographs. So you have to be a little bit more strategic when you are designing these portals. And the introductory paragraph, it was something else before, and then I was like, no, people need to at the very first stage, they need to sort of understand what the portal is and how to go about it, how to read it. How will they understand? Because now I know I'm making a presentation. If a person is doing an organic search, going on the portal, they need to sort of understand how to navigate it. Yeah. So I've explained it like that on the homepage on how to navigate the portal. So these are the things that you need to sort of think when you're building a portal, and what sort of, how do you want to strategically arrange the evidence or the research that you have, right? What was your next question?
How do you identify the problem area, and like do government agencies approach the organization, or the organization comes up with a topic and look for funding?
So with CGIAR, yeah, it's both ways. CGIAR, we were doing a set of systematic reviews with them already in the area of agriculture, innovation, and women. And then they wanted curated evidence on their, they have a gender platform. So they wanted sort of, because they have on the platform, they have publications, they have blogs, they have reports. They don't have this kind of curated evidence on their website. So this is the sort of, when we did brainstorming, it was decided that we need curated evidence on the intersectionalities of gender and climate change, and this is what we will build. So that also took like, that idea didn't come immediately. That also took like a couple of meetings to sort of have clarity on exactly what we are going to do with it. And then it was put into motion. And the third question was another question. Choosing the product, yeah. So different sort of audiences that we mainly work on policy briefs. There are different knowledge products that we work on. We work on policy briefs. We work on, like, newsletter is a knowledge product as well. We disseminate it to like we have a list where we disseminate it. Then we have webinars that is a different sort of it attracts a different sort of an audience, where we have on different thematic areas, different topics, and we bring in experts, and they talk about their own research on those topics. And then there are plain language summaries, like we said, that are available in different languages. So those are for the academicians. Then there are published reports that are accessed by the researchers. That is also knowledge products. So different, like, sort of, and if we have to go and speak to a policymaker or somebody in the government, we would show them the portal. With that will be no exercises for exercise.
Hello, thank you for the wonderful presentation. So, as far as implementation science is, implementation research is concerned, since I specialize in that, ma'am mentioned about dissemination plan, right? So, in order to make a dissemination plan, we have to roughly map out our knowledge translation. So my question is, before actually starting the research, how do we know whether it will be IKT or EOG? Because we have to make out the timeline accordingly. So how do we know whether it will be an integrated knowledge translation or end of grant? EOG, end of grant. So
what we it's working. No? So what we basically do is, so when we write the proposal, so we have this advisory group. So we'll have experts in that field. And then we brainstorm this dissemination plan with the advisory group members as well. So in the advisory group, we'll make sure that we have different expertise. One is the one who takes the data, so one who is into policy and one who is at the community level. So if it's primary research, we also take into account the gatekeepers on how to translate this to the community. And we have all of these people under advisory group. And then once we, that's with the help of them, we will plan this dissemination plan. So, and also we plan to include that in the grant to an extent. And then when this dissemination activity takes place, that is when these ideas generate. So why can't we take this further? So okay, this is the recommendation, here is the gap, so why can't we do this? So it comes from the dissemination plan. So always the grants are connected. So at least this is what has worked for us. So what has worked for us is, first we do an evidence and gap map. Then we tell them, okay, there is a gap here and there's available evidence. Here we have an available evidence. So do we have to do policy briefs, or do we have to do evidence-based decision-making products, or should we conduct a new research or a primary research? So that will help us to take into a next level. So that's how, you know, you build research in the area. So for example, we have a project on Center for Homelessness. And we have, I think it is the 6th update of that map. So they want us to update that evidence and gap map on a regular basis. So we did that update. And that's how it continues, and that's how you build your relationship with the funder, because once you provide them good research and ideas, and they continue to work with you. Did I answer your question?
yes, ma'am. So basically, if I want to know whether I will be doing IKT or EOG, we need to have a proper team, and we have to analyze first, right?
Yeah.
Okay, thank you.
Yeah.
Is there any way you do impact analysis after this? So what change your work has led to? Do you have any framework for that?
We have examples, but not a framework, right?
Yeah, now we are planning to, actually I'm writing a proposal right now on the same, that how policymakers are using this evidence-based decision-making products, and what is convenient for them, and what are the challenges that they're facing and all that.
We,
sorry?
yeah. So that definitely is there, like for the newsletter, like how many people viewed it, how many downloaded, how many policy briefs, what is the footfall on the website, like those kind of stuff. How many people viewed our reels on Instagram, what is the sort of engagement that we are getting on our posts on LinkedIn, on Twitter. These metrics definitely we track. But also an example of uptake that I can tell you is that when I did my research on wilderness and adventure therapy and how it's affecting or not affecting youth, there was a practitioner on our advisory group, and when the final report came in, we sent it to all the advisory group members, and I got an email from the practitioner saying that the findings are very helpful to her, and she is going to use it in the next program, like she's going to build it into the next program. So I mean, that is, I think, because not even policymakers, I think practitioners are the people who are the main implementing people, right? So if they are using the evidence, then I would say that that is a good example of evidence uptake. I think it's 6:30 and we'll have to end. So we can have further discussion during break or dinner. And if you want to learn more about, so the n number of projects. So we've completed 40 projects in last 4 years. We are so with a lot of prominent organizations at global and national level. Yeah, the team, we are a good team. So Ashima takes care of comms and comms related activities. So having an interdisciplinary team is very important. And Suchi takes up the project management and she's the director of research, and Neha takes care of the quality of the work that goes into. So we have a lot of young researchers also working with us, and we have our advisor who is based in the UK, so we take guidance from him as well. So that's how we work, and thank you everyone for being part of this discussion. And can we have some key takeaway messages? I just want each of you to at least tell me one single thing that you want to take away from this session.
So for evidence-based practice, like the way evidence is generated and advocated in multiple ways to different kinds of stakeholders is important, and finding ways to actually educate the global health people and like people who are working in this to translate what they do is pretty important, and the ways to do that, like the products that you mentioned is something that people should look into, because like the advocacy is much more important than the publication as an output.
I think along similar lines, we have been working on a lot of research projects, but we are not translating it into a user interface like this, which becomes accessible. You know, we stop at that publication. We are like, whoa, we have a publication. Yeah, and yeah. So we stop at a conference presentation publication, but I think this is something we should take back from here. So thank you.
Good evening. So here, as a researcher, I think we have to think like what the funders want to let us think. We have to change, modify, because I already have the experience. Suppose your results are not matching whatever they want, so you have to modify it according to them. I already have experience.
So please don't take away that message from us. We cannot modify the results. So with that we can,
Yeah, we can never ever modify the results from the evidence that we are getting. Yeah. And yeah, so the further. Yeah, please don't take away that means we cannot modify the research, but then you can discuss on further research on that particular topic.
Yeah, thank you. It was a wonderful session. The takeaway message for me is that there is plenty of evidence available all over the internet. So ultimately, it's the quality of that evidence that matters the most. So yeah, that's.
Yeah, I think even I have the same takeaway, and I think like evidence is now growing more and more, and infinite researchers are coming. So I think this is going to be very important, so that the amount of data does not become a barrier to action. So simplifying that and streamlining that, I think that that is my takeaway from the implications of knowledge translation. Thank you so much.
Thank you, ma'am, for the insightful sessions. Since I have been wondering, like, how these evidence synthesis platforms actually, interact with the stakeholders in what forms. So from this session, like, I'm a bit sure that like how you translate that knowledge to the stakeholders, and in what forms actually. So this is my big takeaway.
Thank you.
Hi, my name is Mangesh Podar. I came here accidentally, but that topic, kept me hooked over here because I feel that impact-based, research should always be there because I am finding out in many places or many government schemes that those are being designed, sitting in the AC offices. So that is why the impact is very less. But as I said, I could find, systematic and in-depth assessment of what is required to be done is done in this research. So that is my, takeaway from this. We should do this type of, research before planning or implementing any scheme.
Thank you.
Hello, ma'am. Thank you for the wonderful session. So my takeaway will be how this knowledge translation are done the right way, not just translation. So because we have different stakeholder, different beneficiary, I would say, because our knowledge translation will be used, maybe the policymaker, maybe the community. So the right way to do it, because the way the policymaker will use the knowledge will be different from the way the community people will be used. So from this session, I learned that we have to like identify them and then translate in such a way that they are able to grab it. Thank you.
Thank you very much. So, yes, small crowd, but then I enjoyed this discussion. We thought almost no one would attend our session because it's like 5 to 6:30 and then we're expecting 0 participants. Group photo, please, Jenna. Okay. So, do connect with us on LinkedIn. So.